हेलो। चेक। हेलो। चेक। हेलो। हाँ जी सर। Hello, check. Hello.
Can I stand there and I'll give people can see?
Hello. Hello, check. Hello, hello, check. One, two, three, four. Hello.
नहीं अभी तरुण है ऑनलाइन है बट अच्छा लेना हेलो हाँ जी तरुण नहीं अभी ऑनलाइन नहीं है नहीं वो गाड़ी दिया मैंने
हेलो हेलो सर सर हेलो हेलो हेलो
एक यही है हमारा शोकेस ये करने ये जो सर्कल है ना ये गोल होना चाहिए ये देखो उधर कैसे गोल है ऐसा
आज मेरे को काफी ट्रैफिक लग रहा है सनी। हम्म, हाँ, मैंने सोचा 9:15 9:20 तक पहुंच जाएंगे। तो 9:30 हो ही जाएगा। 1 घंटा लग ही जाता है। पहले लगता नहीं था सुबह। हाँ, अभी वो रास्ता खुला नहीं है ना। हाँ,
Roshna ma'am, good morning.
गुड मॉर्निंग।
Yes, ma'am, I would suggest that because we are live, you can keep yourself mute, ma'am. Uh, because we are
यस,
already live on the website,
श्योर,
ma'am.
बट आई
Yeah.
थिंक आई एम म्यूट ओनली, यू नो।
No,
Okay.
I can. We can talk to each other, ma'am.
Okay, okay. Sure, I'll do that. Yeah.
Ma'am, I would suggest that because we are live, you can keep yourself mute, ma'am.
Mr. Tarun? No.
Ravi,
Hi, good morning, everyone. May I please humbly request everyone to switch on your cameras? Thank you. We would be going live in just another 5 minutes. Hi, good morning, Tinu ma'am.
Good morning, everyone. Good morning, Tarun.
Yes, ma'am. Good morning. We are good to go for live, ma'am.
Just a second. ये मुझे उल्टा क्यों दिख रहा है?
उनको सीधा दिखेगा ना?
उनको सीधा दिखेगा, मुझे उल्टा ही दिखेगा. Okay. ठीक है. Tarun, another 5 minutes because we are waiting for our chief guest to come. She's
Sure.
just on her way.
Sure,
Another
sure.
2-3 minutes she'll be there with us in the hall, and
Right.
then we're going to start.
Right, ma'am. Right. Thank you so much.
Thank you.
I can see name in the attendee with S call. Can you please type in your full name, please? There's an option to rename yourself as well.
Yeah, just the cameras. I want to look taller and I'm looking shorter. Then I look fatter.
बस तो फिर अब यहाँ तो मैंने बोलना तो यहाँ से है ना
राज माइक ऑफ करना वहां का.
किरण ताड़ी बजाने में ध्यान देना हंसने में कम सब अपनी हंसी इतना दबा दबा के रख रहे हैं भाई गॉड हाँ सही है कुछ एलिवेटेड रखो मैं तो बहुत जाऊंगी नहीं गिर ही ना जाऊं
Tinu ma'am, I've muted you for some time. You can ask Raj later to unmute you. So whenever you want to go live.
Good morning, everyone. We are just waiting for our chief guest to arrive. आप मेरे को रिमूव कर दो. Hello, can you hear me now? Your hands together for our chief guest, Mrs. Aarti Ahuja, IAS, Additional Secretary and Director General NACO. We welcome you, ma'am. Welcome, ma'am.
No, I haven't. In fact, वो गाड़ी में रह गया. मंगवा लो. अब you are DHS. Yes, ma'am. अच्छा, MD election से दिया. ओ अच्छा. तो मैंने बात करी थी हेल्थ सेक्रेटरी से. नहीं 11 12 बजे.
Good morning, everyone. I would like to welcome our chief guest, Mrs. Aarti Ahuja, IAS, Additional Secretary and Director General NACO. I request Dr. Vanita Gupta, Project Director, Chandigarh SAPS, to give a floral welcome to our chief guest. We welcome you, ma'am. It's a privilege to have you here today.
Thank you.
Thank you so much. I request Mrs. Poonam Bakshi, M&E Officer, to give a floral welcome to Dr. Amandeep Kaur, Director Health Services, UT Chandigarh. We welcome you, ma'am. I would like to welcome all of you to the 10th Annual Conference of Chandigarh State AIDS Control Society, Aidscon. Chandigarh has been organizing this conference every year for the past 9 years. It's a matter of pride for all of us to welcome you today to the 10th Annual Conference. Due to COVID-19, this conference is being held on a virtual mode. Today, people from all over the world have joined us in this conference. We have speakers from different global as well as international organizations sharing their experiences and presenting their research work with us. It's an honor again to welcome our chief guest, Mrs. Aarti Ahuja, IAS, Additional Secretary and Director General NACO, who has come all the way from New Delhi to guide us and encourage us for successful implementation of this two-day conference. I also welcome all the delegates, guests, speakers, chairperson, co-chairperson for joining us in this conference. To start with, it's the time to light up the lamp and remember God Saraswati to shower her blessing on us. As we all know that our relationship with light is as old as our beginnings. We have always been drawn towards light. It stands for auspiciousness, prosperity, and abundance. Light brings brightness, and in doing so, it dispels darkness, and we begin to see things clearly. I request our chief guest, Mrs. Aarti Ahuja, IAS, Additional Secretary and Director General, NACO, to light up the lamp to begin the conference. I request our Director Health Services and our Project Director Chandigarh SACS to join, please. I request Dr. Rajesh Rana to please join. I request Dr. Vinita Gupta, Project Director, Chandigarh SACS, to give a welcome address, please. Good morning, everyone. So today, the 10th year of Aidscon, 2011, 2021, and we started in 2011. Thank you, NACO, for building confidence in us, for reposing all your confidence in us, and giving us this opportunity to hold this national, now I would say international conference. First of all, I must say a big thank you to our most respected chief guest, Madam Additional Secretary, Madam Aarti Ahuja, for having come all the way from Delhi, especially to attend this conference with us. Virtually, we have many big dignitaries who are also with us today. Thank you, DHS ma'am, Dr. Aman Kang, for again sparing her time to be with us. She was with us for the valedictory as well. Mr. Alok Saxena, Joint Secretary, NACO. Without you, sir, we are not complete. You have been with us all these years and steered us towards reaching today. We have other dignitaries, Dr. Rochna Mitra, Dr. Rita Prasad, Dr. Melissa, Dr. Bilali Kamara, Dr. Alexandra, and of course, Dr. Naresh Goel from NACO. Dr. Arun Kumar Gupta, our Principal Secretary Health, couldn't be here, but he is very much on the line watching us and seeing what we are doing. So thank you everyone for being here today, and a special thanks to the team from NACO who is here, led by Dr. Rajesh Kumar. The rest of the team who is here today is Koshambi, Benjamin, Parul, Garima is not here. I'm missing few names. Who else is here today? Vishal Acharya, right. Thank you. Thank you everyone for being here. And thank you all delegates who are attending this conference virtually. Thank you to the network of positive people, to the TSU who is always with us to support us. So madam, continuing in our steady decline towards the end, we are going to reach the end AIDS as a public health threat by 2030. Our prevalence has come down. We are increasingly testing more number of people. More than 1 lakh tested in 1819, 1920. This last year has been a little bit of a downturn in numbers of testing only because of the pandemic, and everyone knows why. But parallel, our community-based screening and testing increased many folds to reach the people so as to ensure that no one is missed. Our community-based testing has increased from 3,000 to 4,000 in the previous years to 5,000 to 6,000 till now, and further increasing along the way. Prevalence is coming down. We are now at only 0.07% in pregnant women and 1.7% in the general population. Reaching 90 targets. Chandigarh is there, ma'am. 88% the first indicator, 90% the second, and 90% the third. We will reach the 95 well in time. And now perhaps Chandigarh would be the first place in the entire country to announce elimination of mother-to-child transmission of both HIV and syphilis. During the pandemic, our targeted intervention projects did extremely well. They tried to reach the medicines, the testing, dry rations, and even money to the people who could not work. So again, I'm grateful to our NGOs who supported the targeted intervention projects to help them tide over this lean period. Another achievement that Chandigarh has done, the PNPSC is complete, ma'am, and we will perhaps be the third in the country to have completed it and uploaded the results as soon as the portal is open for uploading. New HRGs have been mapped, new hotspots have been identified, so we will be able to provide services in an even better manner. Our relationship with the private doctors is extremely good. The PPP doctors have helped us during the COVID times. When the government health facilities were closed, it was these doctors to whom the people were going to. We just had a refresher training for them, and we are fortunate to have the regional STI lab very much here in Chandigarh in PGI, and that helps us to validate our reports of STIs that these private practitioners report. In fact, this is something that we have started now, and every case of cervicovaginal discharge in these targeted interventions would perhaps be screened to see whether it is really an STI or just an RTI which is being reported, because a lot of figures are showing us that STIs are increasing. Yes, syphilis is increasing, but we are doubtful about the others. So the validation will be done by the STI regional center. The other things that are happening is that the viral load machines till now only in PGI have now been placed in the government hospital in sector 16 and also in 32, which will also increase the viral load testing. So we will again be able to provide that care to the PLHIVs, and they're already being switched very well to the dolutegravir therapies. So the switch is happening, and the rest of it will continue to happen with the help of all these machines that have been put up. Ma'am, the search uploading is also very much online. And there are just a few hiccups that are happening in the ART centers, but they should be ironed out soon. Some problems are, of course, back-end, but the ones that are here have been cleared up. Prison intervention is well underway. With the help of TSU, we have also involved the drug de-addiction center that is being set up in the prison, and they will facilitate the continued testing of the inmates. And also we will be opening up an ART center, not an ART center, but a drug dispensation center in that drug de-addiction center. Blood supply has never been a problem in Chandigarh. In fact, the blood supply program in Chandigarh has been always ranked among the very best in the entire country. During the entire pandemic, ma'am, this area never had any shortage of blood. Today, one of our sessions tomorrow, in fact, is going to be on the blood transfusion services, and our blood banks will share how they managed to get enough supply during the pandemic. The social welfare schemes in Chandigarh, we have linked every PLHIV to some beneficial scheme or the other. Chandigarh was one of the first to pioneer giving socioeconomic benefit to the widows affected, infected, to the children infected, affected of this community. Cross-border issues, because Chandigarh is such a place where across the border, we share problems with the other states. So our liaising with PSACs, HSACs, HB is very good. In fact, our World AIDS Day program was done in collaboration with Haryana SACs, and it was a big success. So, ma'am, we're very much there, and I thank the TSU and our network of positive people once again for giving us the support that they do, and we will reach it. We will reach it. Our target is to ensure that no one is missed. Our target is to ensure that no new cases happen. Our target is to ensure that there is no death with HIV, and also, ma'am, that there is no child born of HIV and syphilis. Once again, ma'am, I thank you very much for coming here this morning and sharing our conference and guiding us. Thank you all for being with us. Thank you, ma'am. This is small change in the program as Mr. Alok Saxena, our Joint Secretary NACO, has to leave for an important meeting. So I would like to invite him first to address us, please. Sir?
Okay, thank you. Good morning, all. Respected DG NACO, Dr. Vanita Gupta, our PD in Chandigarh, all the dignitaries of and on the dais, Dr. Kang, the new Director Health Services. It's a pleasure to meet you, ma'am, and very soon we'll touch base physically. I see a whole lot of our partners, our colleagues, Rochna, Dr. Rita Prasad, Dr. Melissa, our brother Bilali, Dr. Alexandra, Dr. Naresh, Arun Gupta, the Principal Secretary of Health for UT Chandigarh. And I see that over the next 2 years, we have the next 2 days, we have a very illustrative list of participants and sessions that will be taking us through over various technical sessions. We have Dr. Ganga Kherkar, Dr. Sunil Arora from PGI, our own Dr. Naresh Goyal, Sunil Solomon from Johns Hopkins, additional DGHS Dr. Sunil Gupta on blood transfusion services, Dr. Puri, and last but not the least, Dr. Gilada. I hope, Dr. Gilada, you're there for this inaugural. 2 years ago, I was there in the 2019 Aidscon Chandigarh, and the things that were being discussed at that time are now implemented. Though I must say that we had a 1 year long gap on account of the pandemic, which is still, towards ebbing, but not ebbed completely. So in spite of these setbacks or drawbacks, we continued the preparations that we did around this time last year in March 2020 to prepare ourselves for the pandemic and for the lockdown, which happened suddenly, had stood us in good stead insofar as treatment of PLHIV is concerned. Blood we were able to manage, but prevention activities, testing, as Dr. Vanita Gupta herself said, have gone down. I'm sure that this opportunity that Chandigarh SACS provides us every year in the form of this Aidscon, which is almost, when I was briefing the DG, I told her that this is our Aidscon, like the international one, with technical sessions and technical experts drawn from all over the world. So it's a place where, as it is, National AIDS Control Program works with communities, with experts, with the people who are affected with the disease, people who are living with the disease. But this one is a purely academic work where all of us go as students and try to learn things, notwithstanding the fact that one could be heading a SACS or university or medical college department or a division in the government. That is relevant but not material, because we come here to learn new things and how they can be implemented in the program. We also know that in health particularly, and in HIV/AIDS, National AIDS Control Program specifically, one size doesn't fit all. It differs from state to state, location to location, and we also try to tell each other, learn from each other, how we are doing in various parts of the country, in various sites, in various cities, and what all can we learn. It is also to the indomitable spirit of Chandigarh, which, as Dr. Gupta said, flanked by states where you have, this total traffic of people going in and coming out. To control this pandemic, there are people who would be staying or sleeping in Punjab or Haryana, but come to work or even engage sexually in Chandigarh. How to control that. So Dr. Vanita Gupta has been doing that work for a long time. Every time when I meet her, I say, Dr. Sahab, abhi aap rahoge na? To main phir puchunga, Dr. Sahab, abhi aap ho na? And Also, I must welcome and introduce our new DG, who is a Chandigarh di kudi. So, वो आपकी अपनी है और उनका पुराना बहुत नाता है AIDS control program से. As Odisha SACS PD long years ago, she's back and she brings with her verve and passion of long years of association in the development sector. And quite unlike me, who's like a regulatory guy, so I'm sure that, and I, that our team, that ma'ams and our team will, along with all of you, take us in a direction where we are able to reach 95, earlier than what is mandated by UNAIDS. As our compare said this morning that I have to rush for a meeting, I'll excuse myself. The moment I come back, Dr. Gupta, I'll join. This room is on for the entire day. Whoever is there will join from here. So this is today, my 9th floor conference room is yours, Chandigarh SACS, and all of us who are in NACO headquarters will be taking part in the technical sessions. As and when I have time, I'll join. In fact, I find that all the sessions that you have are of immense interest to me personally and to us NACO in a policy matter, particularly the one with Dr. Gilada, with Dr. Puri, Sunil, Dr. Sunil Gupta, Sunil as in Sunil Solomon. So we try to be there, at least one of us, and I'll personally try to be here for the sessions, which, all of them which are important. With these words, I thank you, ma'am. I thank you, Dr. Gupta, for inviting me and for actually doing this great work year after year after year. Thank you.
Thank you so much, sir. Thank you for joining us and for such kind words and motivating us. Thank you, sir. Thank you very much. It's a proud moment to have our global partners with us today, who have always supported AIDS control program. First of all, I would like to invite Dr. Rochna Mitra, Project Director, Plan India. She's a public health professional with 25 years of extensive experience in overall health with specialization in HIV/AIDS, reproductive, maternal, adolescence and sexual health, and empowerment and gender equality. I welcome you, ma'am.
Good morning and thank you. I hope I'm audible to everybody.
Yeah, ma'am, you are.
Yes. Good morning and respected DG NACO, Aarti Ahuja Madam, our beloved Joint Secretary Alok Saxena Sir, DHS Madam, Dr. Vanita Gupta, Project Director, Chandigarh SACS, all dignitaries on and off the dais. Thank you very much for the invitation. And I find myself very privileged to be attending and talking about it. At Plan India, we are extremely grateful and privileged to be partnering with the national program for working towards the elimination of mother-to-child transmission across 14 states in the country where we work. As we are all aware, India is committed to ending the AIDS epidemic as a public health threat by 2030, in line with the Sustainable Development Goals. Plan India is proud to partner with the national program, working with all the divisions in NACO to further the agenda of elimination. We are very hopeful that through guidance from NACO and through joint efforts, we will achieve the goal. And as we move forward, we will continue to ensure that all people living with HIV and those at risk receive a comprehensive package of treatment, life-saving services for HIV prevention, testing, treatment, and care. We are not only working on with the national program on preventing and eliminating mother-to-child transmission, we are also responsible for ensuring that testing kits and antiretroviral drugs, which are life-saving, they are distributed across the ART centers, across the ICTCs, and there are no stockouts, and it has, and with proper guidance from NACO, the project has been successful, and we hope to improve it as well in the next 3 years. We have also done the training of all ANMs and counselors so that the peripheral testing increases, village health and nutrition day testing increases, because we all are aware that is the key to the elimination agenda. Once again, thank you so much, Dr. Vanita, for inviting me. Plan India is very happy and privileged to be part of this conference, and I look forward to all the sessions and to hearing all the, the stalwarts, as Jay sir has mentioned, all my colleagues in the sector, and learning from them. Thanks to the positive networks, thanks to everybody who is attending it. Thank you so much. I'm wishing the conference a lot of success. Thank you.
Thank you very much, ma'am. Thank you for joining. I would like to invite Dr. Rita Prasad. She works as a director of programs at Alliance India. She holds a degree in medicine complemented with a master's in public health. She has nearly 2 decades of experience in clinical and public health management of HIV/AIDS, tuberculosis, family planning, maternal and child health, adolescents health, nutrition and research programs, and worked in various organizations like CARE, ICMR. She has worked in National AIDS Control Organization, Ministry of Health and Family Welfare, and led care support and treatment initiatives. She has also worked with WHO and provided technical support to revised National Tuberculosis Program in high burden states areas in Chandigarh. I welcome you, ma'am. Ma'am, we can't hear you. Can you unmute, ma'am, please?
Thank you.
Welcome, ma'am.
Respected AS and DG ma'am, Joint Secretary Sri Alok Saxena, Dr. Kang, Principal Secretary from Health Services Chandigarh, Goyal sir, NACO and SACS officials, Dr. Vanita, Dr. Kamara Bilali, Dr. Sangeeta Kaul, Dr. Melissa, Rochna, Dr. Alexandra, and partners from development sector, from research agencies, faculty from medical college, and most importantly, various students who must have logged in from various places from national and international. Greetings from Alliance India. My sincere appreciation, Dr. Vanita, Project Director Chandigarh SEX and NACO, for organizing yet another virtual Aidscon, but under the shadow of COVID-19. Ma'am, this requires a lot of planning, and presently in these circumstances, I salute you, ma'am. Although we know that global attention is dominated by COVID-19, but we must be aware that HIV/AIDS pandemic is entering its 5th decade and it's far from over. Ma'am, congratulations for achieving the 1990 target, but we know for many states and for country, we have missed it. And we are aware of the fact that the Lancet Global Health shows that severe treatment disruptions because of the COVID could increase HIV mortality by 10% within the next 5 years. But we know the initial phases of COVID-19 HIV prevention testing and care were initially disrupted, but things are not so, it has not been so bad for us. And we know that treatment disruptions has not been so severe, and we have taken very good initiatives, and thanks to our novel approaches, close coordination between policymakers, implementing partners and communities, we have, I think, able to avert a major disruptions. Early decisions involving key stakeholders led to scale up of differentiated service delivery for HIV by expediting multi-month dispensation of HIV medicines, which may otherwise might have taken some more time. So we are proud that Alliance India, along with its subrecipient partners and community networks, played a major role in supporting this program during this COVID time. Multiple innovations of our partners, especially the community networks, like home deliveries of medicines, CSC-based drug dispensations, digital platform for virtual patient support, which actually included adherence counseling on COVID-19 appropriate behaviors, linkages to food security and other social support. HIV prevention services have rebounded, and we know that communities are highly appreciative of the fact that how a nation has averted one of the major pandemic. But we all know and we are cognizant of the fact that a chilling pattern of inequity shapes the burden of COVID-19 HIV. The effect was evident on our key population, and Alliance India, along with other partners and with support of Global Fund, is committed to support national program as we move forward in implementing direct benefit transfer for most needy among the communities. So we will be supporting national program in reaching out with direct benefit transfer for almost 1,85,000 most needy key populations. All that we say about COVID-19 has not actually been so bad. It actually has uh, uh, imperiled HIV services and forced health systems to adapt. But adaptations need not always be harmful. So we need to look also for opportunities to prioritize people-centered strategies, which could actually empower patients and help to address issues like stigma, discrimination, and poverty. And I think with the appropriate action taken by National AIDS Control Society, National AIDS Control Program, State AIDS Control Program, and various development partners, we have taken the right approach, and we will be able to rejuvenate the HIV response. And Alliance India is committed to support national program in this endeavor. I look forward to these 2 days of intellectual deliberation, and I'm sure that robust uh, uh, international and in-country programmatic and research data based on evidence in area of HIV will further nourish our learning, and it will guide us in providing better HIV care. With this, I wish best of luck for these 2 days of conference. Thank you.
Thank you so much, ma'am. Thank you for joining. Now I would request Dr. Melissa. She's the Director, Division of Global HIV and TB Centers of Disease Control and Prevention, CDC India, New Delhi. Welcome, ma'am.
Thank you very much. Ms. Arti Ahuja, ASDG NACO, Sri Alex Saxena, JS NACO, Dr. Naresh Goel, DDG, Sri Arun Kumar Gupta, Principal Secretary, Dr. Vinita Gupta, PD, Chandigarh SACS, Dr. Kang, Dr. Tina Khanna, Dr. Sandeep Mittal, and other dignitaries on the virtual dais, and all our friends here today. On behalf of PEPFAR and the U.S. Centers for Disease Control and Prevention and our sister agency, USAID, I'm delighted to be here with you all today. PEPFAR is grateful and proud to work with NACO and SACS and communities across all 90s and 95s now to really push towards epidemic control. It has been over a year since we learned of novel coronavirus, which is severe acute respiratory coronavirus 2 or SARS-CoV-2 causing COVID-19. Now widespread COVID-19 has impacted the world over and caused widespread disturbances. However, around the world, innovative strategies and committed governance has shown the way to maintain the gains and build back despite incredible challenges. The collision of HIV and COVID-19 has been an ultimate stress test of systems, but it has also catalyzed innovation, and it has shown what collaboration across stakeholders means to meet the gravity of the moment. India has been a leader in getting out in front of the pandemic to proactively look at solutions, eliciting community feedback, and leveraging partnerships to ensure HIV clients receive the care they need despite the pandemic challenges, with wonderful examples across India on partnerships to ensure PLHIV receive their medication and other services, as mentioned just before by Dr. Rita. If we think about this in a terms of undetectable equals untransmittable framework, it is likely that many new infections were prevented by all the hard work ensuring clients were able to stay on ART during this pandemic. UNAIDS in their report Prevailing Against Pandemics noted COVID-19 has been a historic challenge, but also an opportunity. And it's underscored the agility of the HIV response through policy and service delivery innovations. We have seen these new innovations here in India with coordination, collaboration, integrated service delivery models to ensure clients can continue life-saving treatment. While the work continues, it is wonderful events like these here at Aidscon where we all join together and learn about new approaches and innovations. I'd like to offer my congratulations to Dr. Vinita and the Chandigarh SACS organizing team, and I'm really delighted to be with you here today, and best wishes for a wonderful conference. Thank you so much.
Thank you, ma'am. Thank you very much. I would like to invite Dr. Bilali Kamara. He's working with UN AIDS as Country Director for India. He is a citizen of Netherlands and Mali, a medical doctor with a master's degree in public health. He has more than 34 years of international and national experience in health policy and visited more than 50 countries on 4 continents for professional or academic reasons. He has published various articles on HIV, AIDS, TB, STI. He was also a member of UN MDGs. He is a member of International AIDS Society Abstract Review Board. We welcome you, sir.
Thank you. Thank you very much, Madam the Chair, and my dear respected Madam Artia Ahuja, Director General NACO, and my colleague Shri Alok Saxena, Joint Secretary NACO. The two are my sister and my brother. And I certainly look forward to the brotherhood and the sisterhood as we move forward. My best regards and thank you for really taking time to join our colleagues in Chhattisgarh and be with them. It tells us a lot about your leadership. And Shri Arun Kumar Gupta, the Principal Secretary of Health, dignitaries on the dais and off the dais, friends from the community and the civil society, colleagues from the academia, colleagues from the United Nations and development partners, representatives of the media, ladies and gentlemen. Let me thank the organizer of this scientific and community gathering today on behalf of the UNAIDS Executive Director and the United Nations family in India, and especially our co-sponsors, UNICEF, WHO, UNDP, ILO, UNODC, World Bank, UNFPA, UNESCO, the World Food Programme, UNHCR, and UN Women. Those are the ones who are really making UNAIDS what it is today. But I have to really say it, UNAIDS has been created as a replicate of NACO. I really have to admit it and say it. Indeed, this annual high-level gathering is serving as an opportunity to share and learn between scientists, policymakers, civil society, and community activists, discoveries which have been made, lessons which have been learned, and innovative, effective strategies to further address the AIDS epidemic effectively in India. During these 2 days, we will hear from the scientists about their discoveries, implementers about their innovations, the civil society about their progress in advocacy and upholding human rights, the community about their readiness to do more, and the National AIDS Control Organization, NACO, about its inclusive approach to ensure that all these energies, innovations, and knowledge will deliver results for the people so that no one is left behind. My congratulations to Chandigarh for this sustained leadership. And as we say in my country, it is sometimes challenging to be small, but it is always good to be smart. Thank you, Shak Chandigarh, for this creativity in making your union territory the annual epicenter of the AIDS knowledge and sharing in India, and making it one of the best national AIDS conferences in the Asia and the Pacific region. We will discuss a little bit more about what has happened during those challenging times in my next intervention. But let me thank you and tell you congratulations again. Despite the challenges we had together, despite the challenges we have seen our NACO Director General with you, a sign which we will not forget. And I wish you a very successful conference toward AIDS-free world. Thank you very much.
Thank you, sir. Thank you so much for joining. Now, I would like to invite Dr. Alexander. She is Team Leader, Communicable Disease, WHO India. Welcome you, ma'am.
Thank you very much. Ms. Arti Ahuja, DG NACO, Shri Arun Kumar Gupta, Principal Secretary Health, Chandigarh, Dr. Naresh Goel, Deputy Director General, IEC NACO, Dr. Bilali Kamara, UNAIDS Country Director for India, Dr. Melissa Nyandak from CDC, JS Alok Saxena, JS NACO, Dr. Rita Prasad from Alliance, Dr. Rochana Mitra from Plan India, officials from NACO and state AIDS control societies, representatives from civil society and communities, colleagues, friends, ladies and gentlemen. Greetings from WHO India. It is indeed a pleasure for me to be with all of you in this National Aidscon conference organized by Chandigarh State AIDS Control Society. 10 years is a long time, and organizing the conference at a national level year after year represents an incredible effort. I am really happy that we as WHO have been a part of this journey through all these 10 years. I must congratulate Chandigarh SACS and Dr. Vanita Gupta for this excellent event that continues to improve and have greater participation year by year. This year, the event is special. It is happening at a time when the world has been going through the pandemic, which has affected many of us in one way or the other. It has posed many challenges to us and at the same time has provided us with an opportunity to innovate, to adapt, and to keep delivering. The conference comes at a time when we have excellent lessons to be learned from each other, and it provides a great opportunity to hear about what worked well and under which circumstances. The intersections between these two viral diseases, the challenges, the opportunities, and of course, the evolving global evidence as well as national evidence will go a long way. And these are very well captured in the exciting agenda of this conference. I want to say to all the eminent women that I see on this panel and in the conference, happy International Women's Day on Monday, March the 8th, this coming Monday. I look forward to the wonderful scientific sessions as has always been exemplified in the Aidscon, and wish all of us wonderful and productive deliberations and discussions. I would like to end by congratulating Chandigarh SACS and NACO for this initiative and thank them for inviting WHO to participate and contribute once again. Thank you.
Thank you very much, ma'am. Thank you. Dr. Naresh Goel, Deputy Director General IC, CST, and Mainstreaming NACO, is getting his vaccination done, COVID vaccination. So he'll join us later in the second half. Now I would like to invite Dr. Amandeep Kang, Director Health Services, UT Chandigarh. She joined PCMS in 1989. She did her MD in Obs and Gynae in 1995 from Government Medical College, Patiala. She was deputed in Chandigarh in 1999 as HOD Obs and Gynae in GMS at 16, Chandigarh. She has been awarded by His Excellency, the Administrator UT Chandigarh, for her excellent working during COVID-19 pandemic. We welcome you, ma'am.
Respected Additional Secretary Ma'am, Dr. Vanita Gupta, Project Director CSACS, and all the esteemed delegates who have joined in this virtual conference. It is a great privilege for Chandigarh Health Department to be hosting this national conference. And even in these challenging times, Dr. Vanita Gupta has taken up this challenge again. Year after year, she has been organizing this conference with great passion. The National AIDS Control Program is progressing very well in Chandigarh and is on its way to reach the national targets by 2030. The infrastructure for health services in Chandigarh is excellent, and patients from adjoining states visit the city to avail the health facilities. To strengthen the testing services so that no one is missed, more facility integrated centers have recently been added and increased to 31. The 3 treatment centers are registering and treating all positive cases. CSACS is collaborating and supporting other national programs like NVHCP, HIV-TB, and there is 100% reach to pregnant women. During the pandemic, the counselors and other staff helped in a big way to manage contact tracing, reporting, quarantine, monitoring, and delivery of medical services to home isolated patients, in addition to their duties of AIDS control. And we are thankful to our AIDS control team and all the personnel in Chandigarh for helping in the control of pandemic in a big way. Dr. Vinita has over the years, with great passion, she has been organizing the Aidscon, and this year also she has organized a veritable feast of scientific topics related to control and treatment of AIDS. I congratulate you, ma'am, and thank you, ma'am, Additional Secretary, ma'am, for joining us in Chandigarh. Thank you. Thank you, ma'am. Thank you very much. Now it's an honor to invite our chief guest, Mrs. Aarti Ahuja, IAS Additional Secretary and Director General, CGHS and NACO, New Delhi, to address us, please. Ms. Aarti Ahuja, IAS, joined Indian Administrative Services in 1990 after completing her master's in economics in LLB, and is currently posted as Additional Secretary and DG, NACO, in Ministry of Health and Family Welfare, Government of India. She has a career spanning more than 30 years in central government and in the state. She has been secretary in various departments in the state, such as handloom and handicrafts, women and child development, health and family welfare, tourism, and many system-level reforms brought in by her in nutrition and health sectors were recognized as national best practices by independent national and global organizations. She's a member of Independent Expert Group of the Global Nutrition Report, an independent global report brought out every year, and was also a senior honorary research associate at the Global Institute of Health University, London. She has written a number of articles of different journals and books. It's a privilege to have her here with us today. We welcome you, ma'am. Thank you, friends. And first of all, let me, without taking names, formally welcome everybody, virtually and physically, to this wonderful occasion. Thank you so much for inviting me here. I understand that it is the first time you're doing a virtual event, and I must say you've done a fantastic job. Even though it is virtual, I can feel the buzz in the room and I can feel the buzz over the waves virtually. So compliments on organizing such a wonderful event. And thank you for inviting me here. Like Alok has told you, I belong to Chandigarh. And for me, it's actually a very important moment that I'm standing here today because I grew up in Sector 35. I went to school in Government Model School, Sector 35. And today I'm standing here in Sector 35 talking to you. So I feel very proud about it. It's not just, when I started my career, one of the very first postings I held was as PD SACS. That is when NACP2 was just starting. Mr. Prasada Rao was the MD NACO, ASNDG NACO, he was then. And I was in the state of Orissa, just like you are here. And that is when I started learning about it. That is when the new plan came in, and that is when the things that we see today, those were set in motion. Everything that we take for granted today, like targeted interventions, the community level engagement, the social marketing, etc., all those concepts came in then. And that was my grounding in the work of HIV/AIDS. But life has come full circle, just as it is today. And I continue to be inspired. I continue to be amazed by the people
who work in this sector, and more importantly, by the communities. A few days back, the network of people living with HIV/AIDS, they had come to meet me in my office. And amongst them was a young girl. I think she's only 19 or 20 years old. And both her parents were positive. She herself is positive. But what an amazing person she is. When I went home, I told my husband and my two sons in detail about her. Amazing person she is. And so is each one of the people in the communities. The resilience of character, the strength she has, the optimism she has, we don't have that much. And she became orphaned at a young age, grew up in an orphanage, and today she is holding her own. She is her own person, and she is very much, I wouldn't like to use the word productive. Everybody is productive, but she is very much on the forefront of what is happening. And you must have heard that शेर, that खुदी को कर बुलंद इतना कि हर तकदीर से पहले खुदा बंदे से ये पूछे बता तेरी रजा क्या है. And she has shown that. The takdeer that was given to her, if she could have bowed down before that. But it is people like her who inspire us, each one of us, every day, because they are the ones we work for. They are the ones for whom this whole setup is there. They are the ones for whom SACS is there, and they are the ones for whom NACO is there. Each one of them are our bread and butter. Each one, they are the ones who give us our salaries, and we must never forget that. We have joined this job because we are working for them. It is not a charity we are doing for them, it is their entitlement, and we are here to provide that. So today's conference, in fact, and it is a series of many conferences that you have been doing. Today's conference is about that. It also highlights another very important aspect of the way NACO has been functioning all these years. Right from day one, NACO has worked on evidence base. And you have been part of creating that evidence base through the academic, international level conferences that you organize every year. The inputs that are coming from there, from different academics, from practitioners, are something which have been very useful and which will continue to be very useful as inputs in the program. Today we are in the era of COVID. We have all talked about it. All of us are wearing masks, except me right now, but all of us are wearing masks, and life has changed for us. As additional secretary in the ministry, I also look after the COVID response. And today, after this meeting, I'm going to meet the health secretary and I'll be discussing about COVID. But as I keep telling my team at NACO, and as I keep telling my team in the ministry that looks after COVID, that a pandemic has to have the same basic epidemiological response. The public health response does not differ much. AIDS is a smoldering epidemic, and COVID is a epidemic on fire, so to speak. But the response is the same. It is the person at the center. The virus has to be controlled from moving from one person to the other, right? So it is the person that has to be placed at the center, and then the public health response comes about. And just like in AIDS, similarly in COVID, it has been an all of government approach. It is not just the SACS or the AIDS control societies or NACO itself that can do the job. We have to involve other departments. We have to involve other people from the society. We have to involve private sector. The academia has to be there. The multilateral agencies who have been so supportive of the AIDS control in India, all those have to work together, and all those have worked together. And that is a similar approach that has also come about in the COVID response, right? So the lesson that we learn both from COVID and from AIDS is that number one, you have to rely on evidence. Number two, any response that we make has to be person-centric. And number three, if your systems are working, so anything that you do symbolically is not going to work unless you ingrain it in the system. And how do you ingrain it in the system? By not making it about myself or me, right? We ingrain it in the system by setting up standard procedures, standard ways of working, making sure that whatever is done continues, even, it gets entrenched so much that it becomes a way of working. And that is what has happened in AIDS. That is what has also happened in COVID. So many SOPs have been issued, both by NACO over a period of years and also by the ministry during COVID. All those are being adopted all over the country. That is how systems are built. And all of you, each one of you, and those who are attending virtually have been part of building this systemic response. And I must say, we as a country, we must feel very proud. All of us who are present virtually and who are present here today, and anywhere, those who are not present here today also, all the communities, all the partners, all the civil society, people in the government, we must feel very proud as a country in the way we have tackled the AIDS epidemic and the way we have tackled the COVID epidemic. It is something that the world is watching and something that is already becoming a subject of much academic discussion about how a country like India could show such a good response to both these things. So I think the credit goes to each one of the people, down to the person at the grassroots who have been working, our ICTC counselors, our ASHA workers, our ANMs, everybody. They deserve a big salute from our side for working in both the programs. Now, coming back to AIDS, we all have the target of 90, 90, 90 before us. In fact, it's no longer 90. It is 95, 95, 95. And as I keep saying in NACO, for us, it is 100, 100, and 100. There is not a person that should be left. You cannot afford to leave even one person, because that is the nature of the virus, which we have learned again and again, that one person left means the virus is there and the virus will transmit and the virus will multiply. So our aim for all of us has to be 100, 100, and 100. So let us look at how we can build more systemic responses. Let us work together. I think after this conference, let us have some deliberation on how we can increase the responsiveness of our own strategies, of our own inputs, so that we can achieve 100, 100, 100 in the coming 1 or 2 years. So I would very much look forward to the deliberations, and I really wish I was there to attend them. Maybe I'll log in between and listen to some of the speakers as they're speaking. Because there's a lot to be learned from the academic papers and a lot to be imbibed there as well. So I would once again like to thank the PD SACS, the DG Health Services, all the colleagues sitting here, all the colleagues and friends who are present virtually. Thank you so much for organizing this. And let us continue working for those nameless and faceless communities, friends of ours who have nobody else to turn to except us. Remember, we are the only people for them. So we have to bring everybody together and we have to reach out to each one of them, the last person we have to reach out to. Thank you. and wish you all a very happy year ahead. May we be free of COVID very soon, and similarly, may we eliminate AIDS from our country as well. Surely we can dream about that. Thank you so much.
Thank you very much, ma'am. Now I request Dr. Vanita Gupta, Project Director, Chandigarh SACS, to give a token of remembrance to our chief guest, Mrs. Aarti Ahuja, IAS, Additional Secretary and Director General, NACO. I request Mrs. Poonam Bakshi to please give a memento to our guest of honor, Dr. Amandeep Kang, Director Health Services, UT Chandigarh. Thank you, ma'am. It's the time to release Sankalp, annual M&A booklet of Chandigarh SACS. I request our chief guest, our guest of honor, our project director to please release the booklet. Ma'am, it's the annual booklet of Chandigarh SACS. Please put your hands together. Thank you. Now I would like to invite Mr. Sandeep Mittal, Deputy Director TI Chandigarh SACS, to give away the vote of thanks, please.
Good afternoon, everyone. It is my privilege to propose vote of thanks for 10th National Conference Aidscon. At the outset, on behalf of Organizing Committee of Aidscon 10, I would like to express my profound gratitude to Honorable Chief Guest, Madam Aarti Ahuja, IAS, AS and DG NACO, for sparing her valuable time to inaugurate and preside over this 2 days conference. Chandigarh SACS is able to organize event of such a magnitude under your kind patronage, ma'am. Your presence inspires us in organizing more such events in future. I take this opportunity to thank Shri Alok Saxena, Joint Secretary NACO, for providing periodic support for various activities of Chandigarh SACS. Your kind words have motivated us to innovate and conduct more novel events. I place on record deep sense of gratitude for the faith you have bestowed on Aidscon team. I wish to express my gratitude to Dr. Naresh Goel, Deputy Director General NACO, for providing encouragement and support. This conference is being conducted under his able guidance and support of his team from IEC division at NACO, specifically Dr. Rajesh Rana, National Consultant NACO, who actually monitor and guide from time to time for conducting this event. Now, sincere thanks are due to Dr. Bilali Kamara, UNAIDS Country Director, Dr. Alexandra, WHO, Dr. Melissa Nandak, CDC, Dr. Rita Prasad, Alliance, Dr. Rochana Mitra, Project Director, Plan India, who have very kindly consented to enlighten delegates with their valuable remarks. And we are really thankful to you for being with us today. And I'm sure with your able guidance, we will be able to end HIV/AIDS epidemic as public health threat by 2030. Let me express my gratitude to Dr. Amandeep Kang, Director Health Services, UT Chandigarh. She has always been a great motivating force behind various activities of Chandigarh State AIDS Control Society. Ma'am, we thank you for your constant support and encouragement. Thanks are also due to all officers from NACO, Ministry of Health and Family Welfare. Thanks are also due to Technical Support Unit, Chandigarh Network of Positive, various departments in PGI, Chandigarh, GMCH, Punjab University, who are constantly providing technical support for various activities of Chandigarh SACS. And we have been fortunate enough to be backed by our team leader, Dr. Vanita Gupta, Project Director, Chandigarh State AIDS Control Society, come Organizing Secretary, Aidscon 10, who with her meticulous planning mobilized the team members to extract work as per their capacities and capabilities. I take this opportunity to extend my most sincere thanks to all chairmen, co-chairmen, and guest speakers who have agreed to join virtual platform from different locations within India and outside India for their support. I thank all the members of the organizing committee and all my colleagues who have been involved in this particular exercise for last several months. Without their cooperation and full support, this conference would not have been possible. Finally, the wonderful audience who has registered and are attending the conference virtually in overwhelming numbers. We thank you very much for your kind presence. And I cannot thank everyone enough for the involvement that they have shown and willingness that they have expressed to complete this task beyond their other committed duties and beyond their comfort zones. Now, thanks all once again, and we look forward to an extremely productive 2 days deliberation during this conference. Thank you. Thank you, ma'am.
Thank you, Sandeep sir. Now we'll have a short tea break, and after that, we'll start with a session 2, NSCP response during COVID-19 pandemic. See you after a short tea break. Thank you. तुम मुझसे कोई रिपोर्ट मत मांगा करो दोनों जने, अब तुम आ गए हो ना, देखा कितना बिजी रहते हैं आप। ठीक है, कोई रिपोर्ट नहीं मांगेंगे। यार म्यूट कर दिया हमने, हेलो म्यूट तो कर दिया, अगर यार जैसे ही खत्म होता है ना ऐसे म्यूट
Good morning, Dr. Selena, ma'am. Am I audible? I'm just doing a voice check.
Yes, ma'am, you are, ma'am. This is Tarun here.
Okay. Thank you, Dr. Tarun. I think it's time to start. We are waiting.
We're waiting for the chairpersons to come here.
Okay.
Hello, Tarun.
Yes, ma'am. Good morning.
Good morning, Tarun. What time I have my presentation?
Can I have your name, ma'am, please?
Varsha Gupta.
Oh, acha, Varsha, ma'am. Good morning, ma'am.
Good morning.
Ma'am, in this session only, it's at around 12:35, but I think we'll take another 5-7 minutes to start. So around 12:40, around, ma'am.
Around 12:40. Okay. And can I do a screen test?
Yeah, you can do it right now, ma'am, if you want.
Okay, I'll do that.
Yeah.
Then some of the container are transferred to a container with liquid nitrogen. To determine
Is it okay?
It's opening, ma'am. Yeah, I can see your presentation.
You can see my slides?
Yes, ma'am. Yes, ma'am, I can, ma'am.
Okay, good.
Good morning,
Thank you,
ma'am.
Thank you. I can change
Sure,
also.
ma'am. Sure. Yeah, you can, ma'am. You have the controls.
Right?
Yes,
Okay.
ma'am. We
So
can see your
it's
presentation.
good for presentation, right?
Yeah. Yes.
Thank you,
Yes, ma'am. It's
Tarun.
good to
Thank
go.
you so much.
Sure, ma'am. Sure.
very good. Another main method is drying. Drying preservation.
Maninder, ma'am.
These drying methods.
Maninder, ma'am.
Yes, sir.
Are we ready,
Moving
ma'am?
on to our
You also have a
next
presentation.
session, session 2, NACP response during COVID-19 pandemic. Shri Alok Saxena, IAS Joint Secretary, NACO, is away for a meeting, so he'll be joining us later. Dr. Naresh Goyal, he is taking his COVID vaccine today, so he'll join us in the later half today. I request Dr. Gomes, Project Director, Goa SACS, to please chair the session. I welcome you, ma'am. Can you hear me?
Yeah, I can hear you. Am I audible too? I'm able to hear you.
I think there's a small technical error. Can you hear me, ma'am? Dr. Gomes?
Yes, sir. We can hear you.
Can you hear me?
Yes, ma'am.
Good morning,
Yes, ma'am.
ma'am.
We can. Good morning.
Yeah, good morning. So this is the beginning of the next session, NACP response during the COVID-19 pandemic. I'm the co-chair. Dr.
Ma'am,
Gomes.
can you just check your speakers?
Ma'am, she's audible.
We can hear Dr. Miss. We can hear Madam.
I cannot hear, ma'am. I cannot hear her.
Just hold on, ma'am. Just hold on.
Yeah. Hello?
Hello, yeah.
Yeah, ma'am, I can hear you now. So handing over the session to you, ma'am.
Okay,
Welcome.
Yes, I'm Dr. Gomes, Project Director for Goa State AIDS Control Society. Thank you for giving me the opportunity to chair this session. And without making much delay, the second session is the National AIDS Control Program response during the COVID-19 pandemic. And the first topic for today is provisioning ARV through PLHIVs. We should be the speaker for that session is Dr. Maninder Kaur, NACO. Welcome to you, madam.
Thank you, ma'am. Is my screen visible, madam?
Yes, ma'am.
Okay. So a very good morning to everybody who is attending the session, and Honorable Chair, Co-Chair Dr. Gomes and Chairperson DDG who will be joining us shortly. First of all, I would like to thank the organizers of Aidscon to give us this opportunity to present NACO's response or NACP response. And I'll be mostly presenting the essence of how the program ensured uninterrupted supplies. And just before I start my presentation, I want to take a moment to honor all of those our frontline workers whom we lost due to the COVID-19 infection. Our prayers and best wishes are with their families. Having said that, now I would like to formally start the response of the program during the COVID-19 pandemic. So the overview of the presentation will be, there was a scenario in January last year, just before the lockdown, then how the program responded or evolved, the response evolved actually throughout the year, and what were the lessons learned and way forward under the NACP. So just before the lockdown, we all know that on 12th of January, WHO confirms the novel coronavirus as the cause of a respiratory illness, and which was reported to WHO on the 31st of December. On 30th of January, India reported its first case of COVID-19 in Thrissur, Kerala. And 1st of February, on 31st January itself, we were scheduling a high-level emergency meeting on 1st February, which was held at NACO to discuss the need for lopinavir ritonavir for patients infected with novel coronavirus. Here, I would like to mention that we were constantly looking at what was the evidence, global evidence emerging of treating and preventing this disease, infection and disease. In the meeting, DCGI informs us that open label use of lopinavir ritonavir in patients infected with the novel coronavirus was already approved just a few hours earlier to when we held the meeting on humanitarian grounds and as requested by ICMR. Our initial concerns of the program were obviously due to regarding the LPVR stocks. But in early March, as the number of reported cases of infection with the novel coronavirus increased across the country, concerns were raised regarding the vulnerability of peel HIV to the new viral infection. In response, on 16th March, a multi-stakeholder meeting was organized at NACO with national and global experts. We reviewed the existing evidence on vulnerability of peel HIV. This was deliberated upon during the meeting. A guidance was drafted for prevention of the infection, both among the NACP staff and the PLHIV. And email inputs were taken from a wider group of experts. On 23rd of March, NACO shared a comprehensive guidance note with all the states and stakeholders. And all of us know that just the very next day, on 24th of March, a lockdown was announced when the death toll reached 12. So how did we ensure an uninterrupted supply of ARV drugs to PLHIV during the lockdown? What happened, all of us, many of us, in fact, were taken by surprise about the complete shutdown. There was no transport, no travel facilities. The challenge was coordinating between state authorities, our Plan India and TCI, because our first concern was that the states should have adequate stock of the drugs. Then another challenge emerged is PLHIV on ART was stuck in different parts of the country. When the guidance note talked about decentralization and community-based dispensation, and all this threw up the challenge of documenting what ARVs we were dispensing. Another challenge was updating the records of dispensation, PLHIV from private sector seeking ARVs from ARV refill facilities nearest to where they were stranded, instances of foreign nationals on ARTs stuck in the country, patients on third-line ARV regimens stuck in states with no center of excellence, no supply of third-line drugs. So the immediate mitigation strategies, as I've listed the challenges of ART uptake, getting the ARV drugs. Like somebody also, we have mentioned before, new initiations reduce contact with the providers, the patient-provider contact reduce, It had an impact on counseling services, like I said, challenges with third line. Also, because of this complete shutdown, constraints with viral load and CD4 testing, LFU trackbacks, when some of the states tried, phone numbers would not work. When some were not updated, and also subsequently in the lockdown, large-scale migration of HIV positive people. Some of the mitigation strategies, like I said, it all started with a guidance note which we shared to prevent the infection, allowing PLHIVs, multi-month dispensations, decentralized community-based dispensation. ARVs had to be transported emergency with special permissions for third-line patients of other states. This required interstate coordination for migrant PLHIV also, for patients from the private sector. And as the epidemic evolved and the needs of the key population, we realized there was urgent need for looking at other needs of the PLHIV community. Supply chain management strategies, we had to give special permits for drug transportation, coordination with National Health Mission, vehicles which were government vehicles which were allowed movement during the complete lockdown. Emergency relocation between districts and between states. We had instances in the Northeast where, under police protection, the drugs had to be transported across borders. Interministerial coordination with MHE and DCGA, because we needed special airlifting, air transport of the drugs and the kits. So this level of strategies had to be used. Then, as the need evolved, capacity building, there were national and regional distance learning seminars for all our staff on how to prevent themselves and the patients from the infection. And the NACP counselors of our helpline were looped in. Their capacity was built to provide information, because in the shutdown, information provision became critical and crucial for managing this scenario. Program management, we use the technologies to have virtual meetings with states and ARTC, and continuously, as the needs evolve, guidance and advisories to ensure uninterrupted services. So some of the actions taken by NACO, SACS, partners, and our community. And I'm here projecting a picture where the client was at the center of all our efforts. It was a coordinated response and a client-centric approach which worked for our country. And everybody rose to the occasion, not only the policymakers, but the implementers and the communities, our outreach workers, our development partners and technical partners. It was a coordinated country response. And now, like Madam Artil just said, we are analyzing what went well for us. Some of the actions taken by NACO were the various guidance which we issued from over the first 6 or 7 months of when everybody was trying to grapple with the situation, to include ART services under essential services. This was a very, very critical requirement, as we know that in the initial phase of the lockdown, only essential services were allowed to function. So many of our ART centers, there were reports coming in that they have been closed. Also required permits for even PLHIV or patients traveling, even ORW traveling to deliver drugs. These had to be facilitated. As everybody has said, we said give 3 months of medicine because the travel was a big challenge, along with IPT and CPT prophylaxis. This was also very important to keep the immune status of the patient intact. Another thing, the guidance was that no PLHIV to be denied ARVs. Whether they are stuck in other state districts, we have sent guidance that nearest ART center should provide, or the decentralized facility wherever these ARVs were being given. Even private sector guidance was sent regarding private sector patients. We were constantly in touch with the ASI, Dr. Gilada, and that led to the guidance note regarding private sector. For emergency transport, we had Plan India, TCI, and all the states control society coordinating. And then when the first initial rush of trying to send the medicines was with the program managed that, then came the data recording and reporting. And we did modify a lot of our MNE functions in the IMS and SOCH. of patient portability, providing drugs in the transition. The most critical was we gave the freedom and the autonomy or the responsibility in decision making to the states to develop local strategies and tailor-made solutions. The situation across states and districts was different, and we gave them that please explore all possible ways of drug dispensation, online counseling, telemedicine guidance, ICs through social media apps. These were all the emergency measures, and we gave the states the freedom to manage their epidemics. Emergency relocations, there were requests coming in, and there had to be coordination with SACS Plan India and TCI teams. Patient grievance redressals. Some of the patients were writing directly to the senior most leadership, and we were responding to each and every, not only those who wrote to the senior leadership, but also about those whom we even received information either from the patients on the WhatsApp groups, phone text messages, all grievance we tried to redress. Some of the major challenges, like we've already said, and depleting stocks at state level, because we told this give multi-month dispensation. So these were the evolving issues which the program had to continue to manage. Some of the actions I'm trying to show you capture across the country what are the different ways in which states came up with innovative ways of managing. And all of us know, in a crisis situation, when I'm sitting at home, I do not know where I'm going to get my drugs from. Information provision and real-time and timely information was the most critical component. And I think the modern technology helped us to respond to the provision of that information. There was an ART Mitra app developed in Ahmedabad, where you could get information about where is the nearest ART center or the refill center where I can get my drugs. These are some of the images captured when home delivery to PLHIV in red zones happened to children. These are some of the measures taken by the ART centers and the facilities of social distancing, reaching out. And in all this, we maintain confidentiality of the patients. I think the common understanding was at any cost, the status must not be revealed if a patient doesn't want it to be revealed to the family and the community. Again, there were daily monitoring happening of the situation, and states were finding their own situation. These are some of the snapshots. Even staff used boats where there was no other transport. Some of our staff used bicycles, scooters, as you can see in this picture. Everybody rose to the occasion, and each and every person has contributed to our country response. Partnership with the coordination partner, wherever the partners were available, there were no questions asked. Everybody worked as one team, and I'm really thankful to the leadership of the SACS, where they allowed that this can happen, and patients, even ration was distributed by some of the partners to the needy key populations. So what were the lessons learned? So what worked for us was a patient-centric approach. Making sure PLHIV get their drugs was our common goal. Real-time information sharing and issue resolution. Open and transparent communication among the stakeholders at national, state, and ground level. Use of technology, virtual platforms for teleconsultations, program monitoring, capacity building. And what also worked for us, they were PLHIV taking initiatives and risking the lockdown to go get their ARV drugs. This was an encouraging and motivating factors for all of us trying to make sure they get it. Keeping our staff out and outreach workers and community informed and motivated also worked for us. Leadership and commitment of NACO and SAC senior officials. All possible support was provided by the development and technical partners wherever they were present. Last but not the least, I would like to acknowledge the active involvement of the PLHIV community, volunteering to take ARV drugs. We received phone calls saying, I want to help. I want to know how I can help. So this was a really, really, moment, a proud moment for us, I think, for the community also. The community was also monitoring the ARV provision to patients across the country, and informing the senior leadership at NACO of the feedback received from the patients. And when we talk about way forward and adapting to the current scenario, we know that situation is not same across the states and across the districts. So the program is going to take a flexible and conservative approach to transitioning PLHIV back to their parent ART center. We are as it is, differentiated care models worked for us, and we are going to focus further decentralization of ARV drug refills from care and support centers, targeted interventions, and OST centers. And the program is transitioning into dolutegravir-based regimen, and the focus going forward will be on lab investigations, CD4, viral load testing, and better clinical monitoring of the patients. Adapting to the new normal, telemedicine has come up in a big way in our country. It has helped us manage the COVID response when people could not travel. And it involves delivery of healthcare services in the interest of advancing the health of individuals and their community. These are Board of Governors guidelines, where distance is a critical factor, using this for diagnosis and treatment, and also for the continuing education of healthcare provider. So the program has adapted 4 basic types of telemedicine was available in the guidelines, and NACO has adapted this in the context of HIV care. And we have just received approval for piloting a few models at the Centers of Excellence, Pediatric Centers of Excellence, ESASF and LAC. Proposed expansion across the country based on the evidence of the pilot, the program is to expand it across telemedicine across the country for use at the ART centers, for managing services during calamities, disasters, and difficult scenarios. I would like to end my presentation here. Some of the new initiatives will be later subsequently during the day. And thank you very much. And over to you, sir. Ma'am, Dr. Selina, ma'am.
Yes, yes. Thank you, ma'am, for a very descriptive and very crisp presentation, especially during the provisioning of ARV to the PHLVs. The guidance note which we got for this text was very timely. It was very to the point, so that there was no confusion across the states also how to go about. And the intervention by the Plan India and the TCI worked beautifully, because there were certain states like us, we didn't have the third line drugs. We had a problem about viral load testing because we were very much dependent on Mumbai. So these things came so very timely for us, and for, I'm sure, for the rest of India as well. It was very well thought out process. And now, as you have just mentioned in your presentation, what you look forward, because pandemic may continue. So we need to sort of strengthen the little gains that we have made, especially like provisioning for multi-month dispensation or transition to the other drugs as per the availability of the drugs. So all this was so much adaptive, and telemedicine definitely is the way. And as of now, we are sort of being comfortable doing online things. So even monitoring the programs also may happen in a very online mode. And so thank you, ma'am, for this presentation. So going forward, thank you. Yeah. Going forward, we'll take on the next speaker, Dr. Rachna Mitra, Project Director for Plan India. The topic is India's journey towards elimination of mother-to-child transmission, and how civil society partners are complementing the national program of EMTC. Over to you, ma'am.
Good morning, and good morning, Dr. Gomes. Thank you for the opportunity. My screen is visible to everybody?
Yes.
Yeah. So once again, thank you to Aidscon for providing the opportunity. I just want to briefly highlight the work that Plan India is doing in collaboration and complementing the national program of elimination of parent-to-child transmission. So this is the second phase of our program. We started off with in 2015. This is a grant from the Global Fund for TB, AIDS, and Malaria, and Plan India is a principal recipient. So we are in the second phase of the program, and we have, the second phase is started from 2018 January and is going to end this month. And we will be continuing with the third phase starting from April. And as we know that Government of India is mandated to achieve elimination in the next 2 or 3 years. And Plan India is very grateful and happy to partner and complement the national program in its efforts. So we have 3 components in the project. First is Project Ahana, which is, Ahana means the first rays of the sun, which Plan India and the national program sees as an opportunity for elimination of parent-to-child transmission. In the project, the focus is on increasing the uptake of services for PPTCT among women in the most marginalized communities in India. Currently, we are across 357 districts in 14 states. We basically work in the northeastern states and UP, Bihar, MP, Odisha, Jharkhand, and Chhattisgarh. And the other part of India is the program is implemented by the other partner. We also have a component of the supply chain strengthening project. It was very heartening to hear, Dr. Gomes, from you that during the pandemic, the TCI and Plan India were successful in ensuring that there are no stock out of life-saving ARV drugs and to some extent testing kits as well. The project offers comprehensive technical assistance to strengthen supply chain systems for NACO and SACS. And through TCI, it also provides the third-party logistics services to ensure uninterrupted supplies of ARV drugs and testing kits to all ARTC and ICTCs across the country, to basically meet the goal that the national program has adopted to test and treat all. And the third component, which will end by this March, is the building the capacity of the peripheral workers like ANMs and the counselors in the SACS, which is being done by the Tata Institute of Social Sciences as a partner. As I was just saying, Project Ahana is Ahana means the first rays of the sun. And this, I'm very proud to present this slide, the contribution of Ahana project towards attaining AFDCT by NACO. From 2015, when the project was initiated, 37 million pregnant women have been tested, that is screened for HIV during their antenatal checkup. 16K positive pregnant women have been cared for in the sense that linked to the ART treatment, and 12K babies born to positive mothers have been cared for. Just to give you an idea of the numbers, 12,049 HIV-exposed babies have received DBS HIV confirmatory testing, out of which 565 babies have been confirmed positive, and 4.61% babies are found to be positive. This is in our geographies, where the states where Plan India is working. And happy to say that 5,564 babies have been confirmed as negative after 18 months confirmatory testing. If you see the HIV positivity rate among HIV-exposed babies, that is EID plus 18-month confirmatory testing, consistently it has been coming down from 8.28% in 2017 to 3.15% in 2020. And these statistics give us the confidence that along with the national program and under the guidance of NACO and the SACS, we will achieve elimination in the next couple of years. And we are very confident about that. Just to give you a little bit about the program, some of the strategies that have been adopted is basically, as I said, through the Saksham Prerak project, capacity building of ANMs, periphery level testing, because we are all aware that the key to elimination agenda is the provision of the screening at the women's doorstep. So basically, what we have been doing is saturation of all PHCs with HIV testing services, availability of HIV testing at subcenter in small states like in the Northeast, and availability of HIV testing at monthly village health nutrition day. We have also strengthen the FICTCs and the BHND reporting in SIMS, because that has been a major gap area in the national program. And we have been doing ANC health camps to address the gap between estimated and identified positive pregnancy. And of course, ensuring HIV testing through the national program of Pradhan Mantri Surakshit Matritya Abhiyan, which is the national flagship program. We have also kind of established a single window outreach to facilitate linkage of positive pregnant women to treatment and adherence of the same. In the two northeastern states where the prevalence is pretty high, Meghalaya and Nagaland, successful advocacy has led to establishment of new ART centers, because all of us are aware, the dearth of ART centers in Northeast and also in the northern states. And of course, with the other partner, we are also addressing constant migration of positive pregnant women, positive mothers and their spouses. I won't go into the details of the case study, but when we started working in Uttar Pradesh, which has the highest pregnancy ratio in India, from 2015 October, when the project was initiated, to March 2020, Uttar Pradesh has shown an increase in HIV screening among pregnant women from 15% to 78.7%. After which, COVID pandemic, obviously, as it has affected all programs, it also affected our program, and it dipped to 67.6%. But we are constantly trying to increase the number. And if you see 2015-16, 8 lakhs pregnant women were tested. 18-19, the same has been reported as 27.3 lakhs. 19-20, 52.3 lakhs. And 2021, from April to November, it's 30.8 lakhs. And this dip is basically due to the COVID pandemic. 17,985 ANMs and 1,437 staff nurses have been sensitized and trained on how to do a whole blood fingerprint testing. State-specific standard operating procedures for BHND level HIV testing was developed. There has been increasing, participation in the preparation of the NHM PIP, where procurement funding of small pool boxes and other things to increase screening has been procured. Additional budget has been provisioned for alternative vaccine delivery under VHND, and trainings have been done for the block program managers and the district data entry officers on SIMS reporting, which has been one of the areas which we have been told to support. In Meghalaya also, we started the operations from January 2018. And, as to address low HIV testing of pregnant women, all NHM LTs and few senior ANMs have been trained. There was only one ART center in Shillong in the whole state. And because of continuous advocacy and of course, a lot of efforts from NACO and SACS, there are 2 new ART centers now, one in Jaintia Hills and one in Garo Hills, which has really helped the screening to go up. As we all know, the second component that we have been working has been the supply chain component. Basically is the objective is to provide third-party logistics service to improve delivery of ART drugs and test kits at facilities level. The project also provides technical assistance to NACO and SACS to strengthen the supply chain system and improvement of reporting and support on the electronic learning management systems for informed decisions, so that the forecasting is done right, and there is no stock out of drugs or testing kits in the various centers across the country. Just to give you an idea about it, the geographical coverage is pan-India, and the distributions are happening, and the performance is generally above 95%. During the COVID pandemic, Dr. Maninder has already shared, there was no stock out anywhere because of NACO's continuous support, and the project has been totally committed to delivering the services. In Project Ahana also, I don't want to repeat too much, but emergency passes were facilitated for our outreach teams by the SACs and by the district administration, so that they could go and hand deliver ART medicines to the positive pregnant women and to the general clients also, so that the adherence is maintained. These are some of the initiatives under the project: strengthening of supply chain processes through development of a standard operating procedures. It has been approved by Honorable JS Sir, and it is, the trainings will happen for the SACs and it will be in full use. And the capacity building of SAC staff on SCM operations, the electronic learning management system is also almost up and running. It should be starting in the next few months. These are some of the pictures just to show you: strengthening of storage infrastructure in the SACs, distribution of test kits through cold chain mechanism. And as I said, the other component has been the project Saksham Prerak, which is basically training the ANMs and the counselors in the various SACs. We were doing classroom trainings for counselors, but unfortunately, due to the pandemic, with NACO's intervention, it has been shifted to an online module, and almost, 7,000 counselors have been trained across the country. And the last batch is going to start from next week. The project formally comes to a close on 31st March. And, 9,000 ICTC STI counselors were supposed to be trained, but, the numbers we got were only around 7,500. 30,000 ANMs have been trained, and 15,000 PHCs have been transformed as facility integrated counseling and testing centers. So here, this is my last slide, and Plan India, along with NACO and the various SACs where we work, is committed towards the National AIDS Control Program goal to achieve the end of AIDS by 2030 and the goal of 95, 95, 95. We reiterate our commitment to complement and continue working with the national program to eliminate mother-to-child transmission, not only through Project Ahana, but by strengthening the supply chain system and by the involvement of the trained ANMs and counselors across the country. Thank you so much for your attention, and thank you once again to Aidscon for providing the opportunity. Thank you. Thank you, Dr. Gomes.
Yeah, thank you, Dr. Rachna. I have been listening attentively to your presentation, and it's very nice to know that Project Ahana has impressive gains, like from HIV positivity in pregnant for the infant exposed to HIV has come down from 8.1% to 3.15%. And of course, this is also with the aim for eliminating the mother-to-child transmission, which was actually supposed to be by the year 2020, but COVID-19 had other plans for the NACO program. So again, at the level of supply chain management, your performance and coverage has been very impressive, ma'am. Up to 95% was the coverage of delivery of all the supplies needed for the NACP programs across the various states in India. And of course, the Saksham project capacity building has been going on very well. You have been training the ANMs, and you have, you managed to transform the ANMs training into PHCs who are doing the HIV testing and their own and reporting to NACO. That's a very nice thing to happen. Besides that, I was also impressed by how you have overcome the challenges which are happening in the northeastern states by having more ART centers, and in the UP where the rate of pregnancies are very high, and how to increase that HIV testing from 15% to 17%, which will go a long way to the final goal of eliminating mother-to-child transmission. If anybody has any question, maybe you can put it on the chat box, or we can review at the end of this session. Thank you, ma'am, once again.
Thank you. Thank you, Dr. Gomes. Thank you so much.
Okay, over to the next speaker for today, Dr. Melissa. Welcome, ma'am, for
Yes. Yes.
your topic for is mitigation strategies during the COVID to maintain the HIV gains towards epidemic control. Over to you, ma'am.
Thank you, Dr. Gomez. Is my screen visible?
Yes, ma'am, it
And
is.
is it in presentation mode, or should I swap the
No,
screen?
it is, ma'am. It's in
Okay,
presentation mode.
great. Thank you so much. So thank you, everyone, and it's my pleasure to be here today on behalf of PEPFAR and our CDC team to speak on behalf of mitigation strategies to maintain the gains. It's been over a year since we first learned of the novel coronavirus, and as I mentioned in my opening remarks, now widespread, COVID-19 has impacted the world over and has caused widespread disturbances. However, around the world, innovative strategies and committed governance has really shown the way to maintain the gains and build back despite the incredible challenges. I think is my camera on? I don't think it is. I don't know if I can
No,
turn
ma'am,
it
you
on.
please switch on your camera, please. Thank you.
Sorry, I might just have to stop sharing
Yeah,
for a
please do
moment.
that.
Okay, sorry. One moment, please.
Sure.
Apologies. Too many buttons here.
No worries, ma'am.
Okay,
We can see
I'll
you now.
share. Okay, sure. Sorry about that. Let me just go back and share. Okay.
Perfect.
Are you seeing the screen?
Now you need to swap your screen.
Okay, sure. Oops.
Yeah.
Okay. All right. Thank you so much. Sorry for the.
You need to click on the swap, ma'am, once. Just click it once. Yeah, perfect. There we go.
Okay. So, as I was mentioning earlier, however, around the world, innovative strategies and committed governance has really shown the way to maintain the gains and build back despite incredible challenges. India has really been a leader in getting out in front of this pandemic, and as part of PEPFAR, CDC with our sister agency USAID, we work with 12 other countries in the region, and I can tell you honestly, many of the other countries in the region has really looked to India to best understand how India has done all of this in such an effective way. So I'll briefly go through some of the key factors and some examples of innovations, mitigation strategies with clear policy directives, framing the response, how to reduce the risk of transmission of COVID among clients served, protecting the gains through receipt of life-saving ART, but with limited interaction with busy facilities where COVID transmission could be high, and also the incredible coordination among stakeholders, which has been mentioned by prior speakers, which really was the key across this incredible response. As Dr. Maninder mentioned, the government of India proactively organized a consultation of stakeholders and community to ensure uninterrupted ART services early in March. These rapidly liberalized policies were really unseen across the region. And again, as I mentioned, we work across 12 countries in the region. So we were looking at how other countries were responding as well. These liberalized policies eased the scale up of key strategies. And with this in mind, and the government of India really on war footing, they initiated the toll-free helplines to accommodate queries from the public, other strategies on infection prevention control and airborne infection control, liberalized multi-month dispensation policies, including clients who were previously identified as unstable, who wouldn't have otherwise been eligible. The expanded location of drug dispensation in the public and community setting was critical, with a special emphasis on commodity supplies, as just discussed by Dr. Rochana, especially to key populations. I also want to highlight take-home dosing for OST. This was really a game changer in the Northeast, where CDC works in Manipur, Mizoram, and Nagaland. ART services were considered, as mentioned before, part of essential health services under the Public Health Emergency Situation communication issued by the Ministry of Health and Family Welfare. Taken together, these were clear, strong decisions taken by the government early in the pandemic and really helped frame and stand up all the innovations taken at the state and district level, which I'll discuss. With the guidance, one of the early questions was, how do you get the response out quickly? And now, a year into this pandemic, we say, of course, we're using Zoom platforms or any platform. We've probably all been on 3 or 4 different platforms. We're also familiar with these platforms. But early on, really, it was a question of how do you use what's already there? And the ECHO platform was very helpful early on. With NACO, CDC and implementing partners led the dissemination of COVID-19 guidance to the National AIDS Control Program facilities and saturated more than 70% of facilities catering to 2,500 NACP staff within 15 days in 14 batches. This was quick and got the message out. The map shows the states in India and the number of program facilities zooming into these sessions. IPC, or Infection Prevention Control, was high up on the agenda to prevent transmission, and the trainings were delivered in local languages. While the training was initially planned for ART centers, we can't forget all the prevention sites, and OST centers as well as managerial functionaries were added on at the district and state level. Again, we can all say that the use of virtual platforms like this brought us close like today, and even though we're separated by distance, we're still able to share. This slide just demonstrates the immediate change in the practices right after this particular messaging went out. And I'm sure you all have pictures of this from your own ART centers, the practice of social distancing, wearing face covers, hand hygiene, changing seating areas. These are pictures from Andhra Pradesh where we work, but there are many other examples as shown by Dr. Maninder earlier. I also want to say that pre-COVID, a good infrastructure for decentralized ART delivery allowed for rapid scale-up. In AP, one of the geographies where PEPFAR and CDC works, we've worked with AP SACs on scaling multi-month dispensation, decentralized ART, and CSO-led ART dispensation. The groundwork helped the state quickly adapt in COVID-19 with early and rapid adaptation of systems to ensure uninterrupted supply of ART. And this is where we start thinking about going forward, exercising convergence. Where there's good decentralized options available, quick implementation of the NACO recommendation for community ART could be done. In the panel in the upper left, this is in Andhra Pradesh where during successive lockdowns, there was a scaling of decentralized ART at PHCs, urban health clinics, TIs, CSCs, and through linked worker schemes. In fact, at the height of the pandemic, nearly 1/3 of all clients were receiving ART from upwards of 326 new ARV pickup points, in addition to home delivery. We also carefully followed the outcome for stable and unstable clients on multi-month dispensation. Among stable clients, 95% did return for their pill pickups. But I want to tell you, even unstable clients that otherwise wouldn't have been eligible, 89% of them did return for their second pill pickup, which in and of itself is great to know that we can perhaps continue to liberalize these policies with close follow-up. Active tracking and tracing is always critical, and clients who didn't return for their pill pickup are continuing to be followed. I also want to highlight community ART refill groups, which was an innovation pre-COVID used in the Northeast states where we work, where stable clients who are willing to disclose their status to each other form groups with support of the facility and rotate who picks up the medications on a cycle, either 3 months or monthly cycle, depending on what the group is doing. And the entire group or cohort attends the facility when they're due. This approach was merged with decentralized pickup points during COVID to ensure delivery to the most remote locations. Next, Dr. Maninder mentioned ART Mitra. So I'd like to really highlight this. This is an interactive voice response system from MDAX and led by Dr. Shrikala. Here, the CDC and implementing partners, we worked together with MDAX during the lockdown, where the lockdown itself, as with many parts of the country, led to the dislocation from the ART center for many people living with HIV. Interactive Voice Response System, or ART Mitra, was rolled out with widespread visibility in the press, which is really critical, shown on the right. PLHIV who missed their appointment received a short text in vernacular with a helpline number. The helpline prompted PLHIV to answer questions about their location and how likely they would be to reach a nearby distribution point. this schema here really shows the idea. So the slide shows the process of the voice response where the center sends out the SMS with the helpline. The client is able to provide location and likelihood to reach a nearby center, and the data reaches the ART center, whereby program assistants then call the client with a warm line using the data provided to arrange dispensation. The dispensation also includes an offline mobile app-based web form, an M&E component, whereby there's real-time stock updates since the client is receiving medication not from the parent ART center. This allowed for rapid stock updation throughout the project. What was the impact? Well, where SMS notifications went out to 13,000 PLHIV, 1,500 responded with 87% collecting their ART. Using the call data, 13 additional ART dispensation sites were set up in nearby districts of Thane and Palghar, and over 1,300 clients collected their pills as mentioned. But importantly, these 13 new sites led to the support of an additional 1,660 PLHIV who actually didn't call the helpline. So again, an impactful approach to reach PLHIV during the lockdown. I want to mention about coordination. Coordination at the district and sub-district level was really critical in mitigation during the pandemic and continues to be. The government of India requested that states transport drugs and use the DAPQs for coordination. CDC supported the DAPQs with a focus on site-level technical assistance in AP and across all 13 districts. We introduced the concept of an incident management system where the DAPQ leads as the incident manager. The DAPQs were oriented on their role in the IMS structure and expanded the IMS structure to include staff from different programs for a more coordinated response. This approach of IMS was instrumental in addressing supply chain, transport of drugs, and working across partners, as mentioned. Coordinating and ensuring clients receive services really was really important with a real need for help from the community. With successive lockdowns, it became increasingly critical to ensure all stakeholders were coordinating and working together. In the Northeast, in the states of Mizoram, Manipur, and Nagaland, where CDC works, this took the form of an engagement of coordination with community groups, law enforcement, SACs, and also having an emergency case management response for challenging cases. Critical implementation in the field, again, bolstered by clear policy decisions from NACO, including take-home OST, was critical. Additional field innovations included ensuring commodities reached key populations, included same-day OST, field staff acting as OST distribution points, doorstep delivery, adapting night shelters for female injecting drug users with social distancing norms, and coordinating prevention and treatment teams so that all services, including ART, could be delivered in a single visit. The community input continued to be critical to update the needs. So finally, in my last slide, I just want to say in summary, the work to maintain the gains started with looking at the implementation needs that were really under duress, but allowing a nimble and resilient approach with clear policies as NACO provided, continuing to look at the barriers for access and seeking community engagement for solutions, all to ensure the continuity of care for people living with or people at risk of HIV. In doing so, having a 360-degree approach to reduce the exposure of staff and clients to the healthcare setting was really a critical step. COVID-19 posed really unique challenges, but the decisive, resilient, and community-informed adaptive approaches continue to be the key in confronting the pandemic to not only maintain the gains, but also accelerate the work to achieve epidemic control. So again, thank you to the organizers and thank you for the opportunity to speak today.
Thank you, Dr. Melissa. That was an overview about how the mitigation strategies were undertaken during the COVID pandemic, especially with the aim not to let go of the gains that we've done all these years through your organization. Of course, I would, again, though we had the earlier guidance note on the ARV drugs, OST came a little later, but we did, it was very timely so that, that those gains also could not be let go. Infection control practices among the staffers as well as for the clients was also very important so that, we could take care of PHLVs being vulnerable to COVID was another issue. It was very timely and important to adhere to all the norms of to decrease the transmission of COVID among the clients. Another high point that you did mention was the ART Mitra, which was rolled in by the MDEX, very innovative, especially because Maharashtra was like, totally taken over by the COVID pandemic. And it is really commendable that they had to work through such innovative means to get there. I mean, they just could not let go of the clients who were on ART medications. So this, congratulations to Madam Srikala and I think because COVID is as such not going to end in the near future, and maybe in the inaccessible states or hard to reach areas, this could be sort of replicated in other centers as well. So this will go a long way to reaching out to these unreached populations. Coordination from different agencies was a high point to get to not to let go of the gains, especially the law agencies. Then again, real-time management of the stock position, that was also equally important so that we don't adherence is not affected. So this also would be like in the aim of the third 90 that we had in mind. So thank you, Madam, for your valuable inputs and sharing all what your organization contributed.
Thank you so much. Thank you so much. Thank you.
Thank you. Okay, going to the next topic, I welcome Dr. Alexandra, WHO. She'll be talking on WHO's role in facilitating realization of the common goal to end the AIDS epidemic as a public health threat by 2030. Over to you, ma'am.
Thanks very much. I do not have a PowerPoint, just so you're not looking for one. And I just wanted to say that this technology that MDEX developed for PLHIV perhaps could be replicated not only for HIV in other states, but maybe other diseases as well. As the team leader for communicable diseases, I see possible applications, for example, to neglected tropical diseases or TB or other diseases. It looks like a wonderful system that they developed, and maybe they shouldn't keep it all for themselves. So. Okay, so I've been invited to speak on WHO's role in facilitating the realization of the common goals to end the AIDS epidemic as a public threat by the year 2030. As you probably know, WHO is the United Nations Specialized Agency for Health. It is an intergovernment organization and works in collaboration with its member states, usually through the Ministries of Health. The World Health Organization is responsible for providing leadership on global health matters, shaping the health research agenda, setting norms and standards, articulating evidence-based policy options, providing technical support to countries, and monitoring and assessing health trends and threats like COVID. India became a party to the WHO Constitution right from the beginning in 1948. The first session of the WHO Regional Committee for Southeast Asia was held in October 1948 in the office of the Indian Minister of Health. It was inaugurated by Pandit Jawaharlal Nehru, the first Prime Minister of India. India is a member state of the WHO's Southeast Asia region, and the WHO country office for India, where I work, is headquartered in New Delhi with a country-wide presence. During the last decade, we have experienced major scientific breakthroughs, new political and financial commitments, and remarkable achievements, saving and transforming millions of lives across the world. However, despite all these achievements and successes, we have also encountered several challenges, including the raging COVID-19 pandemic. We have unfortunately missed the fast-track targets for 2020, and we are not on track to achieve the 2030 global elimination targets for HIV, viral hepatitis, and sexually transmitted infections. WHO remains fully committed to facilitating the realization of the common goal to end the AIDS epidemic as a public health threat by 2030. At the global level, during the last decade, WHO was closely involved with the achievement of many memorable moments witnessed by all of us. These encouraging examples bring renewed energy, inspiration, and commitment for all of us at WHO for the new year 2021 and for the next decade until 2030. Here are a few examples of WHO contributions at the global level. At the beginning of the last decade, in 2011-2012, WHO and partners brought renewed focus to the challenges of HIV epidemics among key population groups, including men who have sex with men, people in prisons, people who inject drugs, sex workers, and transgender people. Evidence was renewed and communities were consulted in preparation for the launch of new consolidated guidelines on HIV prevention, testing, and treatment for key populations in 2014, which were updated in 2016. 2015 was the target year for achieving the Millennium Development Goals. The targets for MDG 6 to combat HIV and AIDS that once seemed unattainable became a reality. By the end of 2015, 17 million people were receiving HIV treatment compared to just 685,000 in 2000, confirming that the MDG target to put 15 million people on HIV treatment by 2015 was successfully achieved. In 2015, WHO launched a process for validating the elimination of mother-to-child transmission of HIV and syphilis in countries. Cuba, a trailblazer on this issue, was declared the first country to achieve the elimination criteria. At the end of 2019, 13 countries and territories have been validated by WHO, including the Maldives, Sri Lanka, and Thailand from this region, most for eliminating both HIV and syphilis. There are more countries now working to achieve elimination of mother-to-child transmission of dual or even triple epidemics combined with hepatitis B virus infection. Following scientific evidence presented in 2011, WHO announced that HIV treatment also prevents transmission of HIV in discordant couples, where one partner has HIV and the other does not. When an individual with HIV is receiving effective antiretroviral therapy, the risk of HIV transmission is reduced by as much as 96%. In 2015, WHO released full guidance that removed all previous restrictions on HIV treatment eligibility to recommend treatment for all people living with HIV. This step further contributes to reducing stigma and discrimination within communities and empowering people living with HIV to achieve improved health and well-being. By the end of 2019, 95% of all low and middle income countries had adopted WHO's policy to treat all people living with HIV. WHO has placed innovation as a major pillar in its strategies to achieve the elimination of HIV, hepatitis, and sexually transmitted infections by 2030. In 2012, WHO issued guidance recommending pre-exposure prophylaxis, or PrEP, as a powerful prevention measure for people not infected with HIV. In 2016, HIV self-testing guidance was released to expand the reach of HIV testing services and empower communities to know their HIV status. Since 2017, WHO has been promoting the multi-disease elimination approaches, including integrated and differentiated service delivery, integrated diagnostics, and strategic information systems and people-centered approaches. Over the past decade, we saw some alarming signs of increasing drug resistance to treatments for HIV, tuberculosis, and gonorrhea. WHO has developed early warning indicators for HIV drug resistance, issuing reports in 2012 and 2017. The latest data from 2017 showed that half the surveyed countries experienced HIV drug resistance levels above the WHO recommended threshold. Also in 2017, WHO raised the alarm on the increase in drug-resistant or untreatable gonorrhea in many countries and advised intensified prevention efforts. These measures are central in the global efforts for disease elimination by 2030. Now for some WHO contributions specifically here in India. The WHO Country Office has been actively involved in various aspects of the national response to HIV and AIDS right from the beginning of the epidemic in the country. At the national level, the WHO team works very closely with NACO, the state AIDS control societies, regional institutes, key national stakeholders, other development partners, NGOs, community-based organization, and community members in implementing the National AIDS Control Program and progressing towards the achievement of the common goal to end the AIDS epidemic as a public health threat by 2030. WHO provides strong technical support to NACO in implementing all the key national surveillance activities, including HIV sentinel surveillance, behavioral surveillance survey, biobehavioral surveillance, mapping and population size estimation. Also, along with other partners, WHO supports NACO in implementing HIV estimation and projection exercises at the national, state, and district levels. In preventing new infections among the general population, NACO is working on various fronts, including information, education, and communication, youth interventions, mainstreaming and partnership, elimination of stigma and discrimination, management of reproductive tract infections and sexually transmitted infections, blood safety, and laboratory services. WHO provides technical assistance in many of these areas. We are also working with NACO and other partners in revamping the targeted intervention model for preventing new infections among high-risk groups and bridge groups. The TI model was originally developed in the early 90s and found to be inadequate in the context of the changing dynamics of the epidemic and functioning of the HRGs and BGs. Many new and innovative elements are being integrated into the revamped TI model, TI 2.0. These key elements include differentiated prevention approach, navigation strategy, index testing, community-based screening, secondary distribution of needles and syringes, satellite OST centers, community-based ART dispensing, and multi-month ART dispensing, among others. The WHO team was involved in critically reviewing some of these key elements in the field. The WHO team provided technical assistance to NACO and SACS in strengthening HIV counseling and testing services, partner testing, and HIV-TB cross referrals. Also, WHO supported NACO in introducing differentiated care model and undertaking Mission SAMPARC to bring back lost to follow-up cases and improve retention. WHO is working with NACO and other partners in scaling up the viral load testing across the country, also strengthening laboratory quality assurance systems. EMTCT is one of the top priority areas for us to support NACO and other partners. Our team is working closely with NACO in increasing testing and treatment coverage among pregnant mothers and improving early infant diagnosis in the future. We are working collaboratively with NACO and other partners in rolling out several other new initiatives like HIV Sentinel Surveillance Plus, mapping and population size estimation for virtual key populations, case-based surveillance, mortality surveillance, incident surveillance, and others. Similarly, WHO is playing an important role in working with NACO and other partners in finalizing various policy and technical guidelines on PrEP and pilot testing different approaches for the HIV self-testing in the field. So this has been a brief summary of WHO's contribution to facilitating the realization of the global goal to end the AIDS epidemic as a public health threat by 2030. On behalf of WHO, I thank you for the invitation to make this presentation and wish you great success with this important two-day Aidscon conference. Thank you.
Thank you, Dr. Alexandra. It was indeed a very nice overview about, since a very long time association of WHO with India, as far back as 1948 that you mentioned, that you are definitely having a very good leadership role and in keeping forward the evidence-based approach to the response to the public health threats, just not HIV, but many other public health threats that we are encountering. Now, currently, we are seized with the problem of the COVID-19 pandemic. Of course, the timely guidelines like test and treat policy in 2015 has definitely been a good game changer, especially as far as transmission of HIV is concerned. Initiating the PrEP, self-testing, all these policies will definitely go a long way in towards the elimination of HIV by the year 2030. And specifically for India, the technical assistance that is provided by your organization in the front of conducting the surveys, the HIV, TB cross-referrals, and the elimination of transmission from mother to child, not just of HIV, but of syphilis as well, and hepatitis. All these things definitely will go a very long way. Thank you, ma'am, for your nice talk. Okay. So the next speaker that we have today is Ms. Nandini Kapoor from UNAIDS. She'll be talking on proposal by the CBOs, the CSOs for additional global GFATM grant in the context of COVID-19. This is finance is very much welcome anytime, and definitely it will help the program in a very big way. Over to you, ma'am.
Thank you so much, Dr. Gomes. Good afternoon, colleagues and friends. It's remarkable that in these unprecedented times, we are having the 10th Aidscon virtually and responding to what the current situation with COVID has taught us. We will continue to meet and share, and technology makes it possible, as we can see. Congratulations to the organizers of the conference, NACO and Chandigarh SACS, for the excellent organization of the conference. I'm going to talk about a success story for the communities from India who mobilized $10 million from the Global Fund to respond to the urgent needs of the community as an impact of COVID-19. As mentioned by ASNDG Ms. Aarti Ahuja this morning, India is a success story on how we have handled HIV and how we are handling COVID. And the key, as she rightly said, is a people-centric approach. 1 year ago, when we were hit by COVID-19, not knowing what it will be like, how long it will last, and how it will impact the world and us. Though not knowing enough at that stage, the HIV program in India made policy changes very quickly to ensure that services continue to reach the community. For example, OST take-home doses, multi-month dispensing of ARV, community-based testing, etc. And we heard about the examples from the states, from the earlier speakers. To support the program, the community networks and CSOs joined together to reach out to communities with prevention and treatment services. Considering many people had moved from their locations, there were lockdowns, transport was not available, and movement was restricted, as Dr. Maninder rightly pointed out in her presentation as well. While the communities were being reached out with HIV services, the issues that the community was facing on the ground was of livelihood, food ration, and also shelter in some cases. We have examples from across the country where during peak periods of COVID, the community was out there on the field, mobilizing donations, using their own resources to deliver food ration packets to families of those in need. The immediate crisis had to be addressed, but it was not enough. More support was needed as the impact of COVID lasted not weeks, but months, and now a year already. UNAIDS with other partners mobilized from the private sector support to provide PPE to field workers and communities who were fearlessly out there on the field. Efforts were made to access social protection schemes of the government. However, as we know, that's not always easy, as the communities we work with may not have the required IDs or documentation to access these schemes. Global Fund had announced the COVID Relief Fund. Civil society organizations and community groups of key populations advocated for financial resources to Global Fund under the COVID-19 Relief Fund. An appeal for urgent social protection services was endorsed by 10,000 communities from India, representing key populations as well as people living with HIV and submitted to the Global Fund board. The Global Fund in a record time approved the $10 million grant for key populations and people living with HIV and asked for a proposal to be submitted outlining the immediate needs in this difficult period. The country coordinating mechanism of the Global Fund, the country coordinating mechanism of India, endorsed the grant and asked the networks of the communities to work on a proposal which could be submitted to the Global Fund. The networks, which included key population groups and people living with HIV, they put in place a consultative and a participatory process involving communities as much as possible from the length and breadth of the country and discuss the needs of the community on the ground. The National AIDS Control Organization and UNAIDS supported the networks in taking forward the process with technical support and a writing team to write the proposal to be submitted to the Global Fund. The Global Fund grant was to be directed towards social protection, primarily food ration support for communities most in need. As we know, the HIV program and the communities are not really geared to put in place social protection measures such as food ration provision or cash transfers at that scale. Many aspects needed to be considered to ensure that the support is directed to those most in need and implemented smoothly. Practical aspects of how it will be delivered needed to be considered. These discussions were steered by the KP network leaders until they found answers and solutions which were feasible. These conversations took few months before a proposal was actually prepared. Consultations with national health authorities took place to ensure that the proposal will be developed closely with the National AIDS Control Organization and be able to reach communities using all possible systems in place, including the targeted interventions. The proposal was submitted to the Global Fund last year to be implemented through two existing principal recipients, that is SATHI and HIV Alliance. However, the communities will be steering the implementation through a coordination mechanism to ensure close monitoring and effective implementation. The Global Fund has approved the proposal and it is ready for rollout. And as we speak, the community organizations are pulling together coordination arrangements and discussing amongst themselves the rollout plan for the grant. This is a global best practice of community advocacy effort, resulting in a mobilization of USD 10 million to support a plan of action which will be implemented by community-based organizations to address the urgent needs of key populations and people living with HIV during the COVID-19 pandemic. And the first time probably a grant such as this is being provided to be fully managed and implemented by the communities. What are the lessons that we learned? The year with COVID-19 has been and is still difficult. However, we all agree that in most difficult times, we come out stronger if we are in it together. The solidarity demonstrated by the community in this time was exemplary, and how all the groups stood by each other with only one objective: extend support to those in need. COVID-19 has derailed progress towards the Sustainable Development Goals, including those related to health, HIV, and socio-economic advancement. However, it has also offered an opportunity to respond to equality, to build stronger and resilient community systems with a focus on collaboration and solidarity. Finally, in the face of an unprecedented situation, communities, government, partners have all worked together to leverage the HIV infrastructure and lessons learned from HIV. COVID-19 remains a crisis that threatens the impact and gains of HIV response. So we need to remain vigilant and continue to work together to tackle the dual epidemic. Thank you all for your attention and this opportunity to share a global best practice where communities have raised these resources, planned, and will be involved in the implementation, will monitor and ensure that what is needed reaches the communities most in need. Thank you so much for the time. Over to you, Dr. Gomes.
Thank you, ma'am. It's very heartening to know that there is a concrete solution to the problems like the HRV, the key populations are facing. All the states were like totally taken unawares, though we made all attempts to give the consumables pertaining to the NSCP program. But this social protection became an area that we could not do anything proactively. So the proposal coming from the community and the government of India and the UNAIDS working together to form a policy and roll out the funds, it's very commendable, and it will definitely mitigate the sufferings of these marginalized groups, I must say. And definitely the program, the rollout that you are planning, the coordination that is required, it's a program like it's having a very bottoms-up approach for the community, by the community, and definitely I'm sure it will be very successful and very timely at times such as this. Thank you, ma'am. So coming to the next topic, the next speaker is Dr. Varsha Gupta, MD, Professor, Department of Microbiology. Please, Dr.
Ma'am, we have Dr. Bilali first, ma'am. Dr. Bilali will be the first, ma'am.
Let us go to Goa. Correct.
Okay. So our
Thank
next
you.
speaker is Dr. Bilali Kamara, medical epidemiologist, UNAIDS country director for India. He'll be talking on building a pandemic-proof AIDS response in India. Welcome, sir.
Thank you, Madam the Chair, and thank you, dear colleagues. I would like certainly to thank all the people who spoke before me in terms of really how the pieces came together, in terms of how we built something which can really be called a success story in India. By choosing this title of Building a Pandemic-Proof AIDS Response in India, I am taking the liberty to drive us through the history of the national AIDS response in terms of its successes and the important recent innovations you have added to it to make it furthermore people-centered and resilient even in this period of COVID-19. Under the NACO's leadership and with the ownership through an active engagement of the civil society and the community, the national AIDS response has made a positive impact in millions of lives in India. From informing, educating, counseling, testing, treating, upholding their rights, their human rights, and providing social protection schemes to people living with and affected by HIV. Meanwhile, high-level technical resources groups for each of the key population groups were led by their members and contributing to the national response through the NACO's supports. Let us look back and see that India was the first country in the world to introduce the social contracting mechanism, where peer delivery models through the targeted interventions are fully supported by the government's financial and technical resources for them to provide HIV care and related services. Today, this is recognized as a global best practice in public health and being replicated by other countries. To announce the AIDS response, it is certain that inequalities and prejudices must be addressed and barriers to HIV and related services removed, and therefore, India has embarked in establishing this environment for key populations and people living with HIV and AIDS and affected by HIV by passing the 2017 HIV Act, which protects not only for the free access to HIV services, but fully uphold the human right of those people. Furthermore, the Supreme Court in India, through its supreme deliberation, has ended the Section 377 of the Penal Code in 2018, making homosexuality legal in a country and in the country, and giving to men who have sex with men their full rights and dignity. Again, in 2019, the Parliament of India passed the Transgender Act, and subsequently, the Minister of Social Justice and Empowerment established the National Transgender Council to attend and address issues facing the transgender people in India. As a result of these actions, important achievements were made in terms of reduction of HIV prevalence among key populations, which varied from 13% among people who inject drugs to 41% among men who have sex with men, to 44% among female sex workers, and to 65% among transgender people. To these successes, we could add critical outcomes such as the important reduction in AIDS-related death and the HIV transmission from parent to children, along the increase of condom use and other prevention measures among all the key populations. When COVID-19 pandemic has started to challenge public health systems and economic activities, countries have decided to implement prevention measures to keep the pandemic under control. Many of them have introduced lockdowns limiting people's movement and social gatherings. These measures have pushed public health experts at NACO to bring together the UN, the civil society, and community to reflect on strategies to mitigate the impact of these measures on healthcare delivery to people who need them, including people living with HIV/AIDS, people who inject drugs, and social consequences on the female sex workers. Among these mitigation strategies, there were the multi-month dispensing of antiretroviral drugs and the take-home doses of OST. Beyond these, the community has played its important role by ensuring that community ARV drugs delivery and using the door-to-door delivery of community refillers, the expansions of a single window approach, and to improve community feedback mechanisms to ensure that stockouts in drugs, HIV commodities, and OSTs are reported to NACO for immediate action and solution. Again, the Supreme Court of India has made a difference in imposing on all the states the duty to deliver free food to female sex workers, and the Minister of Social Justice and Empowerment introduced the same for the transgender people. Again, the community has played its role in this social protection process, as you have heard from Nandini, by mobilizing $10 million from the global funds. A first success story, the first in its nature in the world. Overall, the tandem NACO, Minister of Social Justice and Empowerment, and the Supreme Court of India has made its response resilient in this country, as the provision of HIV services continued and social protection programs were expanded. But this was possible because of the key role played by the community and the civil society. Ladies and gentlemen, the country has done a lot before January 2020, when the 2 cases of COVID were reported for the first time in Kerala state, and has learned and done a lot since January 2020 in responding to the AIDS and the COVID epidemic alike. Now it is time to take a stock and use these lessons to continue to build better and much effective AIDS response in India. When we amplify and sustain these innovative approaches to achieve public health in general, hand in hand, the government, NACO, the civil society, and community there is no doubt in mind that India will fast track the 2020 target and end AIDS by 2030 as a public health issue. Why not expanding it to the tuberculosis by 2025, if not before? I want to thank you again and to tell you there is really no opportunity for us to go back to normal in terms of how we were delivering services, but to really use those innovations which we have really been able to build during the COVID period, and to ensure that we will move from success to success, that we will make sure the theme of this conference toward AIDS-free world will become a reality. I want to thank you and certainly appreciate all your daily efforts at all levels, and we will continue to support your effort, to support your leadership as UNAIDS, and we hope certainly together we will be able to build a better humanity. Thank you very much.
Thank you very much, sir. It's indeed heartening to know that we are gearing up to building a pandemic-proof AIDS response in India, and UNAIDS has shown the way by way of improving the social protection. So this will very much go a long way in mitigating the loss of livelihoods that has happened, and social protection will become a mainstay in controlling the HIV transmission rates in India. Thank you very much, sir. So going to the next speaker, we have Dr. Varsha Gupta, MD, Professor, Department of Microbiology, Government Medical College, Chandigarh. She'll talk on SARS, COVID-2 and HIV-TB, the lessons learned. Over to you, ma'am.
Thank you. Am I audible?
Yes.
Thank you. The other one will have to close the slides.
Ma'am, you need to share your screen, ma'am.
I have shared.
No, ma'am.
Yes, I have done the sharing. I can see the slides.
No. Please, आप वापस आइए. Zoom पे आइए वापस, ma'am. Go back to the Zoom.
Yes.
And now there's a green button at the bottom. Share screen.
Yeah, share screen. I was doing that.
बस click करिए एक बार उसको, ma'am. Yes,
Okay.
now. Yes,
Okay.
ma'am. Yes, ma'am. Perfect.
Okay. Thank
Yes,
you
ma'am.
so much.
Sure, ma'am.
So my topic for today is HIV, TB and COVID, the lessons learned. First of all, I would like to thank the Dr. Vanita Gupta for giving me this opportunity and inviting me for this exciting session on HIV and COVID. Coming to my talk, first of all, HIV, TB and COVID together, they form two sides of the coin. We have HIV, TB in COVID patients versus COVID or SARS-CoV-2 infection in HIV, TB patients. I'll be discussing both of them together. TB and HIV interact biologically in two primary ways. What are those ways? HIV kills immune system cells, allowing the TB bacteria to move from latent to active infection. On the other hand, in the presence of TB, HIV disease progression as well as transmission accelerates. As the degree of immunosuppression increases in people living with HIV, the risks of developing active TB upon exposure also increase. Now coming to TB and COVID-19, TB increases susceptibility to COVID-19 as well as contributing to the worsening of its symptoms. Individuals in a situation of comorbidities having TB with HIV have a very worse prognosis. Both active TB and a previous history of TB seems to be related to an increased risk for the development of COVID-19 as well as for worsening the infection prognosis. While on the other hand, there's still no data regarding the influence of SARS-CoV-2 on the TB progression. There are a number of similarities and differences as can be seen in the table between COVID-19 and TB. Like both of these diseases have overloaded the national health system. They both need rapid diagnosis, awareness. They have associated social stigma with them. There is a lack of knowledge on individuals' susceptibility to both of these infections and lack of data sharing platform. But the investments for TB have taken a setback, while appropriate health surveillance systems are being used to monitor and track the SARS-CoV-2 epidemic. There is a lack of consistent national policy formulation for tuberculosis, while there is a fast adoption of national policies to contain the epidemic of SARS-CoV-2. We all know that World Tuberculosis Day is celebrated on 24th March. So how we can celebrate World TB Day at the time of COVID-19? We know the major common thread linking both the diseases is that they have stressed the healthcare systems. But what is the point to be taken care of? We know that SARS-CoV-2 has two outcomes. Either it can be eradicated, as was the case of SARS in 2003, or humanity will have to coexist with it until a vaccine becomes available and is given to all the individuals. However, TB will remain a long-standing public health problem. So we cannot ignore tuberculosis. And it's the time, as the caption for the World Tuberculosis Day this time is, the clock is ticking. We have to take care of tuberculosis. Key results from the survey done and completed on 1st June 2020 have shown that 78% of the TB programs reported disruption to service delivery during these times, and 85% of HIV programs also reported disruption to the service delivery. Coming to HIV and COVID-19, having HIV does not confer any type of protection against severe manifestations of COVID-19. Several studies looking at ARV or antiretroviral drugs have shown no mortality benefit of them. The risk for people with HIV getting very sick is greatest when low CD4 count is there, people are not on effective HIV treatment, or people with comorbidities like tuberculosis. So if HIV and TB are coexisting, COVID-19 will be worse. HIV and COVID-19, two important points which have to be taken care of while doing the diagnosis. Though usually serology is not resorted to, that is, we are not doing antibody testing for diagnostics. Rather, all of us would be knowing either we are doing a real-time PCR or we are doing a rapid antigen test. But in case diagnostic serological testing is being performed in HIV patients, it has to be taken care of that cross-reactivity between antibodies to SARS-CoV-2 and HIV has been reported. Lymphopenia, which is a common laboratory finding in patients with COVID-19, also occurs in HIV. So it should be noted that CD4 counts obtained during acute COVID-19 may not accurately reflect the patient's HIV disease status. People living with HIV and not on treatment, or whose HIV infection has not been fully suppressed, may be at greater risk of COVID-19. On the other hand, people living with HIV who are not immunosuppressed and or who have no other co-infections or comorbidities are not at increased risk of COVID-19. They are like normal people. And people living with HIV who are not on treatment, who are not virally suppressed, they may have a compromised immune system as such because of the low CD4 count. And in these cases, any type of opportunistic infection can occur, including COVID-19. So there is a correlation between various drugs and immune response, and we have to take care of them in HIV. Out of many pharmacological strategies, steroids are being tried as immunomodulators in order to reduce the excessive inflammation in SARS-CoV-2. The use of immunomodulators should be based on the clinical history of each individual and taking into account the epidemiological characteristics of the local population, because they may worsen tuberculosis sometimes. Drugs with anti-inflammatory functions like tumor necrosis factor alpha are being used. TNF alpha blockers are being used, and they can also increase the susceptibility to Mycobacterium tuberculosis. So attention needs to be given to potential drug-drug interactions, overlapping toxicities among COVID-19 treatments, antiretroviral medications, various antimicrobial therapies, and other medications. Now coming to interaction between the three, HIV, TB, and COVID-19. Individuals we know that who develop TB are immunocompromised. And the emergence of AIDS in middle of 20th century, which is again an immunosuppressed condition, has enhanced TB dissemination and multi-drug resistant tuberculosis emergence, which was relatively controlled until then. So M tuberculosis and HIV interact cooperatively. They impair host defenses. And as the immune system is exhausted, both pathogens spread through the individual. TB is the main cause of death in HIV seropositive individuals. Now, the synergy between these diseases resulted in what is called as a syndemic of global proportions. And to add to the situation, COVID-19 rises now as a new menace, further due to its devastating impact both on the immune system as well as the lung functions. What is the biological, epidemiological basis of interaction between these three? Exactly, it is still not known. People are working on it. Various researches are being going. Patients immunocompromised by HIV or with TB lung disease could be more susceptible to severe COVID-19. However, HIV and TB have a modest effect on COVID-19 mortality, with 12% and 2% of COVID-19 deaths attributable to them respectively. In comparison, 52% of COVID-19 deaths were attributable to diabetes. So diabetes is a more of a risk factor as compared to HIV and TB. But this small contribution of HIV and TB to COVID-19 occurring, it was due to, it could be attributed to because COVID mostly occurs, death occurs in older people and in whom HIV and TB is not that common. Regarding management of HIV in COVID patients, what we have to take care of, people with HIV who develop COVID-19, including those who require hospitalization, should continue their ART and OI prophylaxis whenever possible. Clinicians treating COVID-19 in people with HIV and in new diagnosis of HIV as well should consult an HIV specialist before adjusting or switching ARV, and also regards to duration of therapy. An ART regimen should not be changed for the purpose of preventing or treating SARS-CoV-2 infection, as the literature says that. Now again, is ART effective against COVID-19? No strong evidence that antiretroviral drugs used to treat HIV are effective in treating COVID-19. And if you're already taking ART, you can still get COVID-19 and should take precautions to prevent the virus from spreading and reduce your own risk. Now, what the negatives that have happened after the trio have emerged? Unintended consequences of lockdowns, travel bans, closure of school, colleges, even hospitals has had a bad effect on the healthcare services. We all know that. Redirection has been done to control COVID-19. All the platforms like diagnosis, outreach programs, medical access, infrastructure is being used for COVID. New and ongoing research on HIV, TB and treatment has been severely affected. In South Africa, substantial economic hardships are being faced because of COVID-19, especially in young women. And in India, national outreach programs for infectious diseases such as TB and HIV have become severely underfunded and put on the back burner. This is a table published by World Health Organization. It is showing a number of annual deaths from these infectious diseases could rise as resources shift to COVID-19. Here are tuberculosis and HIV deaths. COVID-19 has a wider impact on the global health. Apart from reproductive health, non-communicable disease, routine immunization, what is being severely affected are tuberculosis and HIV, malaria and other diseases. 1.4 million additional TB deaths by 2025 by tuberculosis and 6,73,000 additional HIV-related deaths in Africa related to, in 2020, related to HIV. Further funds have been diverged through COVID-19, and the Global Fund reacted decisively to emergence of COVID-19, quickly making available more than $1 billion US dollars to support countries as they respond to the pandemic, adapt their HIV, TB, and malaria programs in response to COVID-19, and reinforce their already overstretched health system. So everything has been diverted to COVID-19. What is the result of this? It has wiped out the years of progress in the field of HIV and TB. 2.4 million people worldwide, roughly half the deaths of the peak of the epidemics were there in 2018, the deaths from HIV, TB, and malaria together. However, this could double in the next year, wiping out years of progress if we do not act decisively. This is being studied by WHO, UNAIDS, and Stop TB Partnership together. Whenever something happens, both negatives and positives are there. What are the positives? TB and HIV diagnostic platforms were already well developed, like GeneXpert, and they are being used for COVID-19 testing. COVID-19 research efforts have increased collaboration, and they have created new approaches to speed up therapeutics and vaccine development in now also and in future also. Several countries in Africa have well-developed HIV and TB clinical trial infrastructures. So these are being used as vaccine trials for COVID-19. Both TB and COVID-19 are respiratory infections. They have similar symptoms. So whatever community outreach capabilities for contact tracing were established for TB, they are being deployed for tracing and quarantine monitoring for COVID-19. And key resources that were extensively developed, like diagnosis, community outreach programs, medical care access, and research, have been diverted to COVID-19. Number of studies you must have seen regarding mathematical models. These models can be used to learn from the past and prepare for the future. And we can also look and explore and plan for possible future pandemics. HIV care delivery has been adversely impacted in several countries during this pandemic, but this has created an opportunity for accelerating effective strategies like multi-month antiretroviral therapy. The concept has come. And also decentralization of HIV care in low resource and incorporating telemedicine in high resource settings will be critical in mitigating shocks to healthcare systems in the future pandemics. What is our role in the global response? We have to protect the frontline health workers from all these diseases. We have to reinforce systems for health. We have to fight COVID-19 on one side and to adapt the system for HIV, TB, and malaria programs. How do we control the situation? The COVID-19 response should be balanced with integrated medical care. These three conditions, as COVID-19 patients co-infected with HIV and TB start attending our healthcare services in large numbers. The provisions like telemedicine, triaging are the need of the hour. They would help in reducing the patient load on the already overwhelmed healthcare systems. They will help to maintain the social distancing. It is important that meticulous planning and judicious use of whatever available resources according to the country, they are inclined at minimizing the COVID-19 impact that has been done. So what is next? In high burden settings, death may be increasing by 10% and 20% respectively for HIV tuberculosis, as I've shown in the diagram. The greatest impact on HIV will be interruption of antiretroviral therapy. For TB, the greatest impact would be the interruption of the diagnosis and treatment of new cases, which could result from any prolonged period of COVID-19 suppression interventions. Further, pandemic of COVID-19 has affected control programs, and thus there would be a large population that could be devoid of the care which they would have got in the absence of the pandemic. A word about BCG and COVID. The BCG vaccine enhances the innate immune response, what is called as trained immunity. BCG vaccine might therefore reduce viremia after SARS-CoV-2 exposure, with consequent less severe COVID-19 and more rapid recovery. But it is not to be used injudiciously. 4 main reasons that BCG should be used in randomized controlled trials only. What are those reasons? Short supply of BCG, effect still remains unknown. BCG vaccination could give a false sense of security, and so patients are avoiding the various norms like social distancing, mask wearing, etc. And careful safety monitoring in RCT is needed to guard against the remote possibility that BCG can exacerbate COVID in a minority of patients with severe disease. So if we give BCG or use BCG in randomized controlled trials, that would be the best to see the effect of BCG and COVID. Finally, coming to the take-home message, COVID-19 causes a spectrum of responses being asymptomatic to severe cytokine storm events leading to fatal infection. People with COVID-19 and TB show similar symptoms, but incubation period in TB is longer. TB exposure is a COVID-19 risk factor in terms of occurrence, COVID-19 severity, recovery, mortality rates, worse outcomes for patients affected by active pulmonary TB disease. Interactions between these three can occur during SARS-CoV-2 or after SARS-CoV-2 infection. Men are more vulnerable to COVID-19 associated with HIV-TB or TB itself. People ill with both TB and COVID-19 may have poorer treatment outcomes, especially if TB treatment is interrupted. The main determinants of mortality for COVID-19 are age and along with them comorbidities like HIV. Patients should try to avoid getting COVID-19. This is the take-home message. Actually, we are all sitting at homes and in the offices, so it will be a message to be taken. So my patients should try to avoid getting COVID-19. Exposure should be avoided by following standard precautions and should be offered suitable vaccination whenever possible. Although HIV-TB programs have taken a setback, but simultaneously the pandemic occurrence has alarmed the humanity regarding the preparatory steps to be taken in the event of emergence and how to tackle them. We should not forget basic prevention strategies to protect against all the three infections, HIV, TB, and COVID. This I got from somewhere. It is preparing for COVID-19 if you are living with HIV. Take action to avoid COVID-19 hand washing. Continue your treatment. Stock upon ART like multi-month ART. Check you are up to date with your immunizations. Have a plan in place for if you feel unwell and need to stay at home, and look after yourself. Eat well, exercise, look after your mental health as well. Thank you very much. In the end, let us try to stop HIV-TB, the dual curse, to being curse trio, HIV, TB, and COVID. Thank you very much.
Thank you, Madam, Dr. Varsha. You have nicely explained the correlation between these two, HIV, TB, and COVID, how one is impacting the other. Definitely on the service delivery front, COVID has really played a spoil sport for us. But understanding the disease and how the COVID would impact the program or the people living with HIV co-infected with TB was very important, as to how the treatment strategies also have to be sort of tailor-made, how it would impact. That has been also very well described by you. And what has come forth is that it really requires an integrated medical care, because these three diseases may somehow continue to impact one another for the next 1 year or so. So we should be like medically more also attuned to gaining more knowledge. Many things were tried like BCG, as was explained by you. Besides ARV drugs, we also thought could help in the treatment of COVID, because the HIV and the COVID virus had some sort of similarities. So all these things you have nicely explained how it could impact. Of course, being adherent to the treatment is the mainstay, so as to avoid getting the complications of COVID-19. Thank you, ma'am. Last. Okay, coming to the last speaker for today's session, and thankfully we are a little short, but not very delayed in a session for this for the first session of the day. Next speaker is Dr. B.C. Gupta. He's an ex-member National Consumer Dispute Redressal Commission, and he will be speaking on the medical legal issues on HIV/AIDS. Over to you, sir.
Yes, sir. ये सर ये फिक्स है स्क्रीन यहाँ दिखेगी सर कंप्यूटर सर
से ओके So thank you very much. I am again there to talk on medico-legal issues and HIV/AIDS. I distinctly remember I came to Aidscon 9. So I talked about implications of HIV/AIDS Act 2017. So in some form or the other, I have been talking on HIV/AIDS Act in many conferences at national level. But today in Aidscon 10, my intention is to go beyond the act. So whatever is not contained in the act, what kind of medico-legal issues can be there? What kind of liability can be there? That I'm going to spell out. And I'm sure not much has been done. Rather, no thinking has been there on those issues. So I will come back to it. Now, coming of medico-legal issues, so I have divided the presentation into three parts. The first one is why there is a medico-legal litigation. Second is the system of courts that is there in India. But the most important is what happens within the system. So I will take up one by one. Why medico-legal cases? For the HIV/AIDS Act 2017, I think that has formalized in a statutory way the instances which could be giving rise to the medico-legal cases, the practice of discrimination, anybody who's discriminated, all matters of common sense. You can go to the court and not taking informed consent, breach of confidentiality. And the other three things, lack of, three things are there. Lack of care and treatment, lack of welfare measures, lack of safe work environment, and non-compliance with the legal provisions of the Act. When I say lack of, there are three things. Who is to do it? Care and treatment, welfare measures, safe work environment. This is to be done by government, central government, state government, establishments. So that definition is given in the Act. What is the meaning of establishment? Public sector, private sector. And if anybody, maybe in the government of India, he fails to do his duty as enshrined in the Act, is it possible to proceed in the judicial courts if somebody is not doing the duty which is listed in black and white in the act. So this is what I'm going to say today. So straightway we come to criminal liability. So there is a full chapter that is called chapter 13. I am sure everybody by now must have gone through the act or must have very intimately familiar with the act. So there is a full chapter. Chapter 13 says offenses are cognizable under CRPC, that is Code of Criminal Procedure 1973. It has also provided that judicial magistrate first class, so he in his court the offenses can be tried. So if there is a disclosure of information, if there is a discrimination, so one can go and knock at the doors of judicial magistrate first class. Some person he puts him behind the bars, some persons he put the fines and all that. So all that is there. So the penalties are there. Discrimination, section 4 of the act, breach of confidentiality, all that. So the question that arises, is there anything beyond that? Is there something known as civil liability also? Although the act does not say so. So in this chapter on penalties, to my mind, there should have been provision, because I speak from the judicial front. As my biodata shows, for 5+ years, I worked in the top consumer court of the country in judicial capacity. So the question that I am asking is there anything beyond criminal liability? So the answer to my mind is yes. How it is yes? So civil liability, it is not provided under the act, but liability under, there is a law of torts, there are consumer laws of the country. So this civil liability will be in addition to criminal liability. So I am told somebody can be fined for 1 lakh of rupees for something discrimination or so. In addition, civil liability can also be there. So there are civil courts, there are consumer courts, then there are high courts and the Honorable Supreme Court of India. So all the courts are there. So the question is, who can come to these courts? Anybody who's aggrieved that the central government is required to make such and such arrangements. Say your state government, you are supposed to provide ART services, but you have not done it. So anybody who is suffering as a result of the negligence in providing the services, or let me say deficiency in service, he can knock at the doors of the consumer courts. So to my mind, he is my consumer because the service promised under the act has not been given. So he has every reason to come to the consumer courts, and the system of consumer courts, and every district we have a district court. Now the jurisdiction is up to 1 crore of rupees and headed by an officer of the rank of district judge. District judge is a fairly senior officer. He has the powers to send a person to gallows also. So you can imagine what kind of seniority is there. Then the state commission headed by a high court judge. Then the national commission, so where I was there, it is headed by a Supreme Court judge. And there are other judges like me. So 6 courts are there, 12 people in total. So that is the national court. And whatever we decide, there is only one appeal that goes to the Supreme Court of India proper. And no further litigation is possible. So the Supreme Court is the apex court which deals with all the consumer cases. So my point is that civil liability, which means that anything promised to be done, anything not being done, anything done to a deficient level, anything to be done as an unfair trade practice, so that is tribal as civil liability in the civil courts or consumer courts. So I have listed all these things deficiency in service on the part of establishment in inverted commas, because the definition is there. Public sector, private sector, even the government. So care and treatment, welfare measures, safe working environment, discrimination, breach of confidentiality. Then if you go through the definition of unfair trade practice, so it is given there. So you test a person and he is found HIV positive, and the disclosure of information about his status, if it is wrongly made, it constitutes, it comes under the definition of unfair trade practice. So the person is a consumer, he can come to the consumer courts. Then within the system, once the litigation is there, I mentioned about this last time also, informed consent, maintenance of records, SOPs, standard operating procedures. These three things, they are universally acknowledged in every part of the globe, in every country, that these three things have to be there when there is any litigation concerning medical negligence. Now, on informed consent, your own act, the HIV/AIDS Act 2017, it says that consent is to be given by individual or his representative specific to proposed intervention. There should not be any element of coercion, undue influence, fraud, misrepresentation, etc. And it has to be taken in the language as understood by the individual. Not you scribble some lines in English and he's made to sign, as it happens in all the hospitals, including the top hospitals. It has to be in the language as he understands. So far as we are concerned, we do not bother whether your document is in Hindi, Punjabi, Telugu, Malayalam, but it has to be properly signed by the doctor who has explained something or a service provider, properly signed by the client, that means the patient, and by an independent witness. So all these things, risks and benefits, alternatives, side effects have to be explained. Then is the degree of disclosure. What does it mean? So I don't want to take your time on this. It means when you are taking the consent, side effects are there. So how much do you disclose? Whose discretion it is? So the law is that all material facts have to be disclosed. Then there is pre-test counseling, post-test counseling. That is again a part of the act. Now, pre-test counselings, it includes information about the test, including the right to refuse the test, safer sexual and drug use practices, then implications of the test, risks and benefits. Then there is post-test counseling. The results of the test, then helping the person cope with the results, addressing fears regarding disclosure, information about safer sex practices, information about available treatment, referrals to HIV organizations and networks. So the point is that all these things are listed there. So the job of any person, any healthcare provider, whether he's a doctor or he's a counselor who is concerned with this kind of activity concerning HIV/AIDS. So the job is well defined under the Act. And if any of these things are not there, it may give rise to medical legal litigation. My only job is to sensitize you. I'm not going to scare you, but something is there which has to be done. Then medical records, the maintenance of records, I think that is a sacred duty. Whatever is the interaction between the patient and the healthcare provider, proper record has to be there. And for that, proper guidelines. If they are there, it is all right. But otherwise, in your case, NACO or the National Medical Commission, they may operate the guidelines. Then SOPs, this is also a general kind of observation. During my 5.5 years in the National Commission, now let me tell you something very startling. hundreds of cases, 2.5 years, I was exclusively presiding over a bench dealing with medical negligence cases in 100% of the cases. When I ask a question sitting at the dais, is there any SOP? Is there any standard practice? Do you have a document which says that you have done the surgery and this is the SOP? The answer was no. Then informed consent. So everybody talks about it in every corner of the world. But out of 100 cases, in more than 50%, there was no document on my court file which says informed consent. And in other 50% cases, where the document is there, but I did not see the signatures of any healthcare provider in any file on any document. I do not know what is the reason for it. It is not my job to teach the reasons for it. So my job is only to give the judgments. So I am only sensitizing the stakeholders, the healthcare providers, even the clients, that whatever is laid down in the law, laid down in the procedures, that should be followed. So if there is a litigation and the essential documents are not there, you can well imagine the direction in which the court order can go. So this is all I wanted to say. So what is the way forward? I think conferences like this, so they can go a long way in the process of sensitization. I am told even in COVID times, I'm very happy to observe in Aidscon 10, probably 700 registrations are there. 500 people are logged in. So this is very encouraging. So the point is, these things should be discussed at appropriate levels. Whatever are your views, they should be flagged to the appropriate quarters. I was talking to one of the very senior officers in the NACO. So I requested him that the Act only talks of criminal liability. So civil liability, any person, aggrieved person, even today, he has the right to come to a court. So it is the job of the establishment, which means the ministry, the NACO, and other concerned ministries. If you say care and treatment, if you say welfare measures, if something is to be done by the welfare department of the government of India, so it has to be done. And it is not done, then the courts will definitely come with a very heavy hand. And don't be surprised if during the act is only 4-year-old. So if during the course of the events in the coming days, the courts come out with passing even strictures and even awarding damages to the patients, and in the process, the establishment may have to shell out heavy amounts. So once again, I'm saying the intention should be that judicial courts should be the last resort. All the issues should be discussed and deliberated threadbare and involving all the stakeholders, necessary directions issued for the guidance of everybody, and standard procedures formulated so that when there is a litigation, so there is adequate defense available to the defendants. Thank you very much.
Thank you, Dr. B.C. Gupta, for taking on this very important topic as far as health delivery is concerned. Also highlight sharing your wide experience in the consumer dispute forum, how civil liability is equally important apart from the criminal liabilities of the consumer, how the healthcare establishments as well as the healthcare workers need to be so much conversant with all the provisions of the Act, and that this sharing of knowledge regarding should be happening at the level of at appropriate forums like the IMA is very much relevant, because as you know that medical negligence litigations are on the rise. So knowing about the act and then knowing how to deal with the provisions of the act and also knowing about the informed consent, everything is to be known by the healthcare workers and the establishment. Thank you very much, sir. If there are any questions, we would be happy to take it now, maybe another 5 minutes or so. But there was a question for Dr. Rachana. Are you there, ma'am? It was okay. I think she's not around. So this is the we are concluding this.
Hold kare. Ma'am, Roshna ma'am is there, ma'am.
Okay, the question was regarding what are the inputs for elimination of syphilis from mother to child, because so much emphasis is given and the testing of the baby post delivery, but what's happening at the level of syphilis? That was a question that was raised by one of the participants.
Roshna ma'am, can you hear us? I think she's facing some difficulty, ma'am. We can move on if you want.
Okay, I think we have come to the end of this session.
Kushika ki kaj?
Yeah, yes, ma'am. We can hear you now. Thank you.
Huh?
Roshna ma'am, we can hear you.
Hello, yeah.
Oh, আচ্ছা কালকে যেটা বলছিল।
Roshna ma'am.
In the meantime, we can take the next question if it is there. Okay.
There are no more questions.
Okay, I think she's there now.
Ma'am, you can ask your question again, please.
The question was for what has been the strategy towards elimination of mother-to-child transmission of syphilis?
Yes, Dr. Gomes, can you just repeat the question once again, please? Yeah. Hello?
So I just read out. Yeah. Parent-to-child transmission elimination is not limited only to HIV. It also includes syphilis, but nothing I could see in this regard. That was the issue
actually,
raised.
Dr. Gomes, you are very right in pointing that out. You know, we are, wherever we are working, we are promoting and working for dual elimination of HIV and syphilis. But in the presentation, we haven't really mentioned it because, you know, the donor is very fixated on HIV. But we are doing dual elimination thing. And we have also kind of, you know, advocated for combo kits so that, you know, when the woman is being screened for HIV, she's also screened for syphilis.
Okay, combo kits. If you have any data, they said they will be happy to learn about
Yes, definitely. I can send it to you. Definitely. Sure.
Yes. So with this, we end this session. Thank you all the speakers who have contributed towards enhancing our knowledge on the various aspects of the NACP response to the COVID pandemic. Thank you.
Thank you.
Thank you, ma'am. Thank you, Dr. Holmes. And thank you all the speakers for joining us in this session. We break for lunch and we'll see you in the session 3, care, support and treatment at 2, sharp 2 p.m. Thank you.
मैडम
हाँ जी
अच्छा वो थोड़ा वीडियो अपलोड और ये सब नहीं पॉसिबल हो रहा है तो कैन वी डू इट पीपीटी प्रेजेंटेशन एंड देन टॉक इज दैट ओके
Yeah, sir, it's okay with us.
Yes, sir. Yes, sir. Okay. Manoj, sir, it's absolutely fine, sir.
Thank you. Thank you.
Sure, sir.
Thank you.
So, should we leave meeting and rejoin?
Yes, sir, you can do that. We will see you
I
at
think
2.
it's
You can log
better.
in again.
Yeah, it's better if you can just leave the link with just mic and your cameras mute and just leave it as such. Don't worry about that. Just keep your mics mute and your cameras off. That's it.
Thank you.
Thank you.
Thank you.
नहीं वो चलो क्या हो सकता?
Hello, am I audible?
Yes, ma'am, you are, ma'am.
Yes, for the next session, because I'd be chairing, so I wanted to make sure that I'm audible. Okay, thank you.
I'll just help you. Just give me a moment, ma'am.
Yeah.
So, if you want, you can keep your cameras on also. Can you see me, ma'am?
Yes,
Hello.
I can see. Okay, hi.
Hi, ma'am. So I can, we can see you, ma'am. It's absolutely
Okay.
good. Just,
And voice is clear?
just angle. Yeah, perfect, ma'am. Just angle your camera a little bit more towards the end, ma'am.
That
Perfect,
is it
perfect,
fine?
ma'am.
Okay.
Absolutely perfect.
Okay, thank you.
Yes, it is, ma'am.
See you at 2 o'clock.
Sure, ma'am.
Okay.
We'll meet after
Bye.
lunch, ma'am.
Yeah.
Yes, ma'am. Thank you.
everyone. Welcome back. Moving on to our third session, care, support and treatment, I would like to call upon Dr. R. Gangakhetkar. He's our chairman for this session. I would like to invite Dr. Manpreet Chatwal, Additional Project Director, Punjab SACS, to co-chair, please. Welcome our chair and co-chair. I hope they can hear me.
Yeah, we have joined.
Oh, great. That's great, sir. I would like to invite Dr. Sangeeta Kaul, Divisional Chief, HIV/AIDS Division, UNAIDS, to chair the co-session with us. Is she there?
Yes, I'm here.
Welcome, ma'am. Welcome, ma'am. So handing over the session to our chair and co-chair. Thank you very much.
Thank you. So, should I start, Dr.
Yes, sir.
Sangeeta?
Yeah.
Yes, sir. You can start and I'll just join you later. Yeah.
Yeah. I don't know whether Mr. Manoj Pardeshi is on.
Yeah, sir. He's there.
So he's there, sir.
Yeah.
Manoj, sir, can you just switch your camera on and your mic on? Sir?
Yes, doctor, I'm here.
No, my camera is on, mic is also on.
No, I was talking to Manoj, sir. Don't worry.
Sir, I'm here.
Okay. I welcome all of you after a lunch that you had, and we have an hour session to look at this point in time. And the first talk is going to be given by Mr. Manoj Pardeshi, who is General Secretary of National Coalition of PL-HIV in India, NCPI. I don't see any reason why I need to introduce him more. He is one of the most senior leaders in the field of HIV advocacy and self-help groups that were formed in India. He was one of those who was instrumental in establishing TAL pharmacies, which is an integrated model for service delivery. I request him to deliver a talk on TAL positive and integrated model for service delivery.
Thank you, sir. Thank you so much. Thank you, Vandana ma'am, NACO, everyone, for giving this opportunity. Warm welcome from TAL Plus family. My presentation is in two stages. One, we have made a small video. How can I run that? Can someone?
Sir, just share your screen, sir, and you can run the video on your laptop.
Okay. How should I share the screen?
There's a small green button at the bottom, sir.
Okay.
Share screen option. Yeah, just click on that and then choose desktop.
Desktop 1.
Desktop 1. And then it goes to your desktop, sir, and then you can share your video.
Okay. Is it?
Manoj, if it is taking time, let's first have the presentation and then we'll figure out the video, if that's fine with you. So that
presentation also I need to share, na? That.
Yes.
Okay.
Just where are you as of now,
Yeah,
sir, on the screen? Are you able to share your screen, sir?
Can I share on his behalf, please?
Yes, Rohan, sir. This is where I was going. Yeah, if you can share on his behalf, please.
Is it visible?
Yes, sir. It is visible.
Thank you so much. ओके, आता आपली चालू होईल ना व्हिडिओ?
हो सर.
ठीक. Carry on. Here we are actually taking you to the Tal Pharmacy tour. Just there it is. It's less than 6 minutes video. Namaskar. Welcome to Tal Pharmacy. Tal Pharmacy is a community-driven initiative supported by USAID in close partnership with NACO, MSACS, MDAX, KHU, YRG Care, and NFP+. It's a holistic approach to lead the life with HIV with confidence towards achieving 95-95-95 goal.
Welcome. This is Dr. Rohan. Welcome to Tal Plus Community Pharmacy and Integrated Health Center. Here at Tal Plus, we provide good quality services regarding ART, PrEP, hepatitis C, and non-communicable disease at a very subsidized and low cost. Here now we are at the reception. Reception is the first point of contact for the client to the center. Here at the reception, depending on the need of the client will be directed to the particular section of the center. This is waiting room. Here, the client will wait for their turn to meet the doctor or the counselor. This is doctor's room. Here we provide good quality diagnostic and therapeutic services to the client. Along with good quality diagnostic and therapeutic services, we provide non-judgmental services to the client. At Tal Plus, we all are trained to provide safe and secure environment to the client, which is non-judgmental. This is counselor's room, where our trained counselor explains the benefit of services to the client. The counseling revolves around safe sex, adherence, and other need-based priorities. The role of the counselor is to explain the relevance of the services and remain adherent to it. This is the room for our laboratory technician. Here we collect all the diagnostic samples required by the client. We follow all the standard operating procedures and we also follow all the necessary guidelines. For the medical waste management, we always adhere to the standard operating procedures. This is staff nurse room. This room is specially dedicated to staff nurse. The main role of the staff nurse is to help the doctors in diagnosis and also to help the lab technician. The other role of the staff nurse is to maintain the documents related to investigations that are prescribed. And last but not the least, this is our pharmacy. Here, the clients can have access to ART and PrEP.
The voice is not audible now.
Okay, so no issue. This is our cafeteria where people, whenever they are coming, they are having their lunch and their free time. Thank you so much, Dr. Rohan. I have another PPT also that I will share with the conference organizer. Basically, there are two models we have now. This is one model which is subsidized. The second thing is that we also have a Tal Plus Link ART Center. So this is the first Link ART Center which opens from 9 a.m. to 6 p.m. and all 7 days of the week. And initially there was a very less response, but now every Sunday there are 8 to 10 footfalls for every Sunday. And that is showing that we need to have a different kind of models to increase the access to the ART center, to the services. One of the best thing from Tal which we are proud to is that it's not just a standalone going in one way. We, since beginning, we were part, when the day one Dr. Ganga Katkar was there, and still he is with us. we are always worked with in the partnership with government, and that is why we are the first when in 2008 or 9 there was a Supreme Court order to share entire private data, not the name, just the data. And we are the first one who started reporting to the MSACs and government. And till now, this is the only private sector mechanism which is reporting the actual data to the national system. Thank you, doctor. And anybody wants to ask any question, then later on I will answer. Thank you so much.
Thank you, Manoj. I think it was a good way where you showed the TAL clinic. And today, thanks to the highly effective daily ART, people living with HIV can expect a near normal lifespan. But even when the virus is well controlled with ART, people with HIV remain at a higher risk of cardiovascular disease and other comorbidities compared to their HIV negative peers. So in that setting, having an integrated clinic approach is one of the approaches which can be adopted and scaled up. So we look forward to hearing more about this TAL clinic. So let me introduce our next expert speaker, Dr. Ganga Khedkar. He will be talking about HIV and COVID. We know for the last 1 year, we have been facing the dual pandemic of HIV and COVID. There is emerging evidence suggesting a moderately increased risk of COVID-19 mortality among PLHIV. However, PLHIV may have favorable outcomes due to the increased health awareness and close medical follow-ups. In addition, some ARV drugs are under consideration as potential treatment for COVID-19. So now over to Dr. Ganga Khedkar, who is an expert in both HIV/AIDS and COVID epidemiology and vaccines. Thank you. Over to you, Dr. Ganga Khedkar. We cannot hear you. You're on mute, doctor. Yeah. Still, you're on mute, Dr. Ganga Khedkar.
Yeah, am I audible?
Yes, sir.
Just one second. Huh?
Sure.
So what we are going to do is very quickly go over HIV and COVID vaccines as an issue that is emerging as of now. Now, all of the 1 minute. One of the issues which we need to learn is perhaps, we start off saying, why do we need vaccine against COVID-19? We know that in a year short span of time, over 12 crore individuals across the world have acquired COVID-19. India has also reported almost close to about 10% of those cases. If you look at the second and third wave that has come up in US, England, and parts of European countries also, you find that they report very large numbers every day. And what it affected was availability of hospital beds in those places. There is a non-availability of a specific and efficacious antiviral, and therefore one has to look at this particular issue. Can we prevent it by producing a vaccine? Scientists were successful to develop these vaccines, and if these vaccines would not have had come up, we know COVID not only is fatal, but it has a potential to cause other morbidities affecting quality of life after COVID infection as well. What does the COVID vaccine protect us from? They protect us against development of severe COVID disease and thus death that could follow that. The initial studies tend to suggest that they may have lower protection to prevent acquisition of COVID infection that could be asymptomatic or mild. Perhaps the second generation vaccines may perhaps be in a better position to address this issue. But the redeeming fact is that those who are vaccinated, even if they develop, let's say, infection subsequently, they acquire infection, but it is generally mild in its own nature. Therefore, COVID vaccine rollout has, if you look at the broader objectives that they have, there are two objectives that one could have. First is reduction in severe COVID associated mortality, The second could be reduction in transmission. Reduction in transmission is very difficult to happen given the fact that vaccines have limitations in preventing the acquisition of this particular infection, and therefore reduction in severe COVID associated mortality has been given primacy. If it was reduction in transmission, then in those cases we would also have had required that we vaccinate all individuals as quickly as possible, and that could have been extremely difficult given the limited availability of the vaccine dosages across the world. Who falls in our priority as of now? You look at healthcare workers and frontline workers who were in the first two groups that were prioritized. And the third group is persons above 45 years of age and those with comorbidity. They have been they are allowed to take these vaccines through the government sector or by payment through private sector. And in that entire list of 20 diseases, you will find HIV infected individuals are also included in it. Now let's try and understand why HIV infected individuals are prioritized in the third group. The reason is very simple. As Dr. Sangeeta did allude to, that those who are infected by HIV, are more likely to be hospitalized for COVID-19, and they have a slightly increased risk of dying due to COVID-19. This especially is likely to happen among those whose viral load is not suppressed, and therefore that's something which we have to keep at the back of mind. We must also remember that among those PLHAs who died due to this infection, the age was far younger, and this is only because the early onset of chronic morbidities. This is far more important for us, mainly because we know HIV infected individuals tend to age prematurely, and therefore they develop comorbidities early, and presence of comorbidity is associated with severe disease, COVID disease, and death. Now, if you look at South African cohort, it had shown a little higher risk of death, more often among people whose CD4 counts were lower than 200 cells or whose viral loads were higher than 1,000 copies, that is, they were detectable. The odds of such a hazard increased by 3.3 times. So essentially, there are issues which we have to think about when it comes to HIV infected individual. In the same study, they alluded to one fact: if people were receiving tenofovir, the odds of even deaths as well as infection perhaps could be lower. But these these issues brought little more clarification that those who are HIV infected, those who are receiving antiretrovirals, will they be protected from acquiring this infection? Because the enzymes that HIV has, you also share similar kind of an enzyme, which is a protease enzyme. People thought that these drugs may essentially work and try to protect these individuals from acquiring it, but that is not true. So essentially, now it is known that those who are HIV infected, they are as much equally prone to develop this infection. If you look at HIV COVID in UK, you find that HIV infected individuals were more likely to be younger. If you look at age adjusted hazard rate, it was 1.47, and age less than 60 had almost two-folds increase in the risk of death. And as I alluded to earlier, that is primarily because of chronic morbidities that people tend to have. Now, one of the things that happened in COVID was within a span of about 13 odd months, you found different vaccines have actually been developed and approved as well based on the interim analysis that they underwent. If you look at Pfizer and Moderna, these vaccines which are not available in India, these are mRNA based vaccine. And what do we mean by that? Whenever our cells tend to produce a protein, they, for that particular protein to be produced, you need genes, which is DNA, which encodes certain information, certain pieces of information, which is transmitted through mRNA, messenger RNA, to the cell, and then subsequently this protein is produced. Everywhere in the world, spike protein is the protein which is being zeroed down by all vaccine manufacturers, and the result that you are seeing that for Pfizer and Moderna, they have used mRNA, whereas AstraZeneca and Sputnik, they are using the entire DNA section that encodes for the production of spike protein, and that is embedded into adenovirus DNA, so that when you inject that particular virus, you will find that our body will also start producing the spike protein. One of the things which was one issue, that since adenoviruses are commonly associated with common cold, there was a worry, as it was seen even in HIV when vaccines were produced using adenovirus, the take of a vaccine becomes lesser because there are pre-existent antibodies against adenovirus. So both the companies have done one thing. They have picked up rarer adenoviruses. One for AstraZeneca, it is from chimpanzee. For Sputnik, it is the rare type of adenovirus 26 and adenovirus 5, where the spike protein genes are inserted in it. When it comes to Bharat Biotech and Sinovac, these vaccines are essentially using the inactivated virion, that's a whole virion, which is almost like dead. No? So it is unlikely to be called even as a live vaccine. All these vaccines tend to have protective efficacy against development of severe disease that ranges between 81 to almost 95%. Now, one issue which we must understand, that in HIV, we don't give live vaccines, but you must remember that the adenovirus that we are providing through AstraZeneca vaccine is non-replicating adenovirus infection. So virus is unlikely to survive in our own body and produce more of adenoviruses. So there is no reason for us to unnecessarily worry. So are these vaccines safe in HIV infected individuals? Both the vaccines which are available in India, Covishield and Covaxin, they are safe. If the person is not immunosuppressed, then the take of a vaccine or the successful immune response that tend to come after provision of vaccine is likely to be seen. But if the person is immunosuppressed, he is not taking ART regularly, then perhaps the titers of antibodies are likely to be lower. Now, as we had already seen, this is adenovirus. In the adenovirus DNA, you put this spike protein gene and put it into human body. When it comes to side effects with this AstraZeneca vaccine, you find a large majority, close to about 60% of them, will develop local tenderness, swelling, and such issues. About half of them will develop headache and tiredness after receiving vaccine. Muscle ache and feeling generally unwell is also seen when vaccine is being provided. And at the same time, some people develop pyrexia, that's fever, and chills, as well as joint pains, as some of the manifestations of local or systemic side effects that are observed with it. When it comes to Covaxin, it's a traditionally old platform, and it tends to have lower adverse events. Adverse events are seen, they are minimal, they are milder, they are seen in less than 7% people 3 months even after vaccination. So there is no reason to worry to take these particular vaccines. We need to remember that you have to take these vaccines in 2 dosages. They are 28 days apart. Most often, whatever amount of toxicity that you experience in the first dose, the nature of that toxicity becomes lesser when it comes to second dose. If you had fever, fever is going to be very short, if at all, and then it may be transient and not lasting long enough. So essentially, second dose is associated with lower toxicity. People were very happy with even non-pharmacological interventions that were occurring, and just the beginning of the vaccination effort, when they came to know that vaccines have been produced, and you look at the epidemiologic curve, everywhere in the world there was a decline that was being observed. But then suddenly people started seeing that in certain places there are different variants of this virus which are coming up, and of these viruses, you found at least two, the South African variant and Brazilian variant, which is likely to show an immune escape or escape mutant could be developed so that the vaccine no longer protects these individuals from producing the severe COVID disease as such. Why does this happen? Like all other viruses, compare HIV or influenza, which are known to mutate at a rapid rate, SARS-CoV-2, the virus of COVID disease, it tends to mutate very slowly. However, if you look at their transmission dynamics, it was a big surprise that you found that there is development of mutants because there is the virus life inside the body is pretty short. It's around 2 weeks time. So within that short period, it would have had been difficult to imagine that such a thing could happen. But these viruses tend to mutate when you apply selection pressure of antivirals or immune response per se. We know that there are no known specific and effective antivirals against COVID-19. There could be two possible reasons why this is happening. One is repeated use of convalescent plasma. We know in convalescent plasma, you tend to collect the blood from a patient who had COVID in the past and infuse this plasma into the body of another individual who's having COVID. That would contain different neutralizing antibodies. If you give them repeatedly, the body will perhaps have different neutralizing antibodies against which the virus will make an effort to mutate, and that's how mutations tend to occur more frequently among them. And the second issue that could be important is when an immunocompromised host or a patient like HIV infected individual would get an infection, the virus is likely to live longer than 2 weeks. If it stays for longer than 2 weeks, then it allows an opportunity for that particular virus to develop mutation. So do we know whether such mutations, which can evade the vaccine acting against them, are they there in India? The genomic surveillance was started in March, and now it has been extended under the leadership of NCDC. We must remember we had more than a crore cases. So if you actually screen for about 3.5 to 5,000 samples today, now you find that it tends to be very small, and therefore there is a large amount of uncertainty when it comes to whether we have those mutants here. But we have been screening certain populations very strictly, the international travelers, and there we find that certain variants have come, though patients have been isolated, so the spread has not occurred. But some variants like N44K0K, E484K, now these two mutants have been seen in India, and of these, E484K is one of the mutants which is likely to challenge these vaccines as such. Of the newer vaccines that have been developed now, Novavax and Johnson & Johnson, as well as even Bharat Biotech's vaccine, is known to be partially effective against these mutants. But it is possible, if they continue to mutate, you might have a mutant strain which will not be stopped by the vaccines from infecting individuals and producing severe COVID disease. Now, what is the implication of emergence of these mutants? You have to have a rapid rollout of vaccines to ensure that no new variants tend to develop in the country. Therefore, what is important is HIV infected individuals should use this opportunity and try and get themselves vaccinated as soon as possible, since they fall in this third category, which is open as of now. There may be some questions that may come to their mind. I had COVID infection in the past. No, should I take it? Yes, you need to take it. You need to take it after 2 to 4 weeks time so that your immune system has returned to normal. I have history of allergies in the past. Should I take it under supervision? Unless you had anaphylaxis, that is, you had such a severe allergy that you were close to dying. In those circumstances, you may not take this vaccine. Please do not hesitate. One of the biggest worries that I have is people may not avail this opportunity because they will have to declare that they are HIV infected, because of the perceived stigma. Please don't hesitate to disclose your status. Carry the certificate from doctor that you are HIV infected. What would happen is getting this vaccine is not only in your own interest, but it is also in the interest of the larger society. Thank you.
Thank you so much, Dr. Ganga, for this very informative and comprehensive presentation, highlighting the importance of COVID vaccination among PLHIV, as well as dispelling all myths and misconceptions about the COVID vaccine. Thank you so much. We would be happy to take questions after all the sessions are over. Dr. Sunil, I see your hand up. Okay.
I just wanted to have one question. If we can have it later on, that's fine.
Yes. Note it down and we'll take all the questions in the end. Verbal autopsy is a technique used in surveillance sites in many countries to assign likely cause of death for programmatic purposes where most deaths are not registered or attended by a medical professional. Conducting a verbal autopsy is a time-intensive exercise. And now you'll be hearing from Dr. Manish about the verbal autopsy that has been attempted in the Indian context. Over to Dr. Manish Bamrutia.
Thank you, Dr. Sangeeta. I hope you all are able to see my screen as well as hear me properly, right?
Yes, sir, we are.
Yes.
Respected chair and co-chair for this session, respected joint secretary, sir, for NACO, all the officials from NACO, SEX, and all the delegates attending this conference. A very good afternoon from my side. So I'll be quickly talking about the verbal autopsy activity for the PLHIVs who have disease and registered at a few of the ART centers. So just a small disclaimer that this is work under progress and the final findings, outcomes, everything will be shared by NACO after due deliberation and approvals with all. So what I am going to do today is just presenting the processes that has been followed and the prima facie observations that has come out so far. Yeah, so I'm trying to change, yes. So basically, as Dr. Sangeeta just now rightly mentioned, so this method is used to ascertain cause of death and the basic is interview with a close relative or other caregivers. The person who was present along with the deceased at the time of their final illnesses. So it uses standardized questionnaire. It relies on eliciting information. So questions are being asked to eliciting informations like signs, symptoms, what happened during that, what were the circumstances. And this is basically a public health tool for estimating cost structure of mortality at population level. So it's not very accurate when it comes to individual level, but generally used as a public health tool for a population level mortality assessment. Just a brief of history. So pre-1900, it started in a way like in Europe, there were people who were known as death searchers. So they started this lay reporting, going to the households and asking if what were the symptoms of disease. Then in 1950, 60, physicians started interviewing to ascertain or determining the probable cause of deaths. And in 1970s, actually, the lay reporting was encouraged by WHO, and it was in 1975 that actually this term verbal autopsy was first coined, and it was again it was coined in one of the projects at Punjab only. So in early form, like it was multiple questionnaire were there, multiple versions, which was standardized by WHO in 2007. And this was revised in 2012. In 2010s, WHO also developed one smart VA tool, which is a kind of Excel-based software. And the final version that we are using was finalized in 2016. Based on due to the COVID pandemic, WHO has also released one small amendment to this and added COVID-related questions as well. In India, basically VA is introduced in 2001 as a part of SRS, and it's basically done by the Registrar General of India, and there is technical support is being provided by AIMS, and there is a Minerva team, I think most of you must have known. So they are doing this verbal autopsies for the government of India for general population, not specific to any particular disease. So basically it's for maternal health, and program like visceral dysmaniasis also is doing. And there is also one online certificate course for the physicians who are included in, to use to code the forms, so final ascertaining of the cause. So we are also relying on the same process flow which has been established and used since long. And when it comes to specific to HIV, it has not happened in our country, but then there are studies from Africa, and they basically most of the studies are mainly on estimating prevalence of AIDS-related mortality among general population, and there are very few papers actually identifying cause of death among PLHIV. So it's kind of one of its kind activity that we are doing for NACO. And how it started. So in 2019, then SSNDG NACO suggested to CST division that death audit or ascertaining common causes of deaths among PLHIV might be helpful for program and take some interventions to prevent deaths further. Obviously, ART has caused a significant decline in AIDS-related mortality, but still we can look for certain clues. And that's how the verbal autopsies at selected ART centers were planned. And so far, NACO has done one national consultation wherein which form to be used, what process to be followed, sites all were discussed. And after that, the selected ART centers and SACs were trained in 2 batches. At NACO, CST division is taking the lead and Project Accelerate is supporting CST division for taking forward this activity. And actual activity started in January 2020. So as I mentioned, the basic aim is to identify the cause-specific mortality among the deceased PLHIV registered at ART centers through verbal autopsy. And it's expected that once we have some findings from it, eventually it can help NACO to formulating interventions for preventable causes of deaths amongst PLHIVs. Some inputs may also go into advanced HIV disease package. And most importantly, we can understand the vulnerabilities of PLHIV for mortality. Like we know that low CD4 count is a vulnerability. So it will obviously also give us some insights on whether there are additional factors that contribute to mortality or not. So these are the glimpses of, I'm sure many of you have participated in this. So we had national consultation in May 2019 and then training in 2 batches in June 2019 and January 2020. So this is basically, we are aiming to cover almost 1,200 cases of PLHIV who died. And the period initially was only 2019, but due to COVID-related interruption, we have expanded it a little bit. And it's being done at 26 sites across 24 states. So you can see it's pretty much a kind of most of the country is being covered. This is the process flow that we are following. So first, a line list is prepared by ART center for diseased patients who are reported as deceased during this period. Then counselor calls the patients and first of all knows their willingness to participate in this particular activity. So whoever is willing to participate, they will then identify the caregiver, schedule the appointment. And once appointment is scheduled on the same day, a VA consultant reaches at ART centers and conduct interview after written consent of the caregiver. And quality checks are on field as well as regular review meetings is being done by CST division NACO as well as the Accelerate team. And finally, the plan is that ICD-10 coding system will be utilized by trained physicians who are trained by who are certified through the course of Minerva will be doing this coding. So this is progress so far. So we started in January 2020 and then in mid-March because of the lockdown and COVID pandemic, the activity was on hold. During that period, 2.5 months, we completed around 313 verbal autopsies at that time. We restarted in mid-December 2020 after 15th of December, and till February, we have done another 423 verbal autopsies. So out of 1,200 which are aimed, we are close to some 700 plus verbal autopsies now. So these are you can see these are VA consultants actually interacting with the caregivers of disease patients at ART centers. So as I mentioned, so a detailed analysis will definitely come from the CST division NACO. What I'm presenting is the primi facie observation. So preliminary, what we are commonly seeing is the like males are larger part. Actually, it depends on various factors like who responds, who agrees to come. But still, whatever cases we have done VA for, 70% disease were male, while 30% were female. The major age group again is 36 to 50, which goes in line with our academic as well. What is interesting is really we have seen this only 32% among these were actually institutional deaths. Most of them, like 60%, 62% are community level. And rest 6 were like on the way to hospital or other facilities. Basically, these are community level deaths. So there's very little chance of getting some medical records of it. Also, other gap which was striking is availability of death certificates. So only half, almost half, had a death certificate issued through an authority. But however, even in these death certificate, the cause of death has not been mentioned. Only 5 cases so far we have seen where cause of actual death is being mentioned. So it clearly reflects that there is a need. We need to be actually get some fruitful outcomes out of this activity. So again, so this I'm just so what we have done is so ICD-10 coding is ongoing, and again it will become as a final outcome. But however, what I'm presenting here is a prima facie probable associate reason. So we have clubbed them just for the presentation sake. And what strikingly, so we expected, yes, so there is like a majority, almost 50% are due to advanced HIV disease, late presentation, and multiple infections, which includes all the like, and again, among those OI, TB as expected is the major one. Others are also there. But the more strikingly important observation so far is you can see the NCDs coming up, like cardiovascular disease, cancers are also one of the significant contributors. Also, some things like dead road traffic accidents and injuries also contribute to almost 7%. So again, so these are deaths among PLHIV, but we can say not everyone have died due to AIDS. There are other factors, and maybe findings from this particular activity will help NACO to design some of the interventions and strategies beyond OI management as well. So I thank all the caregivers who are like giving their time, and again, it's a very emotional moment for the caregivers, so basically because going through again, remembering all those things. Staff of ART centers who are doing most of the work, calling them, scheduling appointments, management, our VA consultants, and obviously the CST division at NACO, Dr. Goel, Dr. Chinmay, Dr. Maninder, and all the division for guiding us throughout this process, and my colleagues at SLRED. So I thank all of them for their contribution. And again, so this is just a work in progress, and hopefully we'll get some good reports out of it. Thank you.
Thank you, Manish, for a very nice talk, because perhaps this is the first effort where we are trying to find out why people died at home, and what was little surprising also, which may be confirmed subsequently, that 22% died due to TB. It was a very sad thing to see, which also means that we may have to strengthen that HIV TB programming little more strongly. However, I also understand that these findings may change over a period of time. Finally, this is verbal autopsy. It is possible that they may be misclassified, and therefore we may be getting such a report because there is a mixture of population. No, we would not know whether somebody died due to COVID or TB at this point in time when half the samples or more than half came from 221, December 20 to January 221. but it's a very interesting study. Now, we would invite Dr. Purnima Parmar, who's consultant in CST division, for delivering a talk on new interventions in ART centers.
Thank you very much, sir.
Please share your screen, Dr. Purnima.
Yes, I'm doing it. Just very good afternoon to everyone. I will be talking about the new interventions in the care, support, and treatment under National AIDS Control Program. I'll be talking about the rapid initiation, which has been rolled out, the dolutegravir-based regimen, routine viral load testing, as well as the private sector engagement, which we are working currently on. So coming to the rapid initiation of ART, as per the test and treat policy, every individual who is diagnosed with HIV infection are eligible for ART initiation, irrespective of the CD4 count or the WHO clinical stage, age, or any population by the general or the high risk group. So hence, it is very important to reduce the gap between the diagnosis and the initiation of ART, and that is why the rapid, or we call it same-day initiation of ART, has been introduced into the program. So coming to the rationale why we have introduced rapid initiation under the CST program is to strengthen the implementation of test and treat policy, to bridge the gap which was identified between the HIV detection and the ART initiation. There was a gap which was observed that once the individual is diagnosed with HIV, there was a gap in the ART initiation. So this is rapid initiation will definitely help in reducing that gap, bridge that gap. The LFU rates will help in reducing the LFU rate in the preparedness phase, or we call it pre-ART phase. Benefit the PLHIV in terms of travel in the difficult or hard to reach geographies and population, and subsequently better health outcomes, because there's a faster viral load suppression once we initiate the ART, reduction in opportunistic infections, tuberculosis, etc. So there were many national and regional level trainings which have been rolled out, and this is the algorithm which we have prepared and shared it to the states to roll out the rapid initiation and initiate the ART on the same day. So many trainings have been already been conducted. I'll not go into the algorithm, but the trainings have already been conducted for all the ART staff, and the rapid initiation has already been rolled out at the field level. Coming to the outcomes of rapid initiation. So with rapid initiation, we are going to attain faster viral suppressions in the PLHIV. It will also help in prevention of transmission of HIV, reduction in opportunistic infections, and of course better health outcomes. And in difficult to reach areas, or otherwise the travel time for PLHIV, when they were used to come twice, thrice to get the ART initiation done, will be reduced. Moving on to the next topic. This is the new initiative which we have taken under the CST program. We have transitioned the PLHIV to dolutegravir-based regimen, and all the PLHIV, whether adults, adolescents, children who are above 6 years of age, and the weight is more than 20 kgs, are being transitioned. And it will be the preferred regimen under the program, and we are doing it in a phased manner. There is a pediatric DTG 10 milligram also under consideration. So it is after the approval of DCGI, we will be also pediatric DTG dispersible will also be introduced under the care support and treatment. DTG is also safer when it is used with anti-ATT, which contains rifampicin or bedaquiline. For TB treatment, it can be given as first line, second line, and as well as third line regimen. and will also be used as post-exposure prophylaxis. We are in the process of initiating it as a post-exposure prophylaxis. So this will again help in viral load suppression. The global studies have also indicated that we achieve better viral load suppression when DTG is used. DTG-based regimens are used. When we compare it, 4 weeks for DTG versus 12 weeks for efavirenz, fewer toxicities and side effects have been observed, and it is a more potent regimen as per the global studies. However, there are certain concerns which are there around the DTG-based regimen, and there are two major concerns. One is the use of DTG-based regimen in women of childbearing potential and pregnant women, and there are very limited studies in India when it comes to the adverse effects of DTG. So, with respect to women of childbearing potential and pregnant women, the informed choice has to be given, and the counselors have already been trained to counsel them. There's extensive counseling which are provided, and once they agree, then only they are transitioned to or initiated on DTG-based regimen. And if they do not, then they are given alternate regimens. Although according to WHO, the benefits of DTG outweigh the risk. So certainly there are aspects that has to be considered when we're using DTG along with certain drugs, for example, carbamazepine, metformin, rifampicin, amlodipine, etc. So the dosage or the drug alteration has to be made when we're using DTG with certain drugs. As I mentioned in my previous slide, that there are very limited evidences when it comes to the Indian population. So we have also started routine and active monitoring of adverse effects of dolutegravir. The routine monitoring will be done at all the ART centers for all the PLHIVs initiated on DTG, and this will be monitored and recorded in the patient white card. However, we have also initiated active monitoring of adverse effects, which will be conducted at select centers, 60 select centers in all over the country, where in detail we will be monitoring this adverse effect of DTG, and this will complement the routine monitoring system of regular monitoring system. As I mentioned, that ARV is a lifelong treatment, so it is very, very important we monitor when we introduce a new drug. And dolutegravir will be the most common drug which will be used in coming times. And it is always reported to be safe and potent, well tolerated, but we have very limited studies available when it comes to the Indian population. However, there is also a potential risk of weight gain associated with DTG, but WHO suggests that with regular exercise and monitoring of the food habits, this can be controlled. Hence, we are initiating, we have already rolled out the routine as well as the active monitoring. As I mentioned that this will be integrated into the already existing system, the routine monitoring will be conducted at all the ART centers pan-India. However, the active monitoring will be done at select sites and will be complementing the routine monitoring system, and we will have more specific evidence with respect to the adverse effects of DTG. With this exercise, we are also expecting to strengthen the existing routine systems to detect, monitor, respond, and report the adverse effects of specifically dolutegravir. We'll also be able to identify known and unknown adverse effects of DTG and determine the association with the retention in care, regimen substitution, and treatment outcomes. Coming to my third topic is the routine viral load testing, which was introduced in the current financial year, where the viral load, it refers to the number of viral particles found in each milliliter of blood, and WHO has defined that a viral load less than 100 copies per ml, it indicates successful treatment. So this has been, according to WHO, this has been the preferred approach for monitoring PLHIV as compared to CD4 cell counts. So this has been rolled out under the program. This also helps, it provides an early and a more accurate indication for treatment failure and switch to second line drugs. So we are able to identify PLHIV who is showing signs of treatment failure at an early stage as compared to the indication through CD4 counts, cell counts. This also helps in reduction of drug-resistant mutations, and early identification then again leads to better clinical outcomes when it comes to PLHIV. And we can also understand the distinguish between the treatment failure and non-adherence. As I've already mentioned that it helps in identification of treatment failure and reduction in drug-resistant mutations. Coming to my last topic, private sector engagement. The private sector plays a very, very important role when it comes to the health setting, and there are a lot of patients who are coming from the private. There's a lot of to and fro movement between private and the public sectors. So for optimum results, both the sector needs to collaborate and work together, and that is why different collaborative activities for testing and treatment will be streamlined, and we are already in the process of doing it, and we are doing consultations to streamline the activities and collaborate with private sectors. So the main idea is to provide universal access to comprehensive quality care and treatment services to all the PLHIVs. And India is already a signatory to the goal of ending AIDS as a public health threat by 2030. And NACO has already taken various steps to encourage participation and partnership with private sector to achieve the global targets. So there are certain activities which the states will be taking up to involve the private sector under the program. It includes engagement of local professional medical associations, collaborating with private physicians, sensitization workshops, conferences, CMEs, establishing ART centers at private medical college as per the Gazette notification, and data collecting and reporting through the private sector partners. So with this, we'll be able to tap existing networks of private diagnostic laboratories, which will help us in achieving a 95, the first 95 goal, and involving the private doctors who are providing PLHIV, providing HIV care, will also help in attaining the second and the third 90 with the support of viral load testing and viral load suppression. So we'll also be doing capacity building, as I mentioned in the previous slide. This will also help us in standardizing the service delivery, the care, HIV care, and improving the reporting between the private and the public sectors. That's all from my side. Thank you very much.
Thank you so much, Dr. Purnima, for describing in detail NACO's new interventions aimed at improving the coverage and quality of ARV service delivery, whether it's same-day ART initiation, transitioning of TGG to TGG, and at the same time monitoring the adverse effects and getting some programmatic evidence, especially in the Indian population. That is great. And not to forget about routine viral load testing, which is an internationally accepted management tool for making sure that we are able to identify people who are resistant to drugs or drug failure cases. And private sector engagement is equally important. Thank you so much. Thanks to all the 4 excellent presenters. And now we are opening it for questions. In the interest of time, we would be taking maximum of 5 questions. And I know Dr. Sunil has been waiting very patiently for his question. So over to you, Dr. Sunil. I think your question is for Dr. Ganga.
Yes. Thank you very much. Thanks for allowing me. And I really enjoyed this session, though I joined a bit late, but lucky to be listening to Dr. Ganga Khedkar. It's always a pleasure to be listening to him because it's always informative. Today as well. So, Dr. Ganga, I just want to ask 2 small queries regarding the COVID vaccine. You gave a lot of information. One is that I read in the reports and papers coming up that now that earlier it was said that it has not been tested on children, but then one report said that yes, children can also be vaccinated. Is that true or no?
No. Children, as of now, the vaccines, the phase 3 trial on children is recently has started by AstraZeneca. No, we still don't have information on the same, and we would not like to give spike protein in whichever form to children, because we don't know what was it that was producing such a severe immune response in adults when they were infected. If it was spike protein, these vaccines also provide you spike protein. So essentially one should wait, and in any case, children tend to have milder disease. The likelihood of MISC is very rare, as much as we understand, and we are also cognizant of the fact that COVID is likely to become an endemic disease, and the age groups will continue to shift towards children, over a period of time. But it is believed that the children will escape severe disease.
And the lactating mothers also?
Lactating mothers, I differ from national guidelines. If I was to talk on personal viewpoint, I don't see why it should not be given to a lactating mother. The only concern which perhaps could be there is spike protein will pass from breast milk to the baby. But I think that likelihood is so small that if the mother can take it, perhaps she will also save her own life and ensure that the child will not be an orphan, at least single parent orphan, if she has any morbidity.
And this last one is about the people. There are some cases which have shown that after taking vaccine, some people had raised hypertension or blood pressure. Is it contraindicated, or is it really important to have your blood pressure checked? Because now that we are opening for 60 and above, we have already opened, and many of above 60, they have these kind of problems. Is it a concern that people with hypertension history or those who have blood pressure, high blood pressure, should be careful taking this vaccine?
I wouldn't say they need to be careful, but it is that hypertension tends to be labile. Many a times, those who belong to older age group have two important issues that could be associated with the lability. One is most of them are tensed up, having read in social media or read in the media or seen in the media about the side effects. So you need to at least ensure that their anxiety levels come down before they are administered vaccine. The second issue, which is also important, is we have to ask them whether they have taken their routine hypertension medicines as well. No, because during this tension, some of them may forget to take what they were expected to take. It also depends on the time that was allotted to them. But I think just a brief conversation with the patient will resolve those issues rather than it being treated as a contraindication or relative contraindication.
Thank you very much. Thanks.
Thank you, Dr. Ganga, and thank you, Dr. Sunil, for the question. Do we have any other questions for the other speakers?
No, ma'am. No questions.
Okay. Thank you very much. Thank you, my co-chair, Dr. Ganga, as well as the presenter, and all the other three presenters, and Dr. Sunil for this great questions, which are very relevant in the current pandemic or the dual pandemic which the country is facing. So thank you all, and a big thank you to Dr. Vanita for organizing this excellent conference and giving us an opportunity to be part of it. Thank you so much.
Thank you, Dr.
Thank you
Sangeeta.
from
Thank
my
you very
side
much.
as well. Thank you.
Thank you, Dr. Sangeeta. Thank you, Dr. R.R. Gangakhetkar. Thank you very much to all the speakers for joining us today. Moving on to our next session, I would like to call upon Dr. Sunil Arora, Professor, Department of Immunopathology, PGIMER, to chair the session. To co-chair this session, I would like to invite Dr. Mala Bhalla, Professor, Department of Dermatology, GMCH, Chandigarh. Welcome, sir. Welcome, ma'am. Handing over the session to our chair and co-chair. Thank you.
Thank you very much. I welcome you all to this next session, which is basically on virus and comorbidities. And before we start the session, I would like to thank Dr. Vanita Gupta and her team for letting me do this and inviting to chair this session and give a talk as well. It's a pleasure to be associated with this program, which has been going on for many years, 10 years, and I have been associated very closely with Dr. Vanita Gupta. She's a very dynamic lady, and since morning, every person has praised her. So I think I'll take this opportunity to say my thanks and congratulate her and her team for doing this very great job. So moving on to this session, what I'll do is I have requested my co-chair, Dr. Mala Bhalla, that we can make a little bit rearrangement in the sequence of lectures. So since I'm going to speak on viral evolution, Dr. Gurleen will be speaking something very close to this particular topic. So I requested Dr. Mala to speak either before me or after Gurleen. So she herself said that she will speak in the end of the session. So for the time being, I hand over mic to Dr. Mala to start the proceedings, and then we will carry on with the lecture. In the meanwhile, I'll ask the organizers to allow me share the slide. Okay.
Thank you so much, sir. And
okay.
thank you, Dr. Vanita and her entire team for inviting us to be a part of this wonderful conference, which is unique in the sense that it brings so many people from different streams together. And as sir said, that he's going to be the first speaker and he needs no introduction. So I'll invite Dr. Sunil Arora for his talk. He's, as you all know, is a professor in the Department of Immunopathology at PGI Chandigarh. So over to you, sir.
I'm trying to, okay.
Share.
So you shared your screen, yes. And
is
now,
it okay now?
Yes, sir. And just go on a slideshow, sir.
Good afternoon. Is it now visible in the slideshow mode?
We are waiting, sir. Just click on the slideshow, please, once, sir.
I have clicked on slideshow.
Okay, so you need to swap your displays, sir.
Actually, is it okay?
I think you must be seeing the full screen on your end.
Right? I am seeing the full screen on my computer.
Oh, okay. So you need to swap the screen, sir. Go to your full screen and just drag your arrow and shift it to the left-hand side, the whole screen itself. Can you do that?
Let me stop share.
Yeah.
I'll have to, actually I shared my whole screen. So
yes,
what?
Just share your, just open your PPT, PowerPoint, and go to the Zoom and just share your presentation. That's it. Don't share the whole screen, sir.
Is it okay now? Can you see the slide?
Now is it on a full, just click on the full screen, sir.
Is it okay?
Again, it is back on the slideshow mode only, sir. It's not on it's not on the slideshow mode, sir. I think you must be looking at the slideshow, right?
Yes.
How about this? Let ma'am start first, and then I can at the back end can help you out on the phone, sir. Will that work?
Oh, hold on a second. Let me try once more.
Oh, okay, sir. Okay, sir.
If I
you need to go on the display option, sir. Can you see on the top bar, on the menu bar, there's a slideshow.
If I go to application window, I see two screens. One is full screen. Another is, I do this, share, and
yes.
then
now minimize all of this, sir, please. Now minimize your screen.
Minimize the screen.
Yes, go to the desktop, please.
So should I minimize the screen?
Yes, sir. This one. Yeah.
Okay. Now you can see my slide.
No, sir. I'm not able to see your slide. Waiting to. Just click. Is it okay if I give you a call, sir? And by the time ma'am can start her presentation, will that be okay?
Yeah. Yeah.
Okay.
Sure.
Ma'am, please do the honors, ma'am. Thank you.
Sorry about that.
Okay.
No, it's okay.
Okay. So
Dr. Mala, you can go ahead and present your this thing.
Right. Okay, sir. Okay, let me share my screen then.
Can you see my screen now?
Yes, sir, we can see your screen, so you'll have to.
Is it on slide mode now? No.
No, sir. Sir, can you see the slideshow? There's an option of slideshow on the top, sir, next to animations. Just press escape once. Just press escape.
Escape, yes.
Yeah, and just go on the top, where file and home insert design is written. There's an option of slideshow there.
Yeah.
Yeah, just click on slideshow once. No, not this one, sir. The word slideshow itself. Next to animations, yeah. Next to animations, yeah. Right. Like click on this. Now there's a use presenter view. Just remove that on the right hand, extreme right, sir. Extreme right. Not the left. Use presenter view is there, sir. Right side, sir. Right side. This next to this. Use presenter view. Just uncheck this, sir. Now go on a slideshow mode, sir.
Okay. Okay.
We are waiting, sir. Just a minute.
Now you can show. You can see the slideshow mode.
No, sir. And now you need to press press escape again, sir. With all due respect.
Yeah, escape.
And now press. Is it a Windows phone, sir? Windows laptop?
Yes, Windows.
Press Command or Command P, sir. Or Control P.
Control P.
And there must be an option of duplicate slide. Control P, sir. Or Windows P. I'm so sorry. It's not Control P. It's a Windows phone. So there's a window button. Just press Windows and P. There's a duplicate option of screen, sir.
Yes, I'm doing that duplicate.
Okay. So, and now just go on the slideshow mode, sir.
Hello, Tarun. Can we move in this format only if it is not going?
Okay. So will you be comfortable presenting this, because we can see your slideshow, but not the whole full screen mode, not on a full screen mode, on a shorter view, but we are able to see your screen.
Yeah, and we are at least able to see it in a good way.
Sir, I think you can present like this because these slides are visible.
Okay. So can you see my slide now?
Yes, sir.
Okay. So I'm sorry for the technical snag. In this particular session, I'm going to talk about the genetic evolution of HIV in the host during course of disease and influence on the of comorbid conditions. Dr. Ganga Khetkar and subsequent speaker have already made my life easier by saying that the certain comorbid conditions, the virus, when it is growing in a host, it basically changes its mode, and there are so many mutations, there are so many genetic alterations, they basically occur in the virus, which changes the nature of the virus. So we are going to talk about those in this. So if we talk about the HIV origin, it is also believed to be have originated in some of the non-human primates, like chimpanzees or African green monkeys or those individuals. And it has somehow jumped the species to humans. And in the human, it has adopted, and then it is growing there. So basically, when the virus has come in the humans, it has further genetically diversified, and there are so many different, genotypes of this virus. So HIV-1, we know about HIV-1 and 2. HIV-1 basically belongs very close to a virus which exists in chimpanzees. So chimpanzee virus, the chimpanzee is a natural host for that virus, and this chimpanzee virus is cannot infect now humans, and human virus cannot go back to chimpanzees. But genetically, if we look at the sequences, we see that HIV-1 is a sister virus of this, and it is very likely that the HIV-1 has evolved from chimpanzees, and further it has evolved into many subtypes like group M, group N, and group O, and group M being the most prevalent one.
Sir, are you moving the slides forward? Because the slides are not moving. We are stuck on the first slide only. Okay.
Now you can see this, okay?
Yes, sir. Yes, sir.
Okay. So this is now it is okay. That's fine.
Yes, sir.
Yes, sir.
Okay. So HIV-1 is closer. Can you see my cursor also?
Yes.
Yes, sir.
Okay. Okay. Then now we are fine. So HIV-1 is closer to this, and HIV-1 basically further divides into HIV group M, N, and O. O is the outlier, and we have the M1, which is the M is the major one which is causing all the disease around, and we have many subtypes of this, and the A, B, C, D, G, H, J, K, and many circulating recombinant forms, and that's how the virus is genetically diversified. Whereas HIV-2 is more close to the simian immunodeficiency virus, which is found in sooty megabees, which are also monkeys which are living in West African jungles, and genetically very close to it. And all these, they are closer to simian immunodeficiency virus, which is from the African green monkeys. So basically, we have the HIV-2 very far away from, genetically far away from HIV-1, but these two viruses, they infect the humans, whereas the other viruses, they non-human primates and everyone. So basically, this shows that how the virus is evolving. This virus belongs to a family which is called Retroviridae family. They are all the viruses which are RNA viruses. And among them, there is a genus called lentiviruses. These are the viruses which basically cause a chronic disease in the host, and they are slow-growing viruses and live for longer incubation period, and they cause this. So HIV belongs to this particular group with this family, because they have got two single-stranded RNA genome, and it carries with it the replication machinery in terms of its enzymes, which are the reverse transcriptase and protease enzyme, and also it is enveloped virus, and it carries all these glycoproteins in the envelope in the form of GP120, which are the knobs, and the transmembrane protein, which is GP41. GP120 is the protein which goes and binds to the receptor, which is called the CD4 molecule on the surface of some cells in humans, and all these cells which carry the CD4 molecule, they are called CD4 cells, CD4 positive cells. So virus will infect only those cells which carry this molecule on their surface. So the GP120 goes and binds to CD4, and that is not sufficient for the virus to get entry into the host, because it requires a co-receptor, co-molecule, which in the form of co-receptor, which can be either a chemokine receptor, which is called CCR5, or CXCR4. So it is believed that initially when the virus goes inside the humans, it prefers to infect those cells which have a CD4 along with CCR5. So in general, the virus initially infects all those cells which carry CCR5 receptor, and most of these cells are even the cells of phagocytic cell line, like the macrophages, monocytes, dendritic cells. They all carry this receptor. So it is also called the R5 kind of virus. But during replication and during its evolution in the host, it converts to start using the CXCR4 also, when the virus, when the disease in the active mode. And this CXCR4 is mainly expressed on CD4 cells, the lymphocytes. So at that time, a lot of cells which are getting infected are the CXCR4 carrying, and this virus, then the virus in a way converts from the R5 type to X4 type of virus. So once it attaches and uses this co-receptor, it lets the genome of the virus go inside where the RNA are released. RNA strands, they convert into cDNA, and there it uses its enzyme reverse transcriptase. And since this is the first step of start of replication, so most of the antiviral drugs, which we are called the reverse transcriptase inhibitors, are against this particular step. They block this reverse transcription, so they block the replication of virus. So once this cDNA is formed, it converts into the double-stranded DNA, which translocates into the nucleus, and then it uses its enzyme integrase to integrate this particular viral genome into the human genome, and then we call it the proviral genome in the human genome. And this has got its own, replication machinery along with it. So it basically transcribes into, whenever it starts the actively replicating, more RNA strands. Some of them they convert into the RNA strand which is going to be packed in this virus. Others they transcribe into translate into the proteins, viral proteins, which get packed and they bud out in the form of more virions. So this is important in the sense that I'm trying to tell you, because as it grows, there are steps where it uses an enzyme reverse transcriptase, integrase, and finally it uses the protease. And these are the enzymes against which we have the antiretroviral drugs which are going to block these. So the virus basically, once it goes inside, it starts a disease with a primary infection in initial stages, which converts into clinical latency, because this is the time when we don't see any symptoms and the virus still keep replicating, though at a very low rate, in the lymph nodes and all those organs where it keep hidden. You may see very low viral load in the circulation in the blood, but the virus is replicating. And as the virus is replicating, the CD4 cells are dying, and slowly there is a decline in the CD4 cells. And over the years, you find that when this decline goes below 200 cells per ml of the blood, then you see that the person starts having the constitutional symptoms and opportunistic diseases. And this rate of decline basically decides the progression of the disease. So we monitor these with the progression of the disease, and nowadays we keep monitoring the viral load also, because now that each and every person who is detected HIV positive is started with antiretroviral treatment. And if we want to see the response to antiretroviral treatment, then we think that the virological marker is the viral load, because that is the first thing which can be monitored, that whether the virus, person is responding to the antiretroviral treatment or not, as it has been said by other speakers also. So the viral load goes down quickly. If it doesn't go down after antiretroviral treatment, that means we can call that person can be non-responsive to the antiretroviral treatment, and then he may require change in the regimen in the form of second-line treatment or subsequent change in the regimen. So we have typically many different types of individuals depending on the progression of disease, which is monitored on the basis of decline in the CD4 count. This slope can be very typical when the decline goes below 200 in about 7 to 10 years in non-treated individual. But in some individuals, this decline is very fast and sharp. And these rapid progressors basically have many different factors which are affecting the faster decline. They may be genetic factors, nutritional factors, they are geographical, or certain comorbid conditions like co-infections or existing disease or substance abuse. And it is seen that, as it was said, that people, Dr. Ganga Khedkar mentioned that when they did that survey, many people who were dying at home, although they were taking antiretroviral treatment, they were dying because most of them, they had tuberculosis. So tuberculosis is one of those comorbid conditions where even on treatment, some people, they die faster. And today we'll try to show why this is happening. So HIV-TB co-infection has a great impact on the disease progression. The infection increases the likelihood of new MTB infection while progress rapidly to TB disease. Among the HIV-infected individuals, there is a lifetime risk of developing active tuberculosis. It is about 50%. So compared to 5 to 10% in the persons who don't have HIV. So there is almost 5% or 10% increase in the chances of getting tuberculosis, whereas in the presence of TB also allows the HIV to multiply faster, and the people living with HIV are 6 times more likely to die during TB treatment even. So this is the reason why we thought that maybe there are reasons why we should think about that the virus is changing much faster in these individuals. Long time back in 2004, even Nelson Mandela mentioned that TB and HIV is a double trouble. So if we are trying to manage AIDS, we should first look at whether we can manage the tuberculosis as well. Because once they get together, they make a very, very wrong combination, and the people, they don't really behave very nicely. So there have been papers lately which have shown that when there are elevated turnover of lymphocytes, this basically is because of accumulation of deleterious mutations in the virus. So what we envisage is that if people are dying faster in people who are HIV and TB co-infected, maybe there are certain genetic alterations which are occurring and they are accumulating in the virus, which somehow changes the nature of the virus to make it more replication competent. Similarly, there are other papers also which have shown other genetic alterations, and one would like to think to understand if these two factors are related to the enhanced replication competence of the viral moieties and hence increased disease progression in HIV-TB co-infected people or individuals who are on, say, intravenous drugs use. So why we think that there are, chances of acquiring new genetic variations? It is because of the high replication rate of this virus. This virus replicates very fast in the host. 1 to 10 billion copies of the virus are made every day on an average in a HIV-infected individual. And as it replicates, it acquires certain mutations because, as I told you, that the first step of replication is the reverse transcriptase. And reverse transcriptase is a enzyme which basically lacks the proofreading capacity. In our system, when the DNA replicates DNA to RNA, RNA to protein, the DNA to RNA is a DNA polymerase enzyme. It has got a proofreading capacity because during polymerization, there are wrong nucleotides which are added into the genome while replicating a copy of the, making a copy of the DNA. But then the enzyme goes back and checks those errors, remove the errored nucleotide and puts a right one. So this is called proofreading capacity. But this reverse transcriptase doesn't have that proofreading capacity. So there are more chances of having errors. So there is one error per 10,000 bases which are added to the DNA molecule, which is made from RNA to DNA, reverse transcription. So there are chances of acquiring 1 point mutation per replication. So this is a very high chance of acquiring a lot of mutations, and these lead to the accumulation of some quasi species of the virus which accumulate in the host during replication. So all those people where the viral replication is not suppressed, there is a chance of accumulation of these kind of mutations more than in those individuals where the virus replication is suppressed. So that is why the more emphasis is nowadays on the strategies where we can, how effectively we can suppress the virus replication or keep the viral load very low, as it was said initially by another speaker, that is the emphasis by using different strategies or different newer mechanisms. how we can do that. So there are many other factors like viral factors, cellular factors, and other operating products which can affect all this, accumulation of these mutations, and the rate at which the HIV infected individual progresses to AIDS may be explained by the combination of all these factors. So there are certain genetic factors which are already established. Like we all know that if in the CCR5, which is a co-receptor for this virus, if there is a delta 32 mutation, then the cells will not allow the viral genome to enter. That means all those individuals who have a delta 32 mutation, they are immune to HIV infection in a way. Similarly, there are other genetic mutations which may increase the susceptibility or risk of transmission and rate of disease progression. They are like in the HLA types, if you have B27 or B57, then the disease progression is very low. But if you have B35, the disease progression seen is very fast. So a few years back, we had published an article where we have shown that the Mycobacterium tuberculosis in a co-infected individual modulates certain genes, which leads to higher replication of HIV and faster disease progression. And we had shown very clearly that HIV makes the condition favorable for MTB because of immunocompromised situation. But on the other hand, MTB also makes the HIV to replicate faster in that individual, and that's why people move faster. I have already told you that antiretroviral treatment will fail in those individuals who accumulate certain mutations in their genome because they may not respond to the treatment. So how can we envisage this? Suppose this is the initial stage when a person is infected with the virus. All those fluorescent looking yellow dots are the viral species which are wild type. They respond to the antiretroviral treatment. But in between, you have seen 3 pink dots, which are the viruses. Suppose they are the mutant viruses. When we put this person on a drug, then due to drug pressure, all those wild type viruses will stop replicating. But the pink type, they are the mutants, they will not respond to the drug, so they will start replicating. And over the years, you see as the disease progresses, you will find that these will become dominant type of viral species. So this person can fail antiretroviral treatment because of the predominance of this kind of viruses which do not respond to the primary regimen. And that's why they are changed over to second regimen, where these drugs are changed, and we see that they may respond to the treatment. So we can actually detect these by phenotypic assays as well as genotypic assays. In genotypic assays, what we essentially look at is the mutations, as told by Dr. Ganga Khedkar. And this COVID has done something good also, because even in the general public and all those people who do not know the molecular biology also, they have also started understanding what are mutations. So as we know about the SARS-CoV-2 new variant, there's a mutant variant which is coming up, the UK variant, which carries the mutation D64G. That means that there is one amino acid which is replaced by another amino acid at a specific location in the genome. Similarly, in the HIV genome, there are so many mutations they occur where the amino acids are changed. And in this list of these mutations, you see that these are nucleoside NRTIs, these are NNRTIs. They are the reverse transcriptase inhibitors, which form the combination of our antiretroviral treatment, and these are the protease inhibitors. You see that these mutations, they may cause resistance to these drugs, which are basically form the first line regimen and second line regimen. Some of them are red colored. We show that these are the mutations. If they occur, they actually lead to very high level of resistance against these drugs. Whereas blue ones, they cause intermediate or low level of resistance. Like if M81V mutation occurs, then that person will never respond to lamivudine. So you can see that there are certain mutations which are very high impact mutations and they cause very high level of resistance. Some mutations, they cause low level of resistance. So this is a list of one. We can actually do that by amplifying this gene and going ahead with the sequencing and then going ahead and looking at, I'm trying to pass some of these because I don't want to go into detail because of paucity of time. So ultimately we go to the database and look at the sequence of the virus and then try to see whether there are mutations or not, and then we characterize them. So what we did in our last couple of years, we try to check in some of the individuals who were mono-infected, means they were only HIV infected, and we try to follow that and we try to look at how many mutations they have accumulated. We found that out of say 50 individuals or 30-40 individuals, only 4 of them, they showed some of these mutations when they were mono-infected with HIV only, but most of these were low-level resistance. Only one individual had this high-level resistance. But when we looked at a group of those individuals who were HIV TB co-infected, same number of individuals, we found that most of them, some 4 of them even died during the antiretroviral treatment, but most of them, they accumulated those mutations which can provide very high level of resistance. Similarly, we look at individuals who were on intravenous drug use. There also you find that accumulation of these mutations which can cause very high level of resistance was much higher. So if we compare the data, that out of all the individuals, 18% in the mono-infected showed some mutations which were of low resistant capability, whereas 40% of these individuals in other groups, they acquired those mutations which could impart very high level of resistance. So that's the reason maybe why these people were dying faster and they were not responding to the treatment. So this is how I explain that the virus evolves much faster in those individuals which have certain comorbid condition. Same thing is applied to other viruses like even SARS-CoV-2. You are looking at that if you do not suppress the viral replication, there are likely chances that the virus will replicate faster and it will acquire mutant. And if you don't take vaccine, suppose, then the individuals who are actually susceptible to the virus, they will generate certain mutants which may escape even the viral, the vaccine immunity. So that is why it is very important that everyone should take the vaccine so that it can keep the viral replication low. So if we keep the viral replication low, there are less chances of development of mutant variants, and there are less chances of having a escape mutant, that's the reason. So then I talked about the NF-kappa B sites. This is HIV genome. We know that HIV replicates faster in those cells which are actually activated cells. So activated cells, activated immune cells, they occur only when there is a immune activation. So immune activation basically leads to generation of a lot of NF-kappa B. NF-kappa B is a molecule which is available in our blood, but it is found in the inactivated form because I-kappa B keep bound to this. But in case of certain conditions where there is immune activation, another kinase which is called inhibitor of kappa kinase, it removes this I-kappa. So this dimer goes inside the nucleus and binds to the genome and leads to the replication of a gene. So this is what happens in the HIV also, because in the LTR region, the long terminal repeat region of HIV genome, we have 2 sites of NF-kappa B. So whenever there is NF-kappa B generation, then the virus replication also increases along with the cytokine formation and other things, So that's why there is a report earlier which had shown that in HIV subtype C, there are multiple copies of this NF-kappa B binding site. More than 2 copies can be there. So what Goodlean did was she tried to detect some of these in the and she will show you data herself. So in summarizing my talk, the HIV basically accumulates genetic variations in its genome as it grows in the human host, leading to emergence of certain genetically diversified viral species. Such virus evolve faster in those individuals who have comorbidities like HIV-TB co-infection, or those who are using intravenous drug use, or those who are co-infected with other things also. There, the virus gets a chance to replicate faster, and it acquires certain genetic alterations in terms of higher frequency of drug resistance mutations, high number of NF-kappa B binding sites. And these genetic variations make the virus more replication competent, and they cause the faster disease progression and with a stunted response to the antiretroviral. Finally, I would like to say that as per current guidelines, we have that ART is started irrespective of CD4 count. In such a scenario, if the virus has already accumulated mutations, the choice of antiretroviral treatment in the first line regimen would need to be articulated according to the drug resistance profile of the circulating virus, which is important, although it is not done in our program, but it should be done, because that only then we can see that the people, they respond very nicely to the treatment. So I'd like to acknowledge Gurleen, who has done some basic work in this, Dr. Aman Sharma, who is our clinical partner also. He is a professor in internal medicine, and Jaideep, who was my previous student. Thank you very much. So I'd like to take up some questions if there are. Or we can go ahead with the presentation by Gurleen also, and then we can take the questions later on. Thank you very much.
Thank you, sir, for a very enlightening talk. So now I'd like to invite Dr. Gurleen Kaur, Technical Officer in the Department of Immunopathology, PGI, for her talk, which is acquisition of certain mutations in the HIV genome in patients who are HIV-TB co-infected and intravenous drug users. Dr. Gurleen.
Good afternoon, everyone. Thank you, chairpersons, and I thank the organizers for giving me this opportunity to present my work. I hope I am audible.
Yes, ma'am, you are, ma'am.
Thank you. Thank you. So my work is acquisition of additional NF-kappa B, which is nuclear factor kappa B binding sites in the LTR of HIV-1 genome in the HIV-TB co-infected and intravenous drug users. So as per the UNAIDS data, we know the highest prevalence is there in African countries, and India has less than 0.5%, which is estimated at 0.22% in 2020. Although India is considered to be a low prevalence country, yet it is the third largest, it has the third largest burden after South Africa and Nigeria. So to start with, human immunodeficiency virus, which is HIV-1 infection, is known to be the leading cause of morbidity and mortality throughout the globe. HIV-1 has been known to be a significant predisposing risk factor for individuals infected with MTV, increasing the risk of active disease by 20 to 37 times, which is too much. Unusual disease progression is also observed in the HIV patients who are infected using sharing of needles and are on intravenous drug abuse. The mechanism, although involved in the altered immune defense and synergistic effect in these comorbid case conditions, is still not well understood. So as we know, 38 million people are living with HIV, and 1 in 10 people with active TB are also living with HIV. And as per UNAIDS, tuberculosis remains the leading cause of death among people living with HIV. It is also said that the risk of developing tuberculosis is estimated to be 16 to 27 times greater in people living with HIV than among others without HIV infection. The same facts for IDUs. About 1 in 10 new HIV diagnoses in the United States are attributed to injection drug use or male-to-male sexual contact and injection drug use. So as per literature, one of the mechanisms by which the virus evades the immune defense system involves the obstruction of NF-kappa B signaling cascade. So it is very well documented that HIV dominates the host machinery and generates its copies at tremendous speed while spreading to the lymphoid organs and the bloodstream. Hence, we wanted to look upon the genetic evolution of HIV in terms of NF-kappa B binding sites in these comorbid cases. So what is NF-kappa B? Sir has already explained, but I will just share a brief about that. NF-kappa B, that is nuclear factor kappa B, is a major transcription factor that regulates genes responsible for both our immune response, may it be innate or adaptive, and it is sequestered in the cytoplasm, and it plays a very, very important role in the HIV gene expression, and also has a very significant impact on the host defense regulatory response against this deadly virus. HIV-1 uses the host machinery, as we all know, to produce the virion particles and finally bud out of the host cell membrane, and it produces and infects also many more cells. The transcription of this HIV, now this transcription initiates at the LTR region, which is a long terminal repeat region, and the transcription activity of the LTR that controls the activation and latency of this virion is regulated by this transcription factor. So the viral promoter region with the 5-LTR contains two identical NF-kappa B sites, which are found to be highly conserved among certain HIV subtypes. And also, as Sir said, reports also suggest that HIV-1 acquires multiple NF-kappa B sites and achieve higher level of transcription activity. And these strains gain potential selective advantage in terms of co-infected cases, and as a result, multiple transcription sites happen in the coexistence of these two bugs. So this is again a picture of the genome, and we can see two intact NF-kappa B sites in this region. So the research question was, does MTB or this bug cause any genetic change in the makeup of the virus in the co-infected individuals that may facilitate the disease progression? Sorry. I'm sorry, one second. Yes. And whether this HIV acquires extra NF-kappa B binding sites in the presence of the two comorbidities, making it more replication competent. So we hypothesize that the MTB or the substance abuse facilitate the progression of HIV disease by increasing the viral replication through the activation of the immune system. And this TB or substance abuse mediated HIV replication leads to increase in the HIV viral loads and genetic heterogeneity. And this increased quantity and diversity of the HIV causes species allow for the evolution of morphic genetic variants, which may facilitate the disease progression further. So we aim to highlight this particular attribute if the virus acquires any extra NF-kappa B binding sites in our study cohorts. So objective was also to study immunological, virological, and clinical disease progression in the three cohorts, which I will describe further. So this disease confirmation was done, the HIV disease confirmation was done as per the NACO protocol. And for the TB thing, we chose only those patients that were positive for TB by chest X-rays, put them smear positive. So the HIV disease status were monitored by two important components, that is CD4 cell count and viral loads. CD4 was determined by flow cytometry based assays, and the viral load was processed by quantification by the Roche-Techman system, and it was used to quantitatively determine the HIV-1 plasma RNA based on the PCR assay. So these are the demographic details of the patient as well as the immunological and virological details. So we included these three cohorts, which were first was HIV mono-infected, only infected by HIV. The second group was HIV and TB co-infected, and the third was HIV, who were HIV patients who were infected via drug abuse. So if we see the cell count, CD4 cell counts was observed lowest in HIV TB, and the viral load copies, again, the same way, was found the highest in the HIV TB group, which was followed by the HIV IDU group, and least was found in the HIV monoinfected group. Although we did not find any significant difference in the CD4 counts in the three cohorts, but we found a very significant difference in the HIV TB, HIV IDU viral loads with the p-value of 0.0114. Then we proceeded with the LTR gene amplification. To start with that, we extracted genomic DNA using a commercially available kit. We designed the LTR specific primers. Both internal and external primers were designed in the laboratory. This was the amplification reaction used for processing the nested PCR, and the internal and external primers used for this nested PCR process. After the PCR, the amplified products that were obtained after this were analyzed by electrophoresis on the gross gel, and you can see the picture there. The amplified products were then subjected to sequence determination, which was obtained on a sequencer, and the blast analysis was also performed by using the NCBI nucleotide blast. Then we move further to see the clade analysis. Clade analysis was very important because we were working on HIV subtype C, which is predominant in our country. So we wanted to include only those patients who were HIV subtype C. So for that, after the sequence analysis, we do this clade analysis, which is done using context-based modeling for expeditious typing software. And after that, we found that our subjects belong to HIV C subtype. Only these subjects were further used for analysis. Then cluster W alignment was done using the BioEdit software, and the alignments were processed in the BioEdit system. And these sites, which are actually what we were looking at, was the NF-kappa B binding sites, which we could only obtain after getting through all this process. And the NF-kappa B binding sites were searched using the TF search program in the BioEdit software, in the software that I just showed here. So when we plotted a scatter graph, we could clearly see a very good significant difference between the number of kappa B sites in HIV TB and HIV IDU vis-a-vis HIV monoinfected with a p-value of 0.0411. So if we see in the HIV TB cases, there were 26 cases, and out of that, 16 sequences that we obtained had 3 sites and 10 sequences had 2 sites. And in case of IDU, 13 sequences are found with 3 sites and 7 sequences with 2. But if we see only HIV infected, there were only 10 sequences that had 3 sites, 18 with 2, and only 2 sequences that had only 1 site. So we further wanted to see the correlation, how these kappa B sites, did they have any correlation with the viral load? And yes, we found a very positive, strongly positive correlation between the NF-kappa B sites and viral load in the HIV TB co-infected as well as in the HIV IDU group. However, we found a negative correlation between the kappa B and viral load in the mono-infected group. So after finding this positive correlation in both our study groups, we went back to see the clinical profiles of the patient to see the number of deaths, if any, in these groups. And we found more patients who died in the 2 cohorts, that is HIV TB and HIV IDU, as compared to mono-infected. And if we see this data, out of all these patients, only 1 patient died in the mono-infected, but 5 patients died in HIV TB co-infected group, and in the same way 3 patients died in the IDU group, and all these patients died within 3 months of ERT introduction. So this data, this positively correlates with the results observed in our study, that in case of acquisition of extra NF-kappa B binding sites, there is decline in CD4 counts and increase in the viral load, and hence the virus become more application competent, leading to increased disease progression and hence death. To summarize, we found the mean of the mean CD4 count in the individuals in these 2 groups, the study groups, was much lower than the mean in the mono-infected, but the plasma viral load number was very significant and higher with a p-value of 0.011. And interestingly, as we had hypothesized, the results came out to be the same as per the hypothesis, that a higher number of NF-kappa B binding sites in the LTR region was observed in the HIV-TB co-infected as well as in the IDU patients as compared to mono-infected cohort with a p-value of 0.0411. And also the RNA copy number positively correlated with the NF-kappa B binding site with a Spearman coefficient of 0.5074 in case of HIV-TB and 0.5183 in case of HIV-IDU. These observations indicate that HIV undergo genetic evolution in these two comorbidities and seem to acquire some extra nucleofactor kappa B binding sites in the LTR region, which enhances the viral transcription and thus making the virion more replicant competent, leading to faster disease progression. So to conclude, the data clearly shows that there is genetic evolution and there is acquisition of increased NF-kappa B binding sites in these two particular comorbidities. And our current results provide a platform for discovering which intercellular interventions may enhance host immunity and may have implications for testing and optimizing new vaccine and therapeutic strategies that minimize non-specific or off-target side effects. Thank you.
So thank you very much. We can move on to the next talk and we'll take the questions at the end. Dr. Mala, please carry on with the
Yes.
please.
Yes, sir. So I'll share my screen. Is my screen visible?
Yes, ma'am.
Right. So my topic today is experience with STIs during the pandemic. So as you all know, sexually transmitted infections are a unique group of disorders which nobody wants to talk about, including the patients. So that is why it is also known as the hidden epidemic. So the patients want full confidentiality. They don't want to reveal who they are, but they want instant treatment of their disease. So the pandemic, as it affected all our lives, it affected the STIs also. So complete lockdown was initiated on March 24th for 21 days. And so all the OPDs came to a halt in the government hospitals. Then subsequently, there was the unlock strategies, which started with the lifting of the restrictions. So all these social measures that were put in place were thought to curb the spread of COVID-19, also influence the sexual risk behavior of the individuals. And also these lockdown measures also affected the consultation services because they became very limited. Also, this limited the clinical and lab diagnosis of STDs and presumably also their transmission. So it can be said that the COVID pandemic had both a direct and an indirect effect. Direct in the sense that a possible sexual route of infection of SARS-CoV-2 was also hypothesized, so that could have played a role in decreasing the high-risk behavior. And the other indirect effects were that the social distancing measures limited the social contact and therefore the unprotected sexual intercourses with multiple partners. Along with this, the psychological impact of the lockdown was there, which highlighted the great amount of stress experienced by everybody, that is anxiety, fear, lack of interest, and frustration. As well as the decrease in visits to the medical services were there because of the social confinement or because of the concerns about being exposed to the COVID-19 infected people. So how did this pandemic affect the healthcare? So especially talking about our institutions, that is the government medical college and hospital. So the physical OPDs were halted, but the teleconsultation was started. So as is known that you have to adapt to different situations. So that was our adaptation strategy to start the teleconsultation. So initially, a phone consultation services were started, and then subsequently online e-Sanjeevani was also started. So we thought we should find out how this affected our care of the sexually transmitted diseases. So these are the details of a teleconsultation that from the records that we've taken out. So on a retrospective review of our details that were done for 4 months, that is from April 2020 to July 2020. So the total number of patients seen on teleconsultation was 652. And out of this, the STD patients numbered 13. So which was a percentage of almost 2%. There were 9 males and 4 females. That is, the males were almost double the number of females. The urban and rural were almost equivalent, as were the new and the old patients. So now this was interesting that the mode of consultation was basically the image only along with the chat in 3 patients, while in 10 patients there was the image was sent along with the audio call. But interestingly, none of them wanted to do a video call. But that could be attributed to the fact that all of them wanted anonymity and they did not want to talk face to face, though they wanted to talk for all the reassurance and for clearing up all their queries about the disease. So in the age range, as we can see that as is usual, that most of the younger age group was affected. That is, most of the patients, about 11, were below 50 years of age. The area was, as our institute is in Chandigarh, so there were 7 from Chandigarh and Haryana, Punjab. Maybe this is because of the fact that initially the services were open to these areas only, because otherwise for teleconsultation there may not be any bar to the area which you can basically service. So in the education, most of them were matriculation and above, maybe because these people are happier with technology which was needed to actually do a teleconsultation. So the duration of the disease usually varied from 5 days to 4 months. Past history of some STD was present in about 10 patients, whereas in 3 cases it was the first episode. So these 3 cases were 2 of molluscum and 1 of herpes. So the additional tests were ordered in the 8 patients. That means the HIV testing as well as the VDRL testing was ordered in these patients, and they were asked to basically get the tests and get back to us. So the diagnosis that was seen was melanocystitis in 4, vaginal discharge in 2, genital ulcer disease, that is herpes genitalis, in 1, and basically there was confusion between chancroid and primary chancre in 1 patient, genital warts in 3, and molluscum contagiosum in 2. So as can be seen from this, the viral STDs are still taking the majority of the cases. So basically we have more of the HPV as well as the molluscum virus as well as the herpes. So the certainty of the diagnosis, because this was now based on the images that the patient had sent and the history that they were giving and the picture clarity. So all that made the certainty of the diagnosis a bit in doubt in certain cases, but we were absolutely certain in 5 cases, which included 3 of warts, 1 of molluscum, and 1 was herpes. And not too much certainty was there in the genital ulcer disease, because the genital ulcer could be seen, but the exact characteristics could not be differentiated. And also the vaginitis cases, because though the diagnosis of vaginitis could be made, but obviously the speculum examination could not be done, so we could not differentiate whether it is cervicitis or just vaginitis alone. So to come to the discussion, so when we compared this data with our data from 2019, where the normal life was going on and the usual physical OPDs were in place. So the total OPD patients that we saw in 2019 during the 4 months were about 24,197, whereas as compared to 652 here. But the STD patients in 2019 were 215, which is a percentage of 0.8%. Whereas now we saw 13 patients, which is almost double or more than double the percentage, that is 2%. But as you can see that the male is to female ratio remained almost the same. Like earlier also, they almost double the amount of females who present to the OPD. So none of the patients, as I said, wanted a video consultation, but majority of them wanted to talk, probably because reassurance and counseling is very, very important in sexually transmitted diseases. And the duration of the disease was least in herpes, that is 5 days, probably because of its painful nature, whereas it was more in the other diseases like molluscum as well as the warts, which are asymptomatic conditions. So probably the patients were ignoring it or thinking that they might go away altogether, but they came only when they could ignore them no longer. So that was about the patients, but we as doctors also had to change our management approach, because we could order investigations only if absolutely essential, because the patients were a little apprehensive about going to various places to get the test done. As I said, vaginitis could not be differentiated from cervicitis. And also we had to change our treatment strategy. Like in warts and molluscum, usually we prefer the physician administered therapies like the podowart or the enucleation of the molluscum. But now we had to prefer imicamode or the patient administered therapies. And as was seen was that counseling was of utmost importance in these patients. So to conclude, sexually transmitted diseases depend on risk perceptions and behaviors as well as social determinants. So though we expected that probably because of the decreased risk behavior, they might decrease because of the various measures in place, but the percentage of patients actually increased. So this could have been due to the inherent stress of the condition, or maybe those patients were already having some problem. And other than that, there is a need for immediate treatment in the sexually transmitted diseases, especially if they are painful, like the herpes. And so we do need further studies from the patient's perspective as well about what they might prefer in the teleconsultation, or do they prefer a face-to-face approach, as well as we need to take out more data to see whether this trend continued over time or it became better. So thank you.
Thank you, Dr. Mala, for a very nice, insightful talk on your experience on STIs during the COVID pandemic. Now that the session is open for questions, if there are any questions in the chat box or somewhere, can that be said? No, I don't see questions there, but do we have questions in the no? There are no, but if anybody wants to ask any question or query regarding these presentations, I would like to just say that the response to treatment basically needs to be monitored based on the comorbid conditions, because in these comorbid conditions, the virus replicates faster and acquires certain genetic alterations, which can be dangerous because the virus becomes more replication competent. It becomes more non-responsive to the treatment which we have. So it is actually advised, or we may think of modulating the articulate our antiretroviral treatment based on certain genetic investigations, which is not being done in many countries abroad. People do the genotyping as well of the virus before they start the treatment. So we should know what is the genotype, how many mutations a virus has in a particular host, so that we can articulate the antiretroviral regimen accordingly. So if there are no questions, I would like to...
Sir, I beg your pardon, sir. Can I ask a question?
Please go ahead, Doctor.
Yeah, my question is to Dr. Mala, ma'am. And as we all know that, STIs over the time, somewhere even in the program, they've taken kind of a backseat, although we know that they are out there and they may be increasing as a very small number of people you have done teleconsultation with has thrown up that kind of data. So I was just thinking that did we take it a step further? And did we advise treatment on remote teleconsultation? And if there was, we did that, how many people responded to treatment through the teleconsultation mode? Just wanted to understand, madam.
Yes.
Thank
So,
you.
yeah, thank you for the question, Dr. Maninder. So we did advise them treatment. And as I said, like for the vaginitis, we usually give the oral ones only. And the problem was with the warts and the molluscum, in which we usually have the physician administered thing like the podovort and everything. So, but in those patients, then we gave them imicomod to apply at that area, because you can't kind of tell them also that, you wait it out till the time the hospitals open. So because the patients are usually so anxious, they do want something to be done. So that is why all of them were then the new patients also, they were ordered to get their VDRL as well as the HIV testing done, because that is the norm that we usually follow. And these patients were happy enough to get it done, though they were saying that we'll get it done only if it is absolutely required, because they were a little apprehensive about visiting the other sites. So other than that, we did call one or two of them for a physical examination also, in the ones that the diagnosis was not that clear. So I hope that answered it, that we did give them treatment.
Thank you, ma'am. Thank you very much for that answer. Because in my mind, I'm thinking that if teleconsultation or telemedicine is going to be coming into any extent, even within the program, then we may as well understand that, self-applied, even for warts and ulcers, if we say self-application or self-medication, we may have comparative studies later on, for even for a subset of populations where it may be more effective, which kind of people we may have to call, and if we can kind of build up evidence for STI management, it will be really helpful going forward when we talk about telemedicine. Thank you, sir, and thank you, ma'am, very much.
Thank you very much. Any other query or comment? If not, then I'll thank all the speakers, and I'll hand over back to the organizers and thank them for giving us the opportunity to conduct this session. Thank you very much.
Thank you very much, sir. And thank you, ma'am. I would once again thank Dr. Sunil Arora and Dr. Mala Bhalla for chairing and co-chairing this session. Thank you very much. Moving on to our next session, session 5, IEC, Information, Education and Communication. It's an honor to call upon Dr. Rajesh Rana, National Consultant, NACO, to chair the session, please. Dr. Rana is with National AIDS Control Organization, and he has more than 17 years of experience now in the field of HIV/AIDS. So we welcome him. We welcome you, sir. Handing over the session to you, sir, now.
Thanks a lot, Ms. Tinu. I would like to extend my thanks to Project Director ma'am also, and would like to congratulate the entire team for organizing this virtual Aidscon 10. So I think this is the last session before we finish the day. So without wasting time, I would like to request my colleague from National AIDS Control Organization, Ms. Koshambi Mudgal, to come and talk about the virtual arena, which is the new dimension nowadays, because we have seen in the past that with changing technology and with changing time, how communication is also changing and what new dimensions are there. So this presentation is about the campaign which has been undertaken by National AIDS Control Organization around World AIDS Day. So I would request Ms. Koshami Mudgal to please come and present. Over to you, Ms. Mudgal.
Till she comes on the stage, I would request Dr. Ms. Poonam Bakshi to hand over a floral welcome to Dr. Rajesh. Please put your hands together for him. Thank you, sir.
Thank you, ma'am.
Good evening, everyone. This is Kaushambi on behalf of National AIDS Control Organization. Thank you, sir, for setting a tone. And I will be talking to you about the virtual arena, which is the new dimension in communication. So amidst this pandemic, which was the most, the unpredictable thing for all of us, I think the word virtual actually has become, we all have become very friendly to this word. So let's talk about what virtual arena is and how it has, set a new dimension in the field of communication. So, traditionally or conventionally, I would say, so how we used to communicate? Like you and me, we are here on this platform, and we are interacting face to face. Or maybe we used to communicate conventionally through telephones, or we used to write letters, and we used to use the same kind of symbols, signs, or the same languages. That used to be the way. But now the definition has changed. So we got a tech platform, and with the help of that tech platform, we can connect with people who are, on the other floor, or maybe in the remote places. We can connect with all of them, and it is all possible. So there is a saying, virtual, real, and or you're physically present or you're not physically present, but the show, it must go on. And I would say all of us on states level and on national level, we have performed really well. And here we would be seeing few examples of that, how we have managed things virtually. So going on to the next slide. Yeah. So let's first understand, I would just like to talk about what makes a virtual arena. So these are the few platforms that we have been using, kind of aggressively. In the recent past, we have used them, like WebEx, Microsoft Teams, Zoom, Google Meet, YouTube, the social media handles, the live streaming of events we have seen in the recent past, like in the World AIDS Day event 2020, the webinars and virtual events. So all of this, comprise an arena which is known as the virtual arena. And out of these, I would say the social media handles have actually played a major role in, in dissemination of the right messages. And I would say this is something that is measurable and impactful at the same time. So I would just pick up one thing out of those all tech platforms, that how our social media campaign that was run on World AIDS Day created an impact. So for this, we actually defined our key performance indicators, and the first being reach, second engagement, third being the impressions that we get on our social media posts, the video views that we get, the cost per click, and through plays that we get on our video ads and all of our videos that we had run on the social media on the occasion of World AIDS Day. So I will be going in detail about all these at the last of the presentation. And moving next, I would just like to talk about the methodology that we had adopted for this. So as we all know, the theme of World AIDS Day was global solidarity and shared responsibility. So we had, that was the call of that hour, to develop the content about, how every one of us is showing solidarity and how we are sharing responsibility towards the elimination of AIDS. So there was a need of our to, frame the right content And hence we proceeded in this way, and we identified the right platforms through which we can disseminate the messages, and we can create a buzz in the industry, and we can talk about World AIDS Day. So then we decided, after creating the right content, we actually decided what should be the frequency of floating the content on various social media platforms. And the platforms that we chose were Facebook, Twitter, and YouTube. And you might have seen that event on YouTube as well. The live streaming happened and the huge traffic was generated. So along with this, we followed, monitoring the strategy and revamping the strategy. What was, we actually, I would like to say that everything in digital space is very well measurable. And if you choose the right key performance indicators, you can monitor it real time, although you are doing it online, but you can monitor it and you can revamp your strategy if that doesn't work. So the key areas wherein we focused during this campaign were importance of ART, safe sexual practices, prevention methods for the key population, and the social protection schemes that are available, through the national program and nutrition schemes available for the KPIs and PLHIVs. And also, I would like to say, having said this, I would actually like to thank Accelerate for supporting us throughout to bring the best in this campaign. However, the content repository was provided by NACO, and the strategic guidance was provided by NACO. But then, implementing the same and giving us all the support, that makes a lot of difference. Here, I would just like to give you a glimpse of the social media campaign that you might have already seen on all our platforms, wherein we talked about how at the ease of a click you can connect via NACO AIDS app, and what is the importance of ART regimen, and how we have done the multi-month dispensation. And the fourth creative that you see in the the upper row, that talks about, the TG talks about that testing ke saath HIV ko mat. And so these were all the creatives that were used to create the buzz around World AIDS Day. And these are few more, wherein the girl says makeup to check kar liya par HIV status ka kya. So hence we promoted testing in this, and many more. These are just to name a few. These are the glimpse of Facebook ads that we had run across, and we were continuously monitoring which of our ads are doing well and are generating a good organic reach, and in which we need to actually put money and boost the same. So I would like to play one of these ads for you, and I hope the kind of content you will that actually explains it well, why the post did well. The total reach being 33,80,220 people who viewed this real time. So there it goes. I think there is some technical glitch. The video isn't playing. I'll move on to the next slide, I guess. Okay, so this is one of the videos. Sorry for the technical glitch. And this is one of the videos that itself had an organic reach. When I say organic, that means without putting any sort of money, and it created a huge impact. 8,620 people viewed this video without any ad and without spending any sort of money. And the overall reach, how many people viewed this video, was 38,171. Moving on to my next slide. So I'll quickly actually talk about the statics that I showed you and the videos that we had floated. The static posters that I just showed you created the reach of 338,717 people. So reach is basically something, how many people viewed your, any kind of post that you had put, how many people viewed that, and to how many people it reached. And the engagement, which you can see in the first column, it is about the static posters and the GIFs. It was 89,190. So engagement is basically when you post something, we posted that, and 89,000 people commented on that and talked about that. And reactions is basically what you post on Facebook, and when you guys you start liking it, and you show certain kind of liking towards that. So this number actually says, if 89,190 people talked about it, so 88,314 people actually liked it, which means they noticed it. And this happened through 16 posts. In the end, you can see the total reach, like the entire campaign, we could reach around 82,90,905 people, which is a huge number. And I think that is, I would count it as an incentive of COVID-19. I would say that wouldn't have happened if, had we not taken a leap of faith in social media. That is the strength of social media. And engagement, the total engagement through the entire campaign was 7,83,309. That means, these many people, they talked about the content, the right piece of content that we posted. The reactions being significant, it is 93,974 people. They reacted to our posts, and this happened via 25 posts overall. The duration was of 5 days. It started from 26th of November and was done till 1st of December. So this is the impact that we created through that campaign. These are few of the observations through the entire campaign. So what we found was that videos are the most engaging way, and they generate maximum traffic, be it your website, be it your social media platforms, or whatever, be it Twitter, be it Instagram. So this generates most of the traffic because people view it, they can correlate with it, they can think about it, and it is long, so they like to view it, and that makes all the difference. Second, I would say the video ads. So the video ads that we had played, they performed at 8.5 times of what we had planned, what we had expected. And 9 lakh was the number that we had expected, and we, as I showed you in the previous slide, we reached 78 lakhs through the social media stuff, specifically through video ads. Then I just observed it, and that's actually a learning for me through in NACO and of the entire team. That's a learning that more limited, more impactful, more relevant your content is, more is the reach of your static or video ad. So community specific ad, like the ad which I was about to show you was about was a specific ad about the transgender population, and wherein the person is talking about the safe sexual practices, and is saying that meri suraksha meri zimmedari. That's how the TG was showing how the TG is contributing towards shared responsibility, towards global solidarity. And the video alone drove a traffic of around 33,814 people. Rest, I would say, regular posting, we had put around 5 to 6 posts a day, and that was done through a broad based targeting approach, and that helped us reach 6x 6 times of the targeted reach that we had planned. So getting also on one of our, on one of our posts, we had actually attracted an organic reach of 50,000 people. And when I say organic, it means you have actually attracted a traffic without any sort of money. And that makes a huge difference, which means your piece of content was actually relevant and was liked by people, and it fulfilled the purpose, I would say. So through plays on our video ads, they were at 1.18%, which is at par with the at par excellence with the industry in the digital space. So I would just say, having said this, I would like to say that 0.9% is actually what the industry says. If your campaign is doing well, your through plays, which means if it is a 15 seconds video, if a person is viewing your entire video, and if your through plays are 0.9%, that means your campaign is successful. And we reached 1.18%. So I think that is the learning, that is something that COVID has taught all of us, that no matter whatever the challenges are, we can always, perform if we move in the right direction. So this is something that I wanted to share with all of you. And I would like to thanks all the SACs for, aggressively sharing the piece of content that we had developed. And that's what contributes towards the organic reach. Thank you, everyone. It was a privilege to share this platform with all of you. Thank you.
May I request Koshambi to please come here and have a seat here? Yeah. Thanks a lot, Koshambi, for presenting this. Definitely, when we talk about communication, we have learned that it needs to be hybrid. And we are seeing at this moment in time also that how hybrid structure is really working. At this moment in time, we are having people, those who are sitting in this auditorium, as well as the people, those who have joined and registered for this conference. So this is one way how the communication will continue. Whereas when Koshambi was presenting, three people might have seen that how integration matters, how targeted messaging is really important, and how you can reach to your population. There are certain organic and inorganic approaches which we follow. And you have also seen that organically we have reached to the people, those who matters to us. So judicially, how we have to spend our money, how we have to reach to people, that is a matter of concern, and we have to take care of that. Thanks a lot for this wonderful presentation, Ms. Koshambi Mudkar. Now, when we talk about technology, we have seen, and in the previous session also, we had seen that how tele-counseling was important. So here also we have to keep in mind that whether it's COVID or non-COVID, we cannot have all the services provided 24/7 in terms of hospitals. The services are providing for counseling and testing. Referral services are also there. But yes, there is another dimension where we have to talk about different type of services which need to be provided using technology. And one of them, which AIDS control program is at this moment in time providing, is our services through our helpline, which is 24/7. Now, in this COVID situation, how helpline has actually worked, what type of services were being provided, what will the impact. To talk about all this, I have my colleague from NACO, Mr. Benjamin, who would be talking about that how tele-delivery model has worked in COVID situation. Now, over to you, Mr. Benjamin.
Good evening to all. It's indeed a privilege to stand before you all and to take part in this prestigious conference this evening. I had a short presentation on how NACO has done interventions during this COVID situation to handle the crisis that was faced by PLHIV. So my presentation, the first two slides will speak of what the helpline is all about and what we offer to the helpline. And then I will just speak on interventions that we have made to the helpline during this crisis management. So I would now consider myself the helpline. My goal is to provide comprehensive information related to HIV/AIDS counseling and referral services to different population groups across India. And I broadly offer four categories of services. One is about the information about HIV and AIDS to the populations that require it, and counseling to the people who are exposed to risk of HIV. And I also offer referral service to reach to the service centers like ART centers, ICTCs, etc. And I also provide grievance redressal and the feedback service through which anybody can call on the helpline and register his or her grievance about the service delivery. And I function, being a helpline, I function from 4 different hubs from Hyderabad, Jaipur, Guwahati, and Solan as of now. And coming to the features, we are operational. I am operational 24/7 for 365 days a year. And I have 49 trained and experienced counselors who are placed in these 4 different locations who take care of the calls. And I'm a toll-free number that can be dialed from any mobile or landline across the country. So all the information that you tell me and the details that you give me remain confidential and anonymous throughout the call process. And I can also send you an SMS as and when as per your need about the details of the service facilities and etc. And through the helpline, I provide counseling services in 15 regional languages as on date. So I would also like to just go through a short journey of how we have started our journey in way back in 2014. The helpline was launched and with 6 languages and 20 counselors. Later, the grievance redressal mechanism was incorporated. Later, the language additions took place and the calls were analyzed, and we thought that one of the reason that could be hindering our call volume is the language selection IVRS, which was later removed, and the call volume has improved. And later we had other plans to integrate with the self-verified adherence model to increase the ART adherence. And we also have other interventions that are planned ahead. So now we're coming to the COVID situation. We have faced a number of situations during the crisis that has suddenly come across all of us. When the nationwide lockdown was announced in March, all of a sudden we are not able to move anywhere. The same as the counselors who are there at the helpline hubs, they were not able to move anywhere. So NACO has intervened. NACO has taken support of the development partners. We have arranged logistics. We have arranged their accommodation. We have ensured that the software application is properly tweaked, and so that the calls, anybody who called on 1097, their calls will land in the counselor's personal mobile numbers, so that the calls can be answered from wherever the counselor is sitting during the lockdown situation. And then there were a number of calls and number of issues that were raised during this situation, and I'll speak about it in the next slide. So this is about the categorization that we had on the helpline during this prime months of lockdown period. We can initially see that the number of calls during March, April and May are very high. Later, when the government interventions have started particularly for COVID, so we started receiving less number of calls. So on the helpline on 1097, we gave basic information about COVID, the myths and the misconceptions and the basic risks associated and the basic things that has to be followed. We have given that information to the helpline, and we have diverted such callers to call on national helpline for COVID, dedicated helpline for COVID. Later, these are the types of calls that we have received during this particular period. We would call it a period of crisis, where there were a lot of distress callers who reached out to the helpline who would be requiring psychosocial support. And we have callers about who are not able to reach the ART centers, the PLHIV, who are not able to reach the ART centers due to the lockdown. Many have reached out to the helpline to ask for travel passes. And we have also coordinated door delivery of ART through our networks or partner organizations through our state AIDS control societies. And we have also coordinated the linkage of social protection schemes. During this time, many PLHIV were not able to get access to basic amenities. So such people are mapped and are linked to the social protection schemes at the state level through the helpline. And we have also received some of the stigma calls related to stigma and discrimination that was faced during this time by PLHIV communities, where we have provided kind of psychosocial support to them through interpersonal counseling. So here are some of our interventions. Through our interventions, what are these impacts that we could make and what is the outcome? I would like to just share that we had increase in the overall call volume that is recorded on the helpline. We have coordinated door delivery of ART to the people who are not able to reach the ART centers to collect their ART due to this COVID situation. And we have reached out, not only the helpline initially had only the incoming calls, but during this COVID situation, we are able to initiate outbound calling, through which we are able to reach out to the people and also ask them to maintain adherence to ART. And we have also tackled some emergency situations like a pregnant woman a positive pregnant woman who's going regularly to a particular center, if all of a sudden that center has been dedicated as a COVID care center, so she was denied entry into such hospitals. So through helpline, we have coordinated with the state offices and the partner organizations, and then we have ensured that she is linked with some other hospital in her vicinity, so that she is provided with proper treatment and necessary support for her safe delivery. And we also have coordinated the grievance redressal services that we have through the helpline. And during this time, there are a lot of people who have registered grievances, and we have redressed them within stipulated time period by coordination with the national office, as well as state offices and the partner organizations. And we have also linked the PLHIV clients to link ART centers, which are there. Many of the ART centers who are linked to major hospitals were closed as after they are designated as COVID centers. In this time, we have also coordinated and ensured that the PLHIV is given ART through a link ART center. The details of these link ART centers are shared through SMS to the clients who needed them. In additional guidance, we would here like to appreciate and thank our state officers who have been constantly in touch with us for getting in touch with the PLHIV clients who are in need of treatment. We are able to reach out to them. And at national level, as well as at the state level, we have ensured that enough of information is given out about helpline, so that people who are in need of the ART treatment, especially the PLHIV and the high-risk group communities, would reach out to the helpline so that their needs can be taken care of. This is just a screenshot of the social media post that we have done during that time. And it has a wider reach, and after which we have started receiving a lot of calls on the helpline about this. And SACS, the state AIDS control societies, have supported us in terms of promoting the helpline through bulk SMS campaigns, radio spots in local FM channels, video spots and TV channels, and through social media. And even we have the NACO has also given liberty to states to deal with this particular crisis situation. Like in such a case, I would like to state the ART Mitra initiative that was taken by MDAX is commendable. So not only at the national level, but the states have also taken enough cognizance of this situation. So we have, to tackle the situation more well and more effectively, we have built the capacities of our counselors who are based at our 4 regional hubs. In collaboration with NIMHANS on mental health issues. We have received a lot of calls pertaining to stress, anxiety, and depression that was caused due to this sudden lockdown that was imposed due to COVID. And a lot of PLHIV clients were not able to do anything about their access to basic amenities. To effectively deal with such kind of clients, we have built the capacities of our counselors. And we have also collaborated with UNICEF for development of a complete toolkit on stigma and discrimination, how the issues can be addressed better in a better way through the helpline. So at this point, I would like to just share a success story that we have intervened to the helpline. The situation was, there was a positive mother who had to give birth at home during lockdown due to non-availability of transport, and in such a situation she doesn't had access to the nevirapine syrup that was required for the baby. And she is a mother. Since she is a positive mother, she is taking treatment from an ART center. And later, the intervention through helpline was that the counselor has listened to her queries properly, and then he has ensured of proper help to her. Later, she was linked to the another center through the development partners, and ultimately they are very happy that since the person was able to reach the helpline and call the helpline, they were able to get access to the syrup, and their baby was fine and they are doing great. So at the end, I would just like to quote this: never given, never, never, never. So irrespective of the situations that we have faced, I hope we are able to manage the national help, the program in dealing with this crisis faced by everyone, and particularly the PLHIV community. Thank you all for this opportunity.
Benjamin, may I request you to please take your seat here on the dais? Benjamin, if you can come up. It was definitely a nice presentation, and we have seen that how helpline has worked actually not only to deliver or not only to provide counseling and services to the people, those who are calling during the lockdown. In addition, how the ART services were also being provided. Then the mental health issues which were being handled through helpline also, those were really, really commendable. And the success stories are not limited to one. There are a lot of success stories which we have come across and which we always get to know. But this is how the integration is to be done and how we have to use the technology for the betterment of our communication activities. Thanks a lot for this presentation, Mr. Benjamin. Now, another example where we have used the technology so that we could engage our youth, we could bring them to the discussion again, we can have at the national level, but people, those who are at the ground root level, those people can also be part of the program. So this youth force and youth engagement, how important it is and how it was been done. So for this, I would like Ms. Parul as well as Ms. Sonal Walia, who will be joining us through online. So both of them would be talking about how the quiz competition was undertaken by NACO through the involvement of each and everyone, those who are part of this initiative at the field level, state level, as well as the district level. And I would like to give a good, warm, and very thankful gratitude to all of them so that they are also being recognized at this moment when this is being presented. Thanks a lot for all that. And now I'll request Ms. Parul as well as Sonal to take us through this initiative. Over to you, Ms. Parul and Sonal.
Thank you, sir. Good afternoon, everyone. I'm Parul. I'm going to present, as the sir said, how we use this technology to empowering the youth. So if we talk about the youth and the HIV scenario, basically, so like what we think, if we अगर हम HIV की बात करते हैं तो हम यूथ को उससे अलग नहीं रख सकते। यूथ हमारे देश में एक बहुत बड़ा पॉपुलेशन है और जो कि एक बहुत इम्पोर्टेंट रोल प्ले करता है। और अगर हम यूथ की बात करें तो यूथ से बात करने के लिए, यूथ को अपने साथ इन्वॉल्व करने के लिए, इस टॉपिक में यूथ को इन्वॉल्व करने के लिए हमें कुछ इनोवेटिव वेज ढूंढने पड़ेंगे और तभी वो हमारे साथ इस मुद्दे पे बात करने के लिए और सामने आएंगे बेसिकली। तो एक आइडिया हम सभी के दिमाग में था, नेशनल लेवल पे एक आइडिया था कि हम किस तरह, हम रेगुलर एक्टिविटीज तो यूथ के साथ करते रहते हैं, एक ऑनगोइंग रेगुलर एक्टिविटीज होती रहती हैं जिसमें वो HIV के बारे में बात करते हैं और एक्टिविटीज भी करते हैं, लेकिन कुछ इनोवेटिव तरीके से हम कैसे कर सकते हैं। तो हमने सोचा कि हम एक क्विज कंपटीशन ऑर्गेनाइज करेंगे। हमने सोचा था कि हम फिजिकल मोड में इस क्विज कंपटीशन को ऑर्गेनाइज करेंगे, पर जब ये प्लान था फिजिकल मोड में करने का तब कोविड नहीं था हमारी लाइफ में, और जब हमने इसको प्लान किया कि हम ठीक है इस साल हम इसको फिजिकल मोड में करेंगे तो कोविड आ गया। अब कोविड आ गया तो वी वर ऑल सिटिंग टुगेदर एंड वी वर थिंकिंग कि अब इसको हम किस तरह से कर सकते हैं। तो फिर हमने नेशनल लेवल पे टीम ने आपस में बात करी, हमने स्टेट्स की टीम से आपस में बात करी और उसके बाद हमने ये डिसाइड किया कि हम इसको एक क्विज कंपटीशन हम कर सकते हैं और इसको हम बेसिकली ऑनलाइन मोड में, वर्चुअल मोड में करेंगे। तो बेसिकली उससे पहले मैं थोड़ा सा RRCs के बारे में आपको बताना चाहूंगी। इफ यू टॉक अबाउट द RRCs, एज यू कैन सी इन दिस मैप, लाइक इस मैप में अगर आप देखते हैं तो हमने ऑल ओवर अगर देखा जाए तो हमने अपने देश का हर हिस्सा कवर किया हुआ है RRCs के साथ, और इसमें हमने यूथ को इन्वॉल्व किया गया है, कॉलेज गोइंग यूथ को हमने इन्वॉल्व किया है जिसका एज ग्रुप है 17 to 24, और अभी तक हमने मोर देन 12,000 RRCs को इन्वॉल्व किया हुआ है। अगर हम इन RRCs को देखें और अगर इनके नंबर्स को हम मल्टीप्लाई करें तो आप ये सोच सकते हैं कि हम किस लेवल तक यूथ के साथ इंटरैक्ट कर रहे हैं। एक बहुत बड़ा ग्रुप है जो इस RRC रेड रिबन क्लब्स के साथ जुड़ा हुआ है और जिसके साथ हम इंटरैक्ट करते हैं। सॉरी, तो जो हम क्विज कंपटीशन की, रेड रिबन क्विज कंपटीशन की हम बात कर रहे थे, क्या ऑब्जेक्टिव था इस रेड रिबन क्विज कंपटीशन को ऑर्गेनाइज करने का? बेसिकली यूथ एंगेजमेंट, यूथ एंगेजमेंट एक इनोवेटिव तरीके से करना सबसे बड़ा ऑब्जेक्टिव था इस क्विज कंपटीशन को ऑर्गेनाइज करने का। फॉर श्योर HIV एड्स को नॉर्मलाइज करना, HIV एड्स की बातचीत को नॉर्मलाइज करना, इस टॉपिक को नॉर्मलाइज करना और रीच को बढ़ाना। वो टाइम जब कोविड के टाइम पे स्टूडेंट ऑनलाइन क्लासेस कर रहे हैं, हम लोग बाहर नहीं निकल पा रहे हैं, उसके बाद भी रिस्ट्रिक्शंस हैं, लोग बाहर जाना पसंद नहीं कर रहे हैं, उस टाइम पे हम मैक्सिमम ज्यादा से ज्यादा किस तरह से यूथ को रीच आउट कर सकते हैं, तो हमने ये एक वर्चुअल तरीका ढूंढा। आई वुड लाइक टू टेल कि ये पहला एक ऐसा ऑनलाइन मोड था इतना बड़े लेवल पे क्विज कंपटीशन, इससे पहले किसी ने ऑर्गेनाइज नहीं किया था। ये पहली बार ऐसा हुआ है कि इतने बड़े लेवल पे कोई ऑनलाइन लाइव क्विज कंपटीशन ऑर्गेनाइज किया गया। कंपटीशन के अलग अलग लेवल्स थे, अलग अलग लेवल्स पे इस कंपटीशन को ऑर्गेनाइज किया गया ताकि हम सारे ही रेड रिबन क्लब से हमारे जितने भी यूथ जुड़े हुए हैं उन सबको हम इसमें इन्वॉल्व कर सकें। तो हमने डिस्ट्रिक्ट लेवल पे ऑर्गेनाइज किए क्विज कंपटीशन जिसमें मोर देन 5000 कॉलेजेस ने पार्टिसिपेट किया। उसके बाद डिस्ट्रिक्ट लेवल से टीम स्टेट लेवल पे आई जिसमें से मोर देन 500 डिस्ट्रिक्ट्स ने पार्टिसिपेट किया और उसके बाद एक रीजनल लेवल हुआ जिसमें 33 स्टेट्स ने पार्टिसिपेट किया और उसके बाद ग्रैंड फिनाले में 4 रीजन से, हर रीजन से एक एक टीम ने इस क्विज कंपटीशन में पार्टिसिपेट किया। और जो हमारा टारगेट था, टारगेट ग्रुप जो हमारा था वो हमारा कॉलेज गोइंग यूथ था जिसका एज 17 से 24 साल के बीच में था। स्टेट एंगेजमेंट की बात करें अगर हम, तो ये क्विज कंपटीशन स्टेट के सपोर्ट और उनके एंगेजमेंट्स के बिना बिल्कुल भी इम्पॉसिबल था। स्टेट्स ने हमें बहुत ज्यादा सपोर्ट किया इस क्विज कंपटीशन को ऑर्गेनाइज करने के लिए। इस टाइम पे जबकि काफी डिफिकल्टीज हो रही थी ऑनलाइन मोड में इसको करना, क्वेश्चन एयर्स को डेवलप करना, स्टूडेंट्स को पार्टिसिपेट कराना, नेशनल लेवल क्विज कंपटीशन में स्टूडेंट्स को लेकर के आना, उनकी सेफ्टी एंड सिक्योरिटीज को ध्यान में रखना, एक प्रॉपर क्विज कंपटीशन बिल्कुल जो भी बायस्ड ना हो उसको ऑर्गेनाइज कराना, मीडिया का कवरेज कराना, उसको इस कंपटीशन में जो यूथ को तो हम इन्वॉल्व कर ही रहे हैं, उनको तो हम एजुकेट कर ही रहे हैं और उसके साथ साथ मीडिया में अब उस क्विज कंपटीशन की पब्लिसिटी करके, सोशल मीडिया में उसकी पब्लिसिटी कर करके एक बड़े मास को इन्वॉल्व करना। तो आई वुड लाइक टू थैंक स्टेट्स कि उनका बहुत बड़ा हाथ है इस पूरे इवेंट को सक्सेसफुल करने में। ऑडियंस एंगेजमेंट की बात करें तो जब हमने नेशनल लेवल पे इस क्विज कंपटीशन को किया तो हमने एक ऑडियंस एंगेजमेंट भी रखा, उसमें हमने ऑडियंस क्वेश्चंस को रखा था और उन ऑडियंस क्वेश्चंस में हमें पूरे पैन इंडिया से रिस्पॉन्सेज आए थे और हर क्वेश्चन पे हमें मोर देन 1000 रिस्पॉन्सेज हमें रिसीव हुए थे। तो अगर हम बात करें तो हम ये क्विज कंपटीशन सिर्फ यूथ के लिए ही नहीं था, उसमें हमने एक तरीका निकाला कि हम ऑडियंस को किस तरह से इन्वॉल्व कर सकते हैं। उसके अलावा सोशल मीडिया के थ्रू भी हमने ऑडियंस को इन्वॉल्व किया, यूट्यूब पे, ट्विटर पे भी हमारे एडवर्टीजमेंट्स जा रहे थे और ये क्विज कंपटीशन लाइव दिखाया जा रहा था, फेसबुक पे भी लाइव था, तो उसके थ्रू हमने अपने ऑडियंस को इन्वॉल्व किया इसमें। From this slide, I would like to call my colleague Sonal Walia to take this presentation forward. Sonal, are you there?
Thank you, Parul. Am I audible?
Yes, you are.
Thank you so much. As you all, good evening, everyone. This is Sonal Walia from IC Division, NACO. I am virtually present here. I have beautiful memories of Aidscon 9, where we were physically present and we spoke about, how eventful we did our multimedia campaign. And this year, we also came up with a beautiful program of Red Ribbon Quiz Competition, first time initiated. And as my colleague Parul has ran through you the journey, how we came across, we initiated, we nurtured this idea, and we went through to the grand finale level. So talking about the highest level advocacy. So advocacy at topmost level is very pertinent because it gives you food for the thought. And in this, we were able to rope in our health minister, Dr. Harshvardhan, and and Mr. Ashwini Kumar Chaubeji, Minister of States, who were present during the event, the grand finale, and they spoke about how youth are important in talking about HIV and AIDS, and mitigating the idea of the adverse effects of HIV among the youth. So learning from peers is very important. This is what he talked about. So when we talked about this, our youth were definitely engaged and they were highly motivated. He also facilitated the winners, and of course, his gracious presence was very, very important. Next slide, please. So talking about the winning teams, as she has already mentioned, that we had four regions participating at the finale. We had Assam team winning it. And of course, everyone is the winner. We'll not differentiate among who is not the winner. Every participant who participated from the college level to the grand finale is of course a winner, for us at least. And the Assam team beautifully won the event and was gracious enough to be present. Next slide, please. So talking about the digital reach, my other colleague, Ms. Mudgal, has explained about the virtual presence of virtual arena. So talking about the digital reach, the previous slide, yes. So we had, when we conducted these regional events and of course the national grand finale, we conducted it virtually, of course, through an online mode. We had our presence on microsites. We asked our state AIDS control societies to share it, maximize, so that we could trigger down the reach to the grassroots level, of course, to the college level, to the college youth, and to our ICTC counselors, to each and every person possible. We also greatly use the use of Twitter handles, YouTube channels, and of course, our Facebook pages. So in totality, I would say that more than 90,000 to almost 1 lakh we reached through our digital platforms. Next slide, please. So talking about the way forward, how we nurtured this idea and we took it forward, talking about the HIV and AIDS throughout this competition. We had questionnaires for everyone. So we have to take it a step forward, of course. So how we have to take this? A meaningful engagement through inter-district quiz competitions. Our colleges, our Red Ribbon clubs who are present across the country, we can definitely take our coverage in the high prevalent districts and conduct inter-district quiz competitions. And this will, of course, if not physically, if we do it through an online mode, how we are interacting today, it will definitely empower our youth. They will talk about HIV and AIDS, and of course, it will lead mitigating the stigma and discrimination involved around it. So this is the way forward which we want to have through our quiz competitions. And of course, we'll have many more quiz competitions coming up in next few, I'm sure in next financial year, of course.
Thank you, Sonal. So much. So as Sonal said, there are more quiz competition coming in next financial year. So I would like to thank everyone for and closing this presentation. Thank you.
Thank you, Ms. Parul and Sonal. So we have also seen how hybrid we were presenting here physically as well as through NACO. To my request, Parul to please come and have the chair on dais. Sonal, sorry, you are there, so I cannot request you to come here. That's it, but virtually you are present. So you have seen that how youth engagement is really important and how we can reach specifically using the different interventions, which was totally new in its own way. So, these three presentations have shown that how digital platform, how online platform are really important when we talk about communication or when we talk about new interventions. So another dimension of the program is that we have to present social protection schemes, because we quite often talk about 1990, 95, 95, 95, but today when ASMM was inaugurating it, she was more about 100, 100, 100. So we'll have to make it sure that we go for the next 100 also, which is extending social protection schemes to the people, those who are in need, because we understand the population is really marginalized and they wouldn't be needing. And in situation like COVID, we have also seen that how interventions where the people, those who are stuck in lockdown, or the people, those who could not have their livelihood, how these social protection schemes are really important. And in one of the presentations, Nandini from UNAIDS also talked about that how Global Fund was involved in extending free ration and dry ration to the people, those who were stuck in lockdown. So how these social protection schemes are important, and what National AIDS Control Program is doing, and in COVID situation, what has been done specifically by states as well as the national level. We have our next presentation to my colleague from NACO, Mr. Ashish Verma. I'll request him to have this presentation so that we can tell the audiences, so that people are made aware that how we are extending global services. So over to you, Ashish.
Good evening, everybody. And I would request our organizing committee to kindly run my PPT. I've already shared my PPT. Yeah. So it's my pleasure to participate virtually in this very important meeting, Aidscon 10. And this is such an important topic, and thank you, Dr. Rajesh, for setting the tone. And we understand the importance of social protections and how the social protections is important in the COVID scenario. So my presentations is basically a reflections of activities that all carried out by the NACO, state AIDS control societies, various partner organizations in collaborations with SACs and DAPQs. I precisely touch upon the guiding principle, what are the guiding principle, the need of the social protections, approach and strategies that worked well, and what are the key achievements and way forwards. So talking to the guiding principles, we understand the importance of the social protections. And if we understand, our effort is to make HIV inclusive and HIV exclusive social protections for marginalized communities, people infected and affected by HIVs and HRG communities. Here, if we refer this document, strategic document of NACP4 of Government of India, it is clearly spelled out the ensuring social protections scheme for people infected and affected with HIV and AIDS through mainstreaming of HIV AIDS with the various ministries and departments at all levels. Next, please. We understand the importance of social protections. No need to talk about why social protections is required. It is already spoken a lot since the morning. But one we think, that the social protections is extremely important in order to mitigate the impact of HIV among individual, then household, and to the communities by and large. So social protections, we understand it has adverse impact on the most productive segment of the societies, as people are infected in their age of prime years. And of course, it is very evident that HIV causes reduced family income and increased medical expenses. When during the COVID time, this time was very critical, and we understand where the restrictions were imposed, where the travels are not allowed, and there were the cases of loss of livelihood, loss of income, and it was the actual barrier to earn livelihood and access to the services. In that time, there was a lot of apprehensions by the communities to access the services, and of course, how they can access the social protections. And meanwhile, a landmark directions came from Honorable Supreme Court of India, and it is fairly directed to state and union territories to ensure supply of dry rations and dry rations to sex workers. And then onwards, we have started discussing, strategizing action plan, how things are possible, whatever is directed by the Supreme Court of India. Next, please. So there are the several strategies and the several approaches that worked well. I must say, the few things what we have initiated that yield result and worked well in order to strategize social protections. So there were the several strategies, there were the several approaches. The topmost priorities is, of course, the social protections were started discussing during the COVID lockdown times. And there was a series of directives and letters were sent by the NACO to state AIDS control societies with regard how the SACs can collaborate with the various departments in order to ensure, if I may talk about one examples of nutritional support there was a letter from NACO to state like how SACS can further coordinate with the Department of Food and Civil Supply. So the food grains may be delivered in the nearest possible points where the PLHIVs or key populations are residing. Because that time travel was not allowed, PLHIV or the beneficiaries was not having that liberty to go to the particular shop and get the ration under the provided by the government, state government. So these kind of the letters were sent from the NACO to state. And beside this, it was also efforts made, and the letters were sent from NACO to concerned ministries like Department of Social Justice and Empowerment, Government of India. And the possibilities were explored, like how the key populations like MSM, FSW, IDUs can be included in the existing social protection schemes provided by the ministries, various social ministries. So these are the directives, and the letters were sent, and then the process initiated to engage various stakeholders, various partners, like how to make things possible for the actual uptake of social protections at the field level. Next, please. So after these letters, the another strategy was like advocacy and meetings were organized at all possible level. A series of virtual meetings were conducted by NACO, and the virtual meetings was fairly conducted almost on every month from May, July, August, and there was a proper follow-up. There was a proper discussions between NACO and SACS with regard to the progress, with regard to the action plan, and with regard to the activities carried out at the field level. And there was advocacy for inclusions of PLHIVs and HRGs. We understand, the things are established. I mean, there are the several schemes in place. Directives were issued by the state government for as a social protections for key populations, people infected and affected by HIV. But somehow HRG is a gray area. If we may refer what all schemes are available, we have the various examples for the social protection schemes for people infected and affected. But while HRGs, we need to advocate with the department concerned, like how the HRGs can be included as one of the beneficiaries of those existing schemes. Next, please. Yes, and then after issued letters from NACO, after virtual meeting, the another important strategies we have adopted was we have shared the guidance note on social protections during COVID-19. This guidance note basically provides guidance like how the SACS need to work on social protections during this COVID-19 pandemic, especially with regard to the planning strategies, how the SACS may engage various stakeholders, and how the SACS can actually implement social protections initiative without much delay. And that was also, the checklist was there, that suggested timeline was there. So these guidelines, and subsequently a letter was again sent by the NACO to SACS. And it is a process of the continued advocacy, both at the NACO level, both at the SACS level. So the initiatives were taken by mostly State AIDS Control Society in order to collaborate with the various line departments at the state level. Next. Another very important area, though the guidance was there, though the letter was sent, though the directions came from the Honorable Supreme Court of India, but actually to expedite the process of engagement, emphasis was given on the engagement of the various stakeholders. Efforts made to engage various departments, NGOs, CBOs, networks, and on the pilot basis, beside these departments and NGOs, even the several bilateral and multilateral organizations were engaged. Even on the pilot basis, UNDP was engaged, and the pilot initiatives were taken place in the 6 high priority selected region in the 6 high priority districts in India. Besides this, there were the efforts made under the various partner organizations through regular programmatic interventions like VIHAN, like Project Accelerate, and they are doing commendable work on demand generations, on enrollment, and access of benefits by the key populations. Besides this, the corporate and industries were mobilized. All the bigger industries, public or private sectors, corporate houses, they are engaged, and the social protections benefits are provided to the key populations. Next. Another important strategy is somehow it is very important to the mapping of HIV inclusive and exclusive schemes. Though the compendiums are developed by the NACO, though various letters, whatever is issued by the state government is there in the public domain, but it is also important to relook our own strategy, relook the compendium. If something is missing, it is important to, like, up to date the directories, include all the advisories, and this booklet is actually working. I mean, it's found very useful by the SACS, and it is considered as a reference document, because tomorrow when we are talking about the minimum package of the social protections, at least this booklet is referred by the SACS in order, if something is missing, something is not there in the state, how the SACS may advocate with the department concerns in order to provisions social protections schemes for both PHIVs and HRGs communities. The another strategies is, like, we also try to develop a matrix of the possible social protections schemes, what all is there with the various ministries of Government of India or the state government. This matrix is basically provide guidelines which are about the particular schemes. What are the small brief related to particular schemes? What are the eligibility criteria? Whether the PLHIVs or HRGs are included in the particular schemes, and what are the source. So we are still in this exercise, and very soon we will complete this matrix. And once it is complete, I think this is again a wonderful, the document which may useful and which may referred by the various SACs or DAPQs with regard to uptake of social protections. Next, please. So out of this entire strategy, we do have the various key results and achievements. So field level activities were carried out. Almost activities are done in all states and union territories, almost in all possible districts. There were the process of engagement of the various line department at the district level, and there is a sharp enhancement and uptake on the social protections schemes in the area of nutrition, in the area of getting dry rations, in the area of getting masks, financial assistance, and the other major social protection schemes to the key populations. And industries and the various industries, they have also, extend social protections benefit as per their corporate social responsibilities. Next. And based on the report received from the state, I must say the dry rations, nutritional support is there in almost in all states and UTs. If you may talk about the financial assistance, even the PLHIVs are getting financial assistance well in advance for the next couple of months. Even the financial assistance disbursed in the state of Andhra Pradesh, Delhi, and Bihar, there were the social protections uptake by the teaching communities, and even the groceries were distributed in various places through corporate and public sectors undertakings. And for example, the food products were given to all HRGs by Indigo in West Bengal. So, in totality, there are the several uptake, and social protections uptake moved well in almost in all corners of this country. Next. So these are the glimpses of the activities carried out on the social protections. So we can see there were the distributions of the rations and the other social protection schemes to the beneficiaries. Next. This is just for the information, like when we are talking about the HIV inclusive and HIV exclusive social protection scheme, these schemes are available in the various part of the country. For example, the free transport is there, widow pensions, Antodaya Ann Yojana, nutritional support people are getting in many places, insurance benefits are there. Even the PLHIVs are considered as a BPL in some of the states. Next, please. So financial assistance is there in Delhi, Bihar, Daman and Diu. And there are the many, besides these states, there are the many states where the financial assistance are disbursed to the PLHIVs. And there are the schemes for children affected by AIDS, OVCs, and the others priorities group. Next, please. Can we move to the next slide, please? So as a conclusions and way forward, I think one thing I must say, the entire strategy of social protections is required continued advocacy. Though schemes are there for people infected and affected by HIV, the similar efforts need to be made for the social protections schemes for people, those who are in high risk group. Coordinate with the line departments are extremely important. Interdepartmental meeting of the joint working groups are useful in order to garner support from the various departments at the state level, at the district level, and the entire strategy needs collaborative efforts. It is not only responsibility of NACO, it is not the only responsibility of SACS or DAPQ, but everyone can contribute in the very important area of work of social protections under National AIDS Control Programs. As a way forward, the linkages need to be developed for more and more social protection schemes. Activities need to be defined for the demand generations, demand aggregations, and there should be a proper consolidated efforts for the actual uptake of social protections, both for enrollment and access of benefits by the key populations. Next. Thank you very much. Again, I must say, small changes can lead to a big impact if we work together. Thank you very much.
Thanks a lot, Ashish, for making us to run through all those schemes which have been extended to people during this COVID situation. Also, the other schemes which are available for HRGs as well as PLHIV under AIDS control program. And we extend our thanks to all the line departments also, those who have actually tweaked their schemes so that these can be extended to PLHIV. Thanks a lot. And I, again, thanks the entire team, those who have actually presented during this session. So with these things, I conclude this session and hand over the session for the next proceedings to Ms. Tinu Khanna. Over to you, Tinu. Thank you.
Very much, sir. Now I request our project director, Dr. Vinita Gupta, to please hand over a memento to our chair, Dr. Rajesh Rana, National Consultant, NACO. Thank you very much, sir, for all your support and guidance.
Thank you, ma'am. Thanks a lot for giving this opportunity.
To our speakers, Ms. Modgil, Mr. Benjamin, Ms. Parul.
Lovely presentation. Really, very well. I was so impressed.
It was a privilege to be here, truly.
Really, really nice.
And such warmth.
Especially memoir from Chandigarh. For you to put in that, please. Oh. I know you've been to Chandigarh.
Yes, that's wonderful.
Many times.
Yes.
Yeah. That was really, very informative. Very, very
I request Mr. Vishal Acharya to please come up on the stage because we would like to thank him also. He's there with us. He's always been a great support. I request Benjamin to please take the memento for Mr. Ashish Verma, who was there with us virtually.
Okay.
It's Parul to take the memento for Ms. Sonal. And Ms. Garima also. One for Ms. Garima.
Ma'am, Dr. Gupta had presented about this act. That's why we skipped the presentation on the act, because we could not do better justice to the act what he has done. That's why.
So I guess you could have heard that.
Yes.
So this is on okay.
So one memento for Dr. B.C. Gupta. I request ma'am to please take the memento because he was there in the session, ma'am. It was a suggestion of Dr. Rajesh. Yes. So please. Dr. Rajesh to please take the memento for Rajesh, who has always been a great support. He was there with us in the morning in the inaugural session. I request Dr. Rajesh to please take over his memento. Not to miss out the pillar of IEC, Dr. Naresh Goyal. He has always been a very big support. Whenever we call him for something, he always says, yes, you can do it. Go ahead with it. So kindly, Dr. Rajesh, take his memento on. All our regards to him. Thank you very much. With this, we come to the end of day one. Thank you, everyone. We'll have one group photograph. Even I would like to join.